Hi, Dr. Mansi. Welcome, Dr. Radhakrishnan.
Hi. Is it going on time?
Dr. Nitesh, you're in the wrong hall. You have to go to the other hall. Hall A, please.
This is the correct hall, right? For the debate.
Yeah, Dr. Geeta, yes.
Where's Satyendra?
I don't know. Let me call him and see where he is. Let me find out.
Okay. Hi, Dr. Raman.
So Dr. Satyendra is joining.
Tech team, can you just promote somebody in the attendee and Dr. Mansi? Then I think you can start. Dr. Raman is here. Hi, Dr. Raman, sir.
Hi, Ji, good afternoon.
Hi, sir. Thank you. Thank you for joining in. I hope we are not keeping you away from a very important meeting. We'll let you free by 4:30. That's for sure.
That depends on Dr. Satyendra.
Oh, is that so?
Yeah. Well, it's a debate, so I don't know how long it's going to take, but yes, it depends on the second speaker.
No. If the debate is spicy, I'm sure even Dr. Ramandeep would want to go. So that is why I'm not concerned. I'm just concerned that he joins in. There's somebody joined in that attendee. Can we please promote them? And I think Dr. Mansi, should we start? Dr. Satyendra, you
Yeah,
have spoken to him, na? He will join in some time, right?
yeah. He just said I'm joining. So
Okay. Okay. So
let's
now we
start.
have 2 attendees. So I'm sure one of them is Dr. Satyendra.
Yes.
So
So, hi everybody. Good afternoon or good evening. Welcome to day 2 of the 4th annual conference of Oncology Forum. And today is an exciting day because we are actually starting with our debates. And without wasting any time, I'm going to introduce the chairperson for today, and it is none other than Dr. Ramandeep Singh Arora. I don't think Dr. Raman needs any introduction whatsoever. He's a very well-known personality in our pediatric oncology fraternity. He is the associate director, pediatric oncologist at Max Hospital, Saket. So over to you, Dr. Raman.
Hi, good afternoon. I hope you can all hear me.
very well, sir. Very well, sir. Can you have the next slide where the topic is there, please? Yes, thank you.
Thank you. So thank you to Oncology Forum, which has over the years grown leaps and bounds. And this is another of their achievements, the annual conference which they are holding. And thank you also for giving pediatric oncology the space, because I know Oncology Forum prides itself on giving representation to all the specialties within oncology. And so from that point of view, we have today a very useful debate. And I'm intrigued as to what the speakers will say, because I myself am completely at an equipoise right now as to what to use. So if they can influence me, then I would be happy to award that debate to that speaker. Also, it is my pleasure to introduce the two speakers. Dr. Neeta Radhakrishnan, who is a pediatric oncologist trained in Gangaram Hospital and now a consultant at super specialty pediatric hospital in Noida, and who is also a great friend. And Dr. Satyendra Kateva, who is a consultant pediatric hematologist, oncologist, and transplant specialist at Manipal Hospital in Jaipur, and also has his roots in Gangaram Hospital, as do many of the colleagues we know. So welcome to both of them. The topic today we are looking at is Philadelphia positive ALL. And we all know that there has been a tremendous improvement in the outcomes of this from the tyrosine kinase inhibitors, with imatinib being the flagship TKI, which was used in CML and then in Philadelphia positive ALL. But now with other generation TKIs available, there is debate as to whether imatinib still holds fort or whether the new TKIs give an advantage. And so both the speakers would be taking one side each. And I would like to invite Neeta to please set the ball rolling. Thank you.
Thank you, Dr. Raman. Thank you to the organizers for this invitation. And I've been asked to speak for first generation TKI in pediatric pH positive ALL. So pediatric pH positive ALL, as you know, would be around 3 to 5% of pediatric ALLs, and it continues to be a high risk subgroup, a very high risk subgroup. So when we did not have TKI, that was like around 20 years back, the data would show that we had survival, the expected survival in this cohort of patients was just about 20-30%. And if you had patients who are older, this is as per the NCI Rome criteria. So if you're older patients and high white cell count, your survival is actually 20% or less. And in this group of patients, in those times, prophylactic cranial RT was given for all, and allogenic HSCT in CR1 was advised. Then came like science fiction, then came TKIs, targeted therapy, and we have had multiple better versions of which have come out recently. So now in 2009, this was one of the highlights of SIOP Brazil, that they discussed that if you are treating with imatinib and on a traditional chemotherapy backbone, these children may not require any transplant and their survival would be as good as the other children as well. So this was 80% 3-year EFS, which was shown by COG, when you are giving continuous imatinib at 340 mg per meter square. Landmark paper, they said that imatinib is safe along with chemo, and imatinib, of course, is much better than the historical controls. And in this group of patients, in their cohort 5 group, I'll describe what was cohort 5. In cohort 5 especially, they showed that it may be even better than transplant, either whichever donor transplant you, this chemotherapy only arm might be equal or slightly better. What was cohort 5? Cohort 5 was just simple continuous dosing of imatinib. And we all know how challenging it is to continuously dose imatinib on a high risk or an intensive chemotherapy backbone. So without any breaks, if you are able to dose imatinib, which is cohort 5, and their cohort 3 and 4 were imatinib at 3 weekly cycles with small breaks in between. And the 3 had actually a 9 to 10 week gap at 2 times as well. So when you give this kind of treatment as cohort 5, you actually even override MRD. Your MRD response, even if your MRD is more than 0.01%, your still outcomes are as good as 70-80%, which was fantastic. But if you give breaks in the treatment, then of course, if you're MRD negative, it is all well. Otherwise, it is going to be worse. If you're MRD positive, this is time point 1 MRD, it is going to be bad. So then we wondered, like any new treatment which came in the market, whether this response will sustain. So 5 years later, the same group published their follow-up data, which showed us that it is exactly the same. The response continued even 5 years later, and the response was similar in chemotherapy plus imatinib versus transplant patients as well. So it continues, it's a sustained response that we are getting. What about the European data? Again, similar data that if you're giving a high or an intensive high-risk chemotherapy backbone, on top of that, if you're dosing imatinib continuously, these children are going to have upwards of 80% survival. And this is the chemotherapy that they used, the BFM 95 backbone. Again, high-risk arm of that. On that, you have to give imatinib. So the bottom line in both these trials, which came out at the same time, was that if you have an intensive backbone and on top of that, you're giving imatinib, the response is as good as around 75-80% survival is something which we can expect. So in this setting, is there any benefit of thinking about a second generation TKI? Of course, there is benefit of second generation TKI because there is resistance to imatinib. We have seen resistance come up in patients who relapse, pH positive ALLs which relapse. Around 80% of those who relapse will have resistance. And when they relapse, their outcome is going to be dismally poor. So the question is, if we do something upfront, if we increase our treatment upfront, will it reduce relapses further? So that is what I think we are discussing today. And in those relapses, one more point I wanted to show that some among the relapses, some of them are relapses which are not going to be responsive to your second generation TKI as well. So of course, newer TKI, as they come in the market, they have better response, they have better affinity for BCR-ABL. Dasatinib crosses the blood-brain barrier, so it has definitely a role in CNS disease, preventing CNS disease as well. But if you have T315I mutation, that also dasatinib will not work. And in dasatinib treated pH positive ALLs, if they relapse, you can see T315I mutation in the range of around 50 to 70% as well. So it's going to enhance that clone of cells which contain this mutation. So data initially came from the adults, multiple studies, which not head-on comparisons, mostly cross-study comparisons, which told us that if they're going to respond early to TKI, whichever TKI we use, they are going to do really well. And allo-HSCT is not required in those who are going to respond early to TKI. And if you have a TKI on an intensive therapy, again, allo-HSCT won't benefit. We looked at Indian data, or on this Western data of around 80%, when we compare it with Indian data of patients who have been receiving imatinib. So this is one of the papers. This is an abstract from 2016, which is 104 patients on an NCP841 patient. That is not a very intensive treatment protocol. On this protocol, even with imatinib, in India, the response from tertiary centers is that you are looking at response of only around 25-30%, similar to the pre-TKI era in the West. Another center from Lucknow, which which reported patients were pH negative versus positive. And you can actually see even before treatment is over, by even at 20 months of survival, even then you have the toxic deaths are so many that your difference between pH positive and negative, you can't really make out a difference in this. So this is the actual scenario of patients being treated in our country. And another recent paper, again an abstract, which came out 2 years back on a recent protocol, which is again high risk arm of that protocol. It is not as intensive as either of that other protocols which were discussed earlier. But even on that, even with imatinib, at 36 months, which is like 3 years into treatment, almost 1/3 patients have already relapsed on this protocol. So the crux of the matter is that the chemotherapy that we are able to deliver is equally important to the equally as important as the TKI which we are giving. Now coming back to the West. So what happened in the West by now? They started looking at whether adding a second generation TKI is going to help. So there is only one RCT, which is a good RCT, which has come in this regard. It is none other than PUI, but the study is done in China, and they had 189 eligible patients. The chemotherapy backbone was injured 615 and 16 protocols. And what happened in this group, out of the 189, surprisingly, we were expecting an 80% survival in the imatinib treated arm. In this arm, the survival of imatinib itself is less. It is 50%. And the dasatinib arm has actually gone up to around 75%. So the study concludes that dasatinib is definitely helpful compared to imatinib. But one wonders why the imatinib survival has gone down. And why has it probably gone down? It is because they have not used cranial RT in either of their arms. And considering dasatinib, the one which has penetrates blood-brain barrier, their CNS relapses in dasatinib arm is less. The CNS relapses on total relapses in the imatinib arm is worse. So that is one change that has actually brought out this glaring difference between both the agents, and the relapses actually went up. The authors go on to say that they have used dasatinib at a dose of 80 mg per meter square, and that's probably why they're getting a better response, but this also needs to be considered. What about toxicity in China? 5% of children died just due to toxic infections in either of these arms. And that's an extremely high number of patients that we are talking about. And they even discuss about the possibility of reducing the intensity of chemotherapy in further studies if we were to use dasatinib, but there is no conclusion in that regard. Is there any meta-analysis on this topic? There was a meta-analysis which looked at whether TKI should be used or not. And in that, they discussed the choice of TKI, but then there is again only one RCT to discuss from. Now the original authors of the COG study went on to do the second step, which was the second logical step, that you're already getting 80% survival with imatinib. Shall we add dasatinib and see whether there is a response? And this data also came out recently, which showed that it did not improve. The addition of a dasatinib to the existing same intensive chemotherapy that was given earlier. This is the AALL 0031 trial, and this is 0062 trial. 0031 at 10 years, you still have around 70% of these children are doing well who received imatinib earlier, whereas 6.2, it is actually not improved survival at all. So on that intensive backbone, dasatinib is not improving. My worthy opponent will bring out this generic option that it is affordable now. There are generic options. So I just thought I'll put it out there. Cost is no longer the issue. There are good drugs which are available in the market, and it is reasonably affordable also. But then there are other choices we need to make while deciding TKI. When we are giving intensive chemotherapy, we are not even able to manage imatinib alone. When you add on an agent which has more of pleural effusions, pancreatitis, and this kind of toxicity, I do not know whether we will be able to give it without much breaks in treatment. So I'd like to conclude by saying that regardless of whatever TKI we use, we should be using it early, we should be using it continuously, and we should be using it concurrently with intensive chemotherapy. We know that imatinib will help with intensive chemotherapy, definitely. Will dasatinib help the track record, improve the track record of imatinib with the same intensive chemotherapy? No, we do not have data on this. In fact, the data from COG says no. Will imatinib help with less chemotherapy backbone? Definitely no. We already have Indian data on this. And does dasatinib help us reduce the intensity of chemotherapy, which would be really good for our setting? We do not have any data on this matter. I'll finish here, and I'll love to hear from my opponent.
Thank you, Nita. Very nicely done. And I enjoyed your presentation and look forward to seeing and hearing Satyendra. Satyendra, welcome.
Hi, hi everyone. So thank you upfront to the organizers for giving us this opportunity. But the question is, here was not whether dasatinib versus imatinib. The question they chose was, should we be first generation versus second generation? That's where I was like slightly, it's for sure it's that we need it. And I'm sorry, I need to share my slide for that. So it's very clear that we need imatinib, we need TKI. But the question here is much more profound, and that is, should we be using first generation versus second generation? I'll try to sort this out. And as usual, Neeta is my good friend, and she has helped me quite a bit into this. I'm not going to introduce anything. And that's what we're going to establish. How strong is TKI? And what is this whole thing of BCR level? Which one is better first versus second? And because it is just 3 to 5% in pediatric, we are never going to have huge cohorts of patients which are going to give us the answer. And we know the trial done by Kirk-Shoes can never be repeated, could not be repeated even by the big boss, Dr. Pui. So let us see how our things. So exactly the BCR-ABL, we know it's constitutively active tyrosine kinase, and which is coded by the BCR and ABL. And depending upon the breakpoint cluster region, there are 3 isoforms. One is P190, which we call it the shorter variant. Then P210 is the longer variant, and the longest is P230, which is very, very rare. And why are we talking about this? Because we need to remember that traditionally what we understand from TKIs has come out from CML. And in then CML, then we have is 210, but in most of the pH positive ALL, what we have is 190. Now, in contrast to CML, what we have to understand is the game is different, because BCR-ABL translocation alone is insufficient to induce the malignant transformation in pH positive ALL. There are many drivers. CML, it was easy, but pH positive ALL, the game is different. And so many other than BCR-ABL are there. They are very common, Icaros and CDKN, PAX, RBI, lot of are there. So we need to understand that's what a pH positive ALL would be. It is BCR-ABL TKI, where plus leukemogenic mutation, and we know leukemogenic mutations, we have to deal with chemo plus transplant. But BCR-ABL, we gave TKI, and now we are going to talk about the combination. So the question I'm raising over here is this TKI first, second, and third. So we don't know how are we going to deal with leukemogenic mutation, because that depends on to how intensive the backbone is, how good the response is, how the MRD is, what is. But what is one thing which is a constant over here, that is BCR-ABL. And can we choose a better fighter to add on to this chemotherapy or the transplant game out of the 3 generations? And we know imatinib and dasatinib, they come into the first generation. So it is between the first generation versus second generation. So it's never about imatinib and dasatinib. Neeta has clearly told us that probably dasatinib is slightly better than imatinib. Oh yeah, I agree to that. Yeah, the question here is whether first generation versus second generation. And we are going to talk about nilotinib, redotinib, and bosutinib. Are they better? And then one slide about the ponatinib. So can we learn something from the CML data? Yes, we can learn. This is the famous paper from the blood, and that, the whole thing of failure go down significantly. So remember, now I'm just want to give a perspective that how to select the TKI. When TKI, anti-TKI, the tyrosine kinase inhibitor is just one player. So we want to select the strongest player. So this paper clear-cut established that with second generation TKI, you have beautiful remission and the failures are less. And then comes this paper, and which is upfront nilotinib versus imatinib for CML patient, and it was very categorically clear. And it was the instant trial, and it had the young the pediatrics also and the young adults also. And they clearly established that yes, nilotinib induces much deeper remissions, and that will definitely help. Based on this, in 2019, a comment came onto the Lancet Hematology, and that's where they concluded that, nilotinib induces much deeper a molecular remission of BCR-ABL than the standard thing. So definitely, if we choose some strong TKI inhibitors, we are going to add to our chemotherapy treatment, which are we going to do the pH positive ALL. So the question is, second generation induces deeper remissions, but can we take this to the Ph positive B-ALL, where MRD is very important. Probably how much important it was for CML, we don't know. But for Ph positive, it is important. So let us take how it does. So here is the paper from the Adult ALL Working Party Korean Society for Hematology, and they compared nilotinib with, they combined nilotinib with multi-agent chemotherapy and newly diagnosed upfront Ph positive ALL, and they gave induction, 3-drug induction. No Hamsil or no LS parazinase over here. So the pancreatitis concerns and all that which my worthy opponent has raised were taken care of. So they gave this induction chemotherapy with nilotinib, and they continued with nilotinib. And once they were sure that you are into the hematological CR, either they continued with 5 courses of consolidation chemotherapy followed by maintenance, or they went ahead and did with the allogenic stem cell transplant. MRD was assessed at hematological CR and the 3 monthly thereafter, and the molecular responses were decided as MR3 or MR5. MR5 was 10⁻⁻5. And here it proved, so 90 patients, and the ages were young adults also into pediatric, not very hardcore pediatric, but young pediatric patients were into there. 20% of the population was young adults. HCR rates were good. And out of this, some 2/3 of the patients went into the LOHSCT. The cumulative MR5 was 90% with nilotinib with chemotherapy. Subject that failed to achieve MR3 or MR5 had relatively high chances of relapse. And MRD status just before transplant was predictive for 2-year survival. So what the graphs was like. So it's outstanding. If you just want to see, this is MR3. After hematological consolidation, you see just with multi-agent chemotherapy and just nilotinib, no transplant, you are talking now to the range of 75 to 80%. And here also, then what about before transplant? If you induce a stronger remission, how does it help? You see it here, MR3, you are going to talk transplant 80% plus, which is a data which has been reproduced by most of the centers. And here, if you induces MR5, this is further awesome. So definitely it told us that yes, if you induces bigger remission into the BCR-ABL along with a multi-agent chemotherapy, yes, they help into the hematological remission-free survival. But historically results range between 50 to 60%, and suddenly with nilotinib, we are talking about 80%, right? And these are the difficult patients. The pediatric patients are easy to treat than the young adults. So in the difficult cohort, we have reduced it. So do we have a comparison now? So nilotinib is okay, okay, second generation look better than whatever it was, but do we have a comparison between first and second generation? And yes, to my surprise, we have. Again, the paper comes from China, 77 patients, upfront treatment with TKI, 45 patients were given the first generation and 32 patients for the second generation. The median age was 30, but they were pediatric patients ranging from 13 years to, including the adults. LOHSCT was given in 3/4 of the patients, and in 60% of the patients who were given the second generation TKI. MMR after first induction was better with first generation, and you can see the comparison. And CR rate before transplant was much better with the second generation. So it is very clear that if you add a second generation, when you compare it to the first generation, you induces better MMR, you induces better MRD, and they all translate into the better survival. So 17 patients who actually relapsed later on were found to be 9 from the first generation and 8 from the second generation. So there was nothing much into this. But how were the response quickness? So they were saying, so second generation probably slightly, but it was not statistically significant. So the quickness of the response was same when it comes to. But when you look at the DFS and overall survival without transplant, whatever you give first generation or second generation, I don't know how come the COG data cannot be reproduced. The outcome is, going to be bad. But what if you induces better remission and do the transplant? It is awesome. And you can see the difference is this much, you cannot ignore it. So with second generation, it is 80%. With the first generation, it's looking between 45 to 50%. And this is with transplant, overall survival, and the DFS both are there. So, and here is the overall, the overall study, which was, a lot of transplants were done, but few patients we were not. So overall, even with second generation, you are around 65 to 70%. So this clearly establishes that second generation, there is a better trend of DFS with second generation TKI. There is no significant difference in the early response, although, The subgroup analysis, if alloHCT was incorporated, second generation was definitely better because they induced much better MMR and hematological response. And both the generations were well tolerated. There was no significant side effect which were reported over there. Now let us slightly for the last few minutes, is first generation TKI better than anyone? Forget about the second one. Is it better than the third one also? And we can always, Neeta help me by saying that money is not the concern, and I completely understand. Money should never be, because here is a cohort of patients. What we are debating is because there the life is 20% was the standard, and now we are talking about 70-80%. So here the life is at stake, and the money is never a concern. So here there is a comparison with hyper CVAD plus ponatinib and hyper CVAD with dasatinib frontline therapy, and you will be surprised to know 110 patients newly diagnosed, 2 consecutive, one was given hypersevered dasatinib, other one was given hypersevered ponatinib. And then they did propensity score analysis with 1:1 matching, and Raman will understand it's a very good way of comparing, when you are comparing the two groups over here. And they compared the response rate, the EFS, and overall survival between the ponatinib and even if you, before I give you the curves and the difference, you see the negative MRD rate was better with ponatinib, the CMR was better with ponatinib, the MMR was deeper with ponatinib. So when you compare first generation with the second or third generation, the response is not only better but is much deeper, which helps the ultimate. And I don't have to tell it, this audience. Ponatinib is much superior than the first generation, and it's very obvious that when you are considering to treat a cancer which has got a lot of mortalities in it, you add a component which induces much deeper remissions, much better of MRDs, which ultimately translates into the long-term survivals. And you can see these graphs are now flattening out. So I don't think they are going to change much. So I would conclude there is no clear-cut data for sure when it comes to the pediatric, and I completely agree with Neetam to that part. But both generations, they are well tolerated. We need to remember that. CML data clear-cut suggests that second generation induces much deeper remission, and we should extrapolate this into the Ph positive. And the data has suggested that the B positive ALL also suggests that yes, they induces deeper remission, which ultimately help with the chemotherapy and transplant. This is especially true when we are considering a transplant. And this is a group where survival is the target. So I don't consider even if we have to use a costlier drug or a cheaper drug, because here at stake, it's not some quality of life, it is about the life. So with this, I would finish my talk, and thank you very much. There is a cost for everything. There is a value. And whenever you see the value is taking care of the cost, we should never be bothered about anything. Thank you.
Thank you, Satinder. Thank you so much. Neeta, can I give you less than 2 minutes for rebuttal so that we stick to time? Thank you.
No, I don't need 2 minutes because we have already kind of discussed what is to be discussed. And I agree with Satinder in that the aspect that cost should not be a concern, and cost is not a concern in both these agents. One. Second, intensity of treatment is what matters. And that has to be delivered with whichever TKI we are using. 2. 3, the better the generation of TKI, obviously we are going to see better or deeper remissions. But the question here was just first versus second generation. So there's no point in discussing ponatinib here anyway. And then last point I wanted to make is it is essentially imatinib versus either dasatinib or nilotinib that we are discussing. And in this aspect, I think if we are delivering intensive chemotherapy, then the difference of first generation versus second generation doesn't seem to be that obvious from the Western data. Whereas a study from China, this is the only RCT which has come. And I really wonder, which is just numbers, why that study was planned in China, or is it because of any other reason? But that data definitely shows. But like I said, again, they did not do radiation. Even for the CNS3, they have not given radiation. And only 1 out of that 189 children went to transplant. So in that setting, when you have not, there are patients, there would have been patients who are MRD positive also. If those children have not been taken up for transplant, and then you show this gap of imatinib versus dasatinib, that doesn't seem very convincing either. So I would like to rest my case saying that if we are giving an intensive backbone, I think imatinib is good. If we want it, there is currently no data to say that a second generation will do much better or significantly much better if we are giving the same intensive treatment. And there is no data to show us that with the second generation, we can reduce the intensive treatment as well. That's how I would rest my case.
Thank you. Thank you both, and also for keeping to time. So I think both of you make a very eloquent and passionate plea for the respective TKIs. And I think the current evidence boils down to one RCT. Dasatinib for me is a second generation TKI, Satinder, so I would still call it second generation TKI. So that boils down to one RCT, and where Neeta, I disagree with you is that even if it is reducing CNS's relapses and we are not giving cranial RT, even that's a good outcome, right? So even if dasatinib can show that, that's a good thing. But the criticism of the trial also is that they did not demonstrate survival in the imatinib arm as is expected as a standard what would be at that time. So it becomes difficult to completely accept it. The answer may lie in a future RCT. But what's interesting is that the current COG or the future COG studies are actually not studying dasatinib versus imatinib. They are actually now focusing on the intensity question, which is, can we reduce the intensity in a certain subgroup of people? And can we add blinatumomab and try and reduce the use of transplant? So I think for Philadelphia positive ALL children, both your debates are winners because they are spoiled for choice in a way. They have good options. And now it is a question of fine-tuning that option and reducing the toxicity, transplanting those who need to be transplanted. And as Neeta said, start early, give it continuously, those kind of things. And I think that's where we are. So thank you so much, both of you again, for your time, and thanks to the audience for listening. I hope, Shubham, you and your audience found this informative.
Really, sir, I think this is something very new to us, and I'm sure that having more and more pediatric hemat topics within this forum will help us actually to stay on track. Thank you so much. Thank you, Dr. Ramandeep. Thank you, Dr. Neeta. Thank you, Dr. Satendra. Thank you for joining in. Thank you so much. Thank you. May I now invite Dr. Anupam to introduce the topic for us for the next debate. Dr. Anupam, I will be sharing the slides for you, please. Doctor, can I share the slides first? Yes.
Yes, sir. Yes, sir.
Thank you.
Thank you, sir. Welcome to day 2 of 4th annual conference of Fortis Oncology Forum for Hemat Oncology session. Here we are, therefore, very interesting debate. It's for VRD versus DARA VRD. Debate is, are we ready for upfront DARA in multiple myeloma? So frontline therapy for newly diagnosed multiple myeloma, it's continuously evolving over the last 10 years. There has been growing emphasis on achieving the best depth of response in the context of MRD negativity, given its prognostic implications and its correlation with superior overall survival. Another emphasis has been to improve the prognostication and staging of the disease by understanding the disease biology in depth. Now, triplet induction regimes, they have been the standard of care for newly diagnosed multiple myeloma. And goals of induction remains the same. That is quick disease cytoreduction, that is urgent reversal of symptomatology, reversal of end organ damage, and improvement of performance status of the patient. So keeping this goal in our mind, monoclonal antibody-based regimens are making their way to the frontline setting for both transplant and eligible patients. Recent data suggest that a deeper remission, that is MRD negativity, it is correlated with improvement in time to progression and improved PFS and overall survival too. So we can say that goal of treatment for newly diagnosed multiple myeloma patients in frontline settings should be to induce the deepest remission possible. So that here we come to the debate topic, interesting debate, that are we really ready for 4-drug combination in frontline setting for myeloma patients? That is DARA-VRD.
Can we have the
To
speaker
chair this
slide, please?
interesting, yes, sir.
Yeah, please go ahead.
To chair this interesting debate session, we have Dr. Rahul Bhargav, sir, who is Principal Director and Head of Department for Hematology Oncology. Sir does not require any introduction though. Over to you, sir.
Thank you, Anupam. Thank you, Shubham, for this wonderful initiative. I think Uday has to back out at the last moment because of unfortunate incidents in his family. So we will invite Dr. Prashant and a slightly lighter, longish debate on how his thing is on DARA-VRD, because we know that VRD is good enough, but can we make it better? Because we still are far away from a word called operational cure. Still not many people live more than 10 years, though it has increased from 3 to 4 years to 5 to 6 years, the median survival, but we want something more. First, couple of years back, it was CR, then stringent CR, and now the word is MRD negativity, which is based on flow cytometry-based minimal residual disease, or you can say a measurable residual disease. VRD has done it well. We know in risk groups, VRD versus KID, VRD has been the forefront, and it has not shown to be, KID has not shown to be superior to this. Next week, ASH is going to convene, and there we are going to see plenty more data from not only from master trial, which is going to talk about DARA-KRD, leading to deeper molecular remissions, and this obviating the need for bone marrow transplant. So DARA-VRD followed by transplant, followed by maintenance strategy, and in certain cases, consolidation therapy might be required. So whatever regime which you use, can we achieve better MRD rates going up to 50-60%, which was not possible in a Melphalan era, which was 10% DARA-VRD, going up to 30%, and now adding DARA to that, going up to 50, 55, 60%. The debate would have been, they would have convinced you that DARA might not be useful as a backbone because VRD is still doing a great job. But as he's not there, we will invite Dr. Prashant. He is well known into hematology and oncology for his targeted approach and a patient centricity. So we'd like to call Dr. Prashant to deliver his talk, why he thinks that the DARA-VRD is now becoming the standard, and keeping cost in mind. Does it really provide the benefit of what it is promising right now? Will it not? Can it reduce the rates for doing a bone marrow transplant, or the bone marrow transplant still remains the backbone in an era of DRVD? So with this, we would like to listen to Dr. Prashant, who is going to educate us about DARA-VRD, a 4-drug combination, and then probably also talking about DARA-KRD as a frontline therapy, which might soon become the reality in the coming days. So over to Prashant. He is a consultant at Asian Hospital, Faridabad. Over to Prashant. So stage is all yours.
Thank you so much, Dr. Rahul Bhargav. It's really a pleasure, and thank you for that invite, sir, so much for this debate. And now I guess this is going to be an internal debate within Prashant 1 and Prashant 2, probably, because Uday is not there. So that debate is already on, let me tell you. So this is quite a rich conference. So in the previous session, probably Pona Blina would also have been making sense. So, but am I rich enough? I would think like that. Do I have enough money? I have not used any upfront DARA as yet, and I treat patients who are not able to take upfront DARA, and even I'm not that rich enough. So let's come to the debate. So I'm going to be doing this academic discussion now. So let us talk of MRD first, which everybody here is talking so much about. So this is a large meta-analysis. Probably this is what actually is driving the whole discussion. And let's see the association of MRD between PFS and OS. This is the PFS here. Look at the newly diagnosed myeloma, transplant eligible, ineligible, relapsed refractory, MRD negative or positive. Everybody kind of benefits patients who have MRD negativity, they actually have a longer survival. You can see the curves, Kaplan curves, very clear here. So, and also look at the forest plot, the hazards are also favoring patients who have MRD negativity, all kind of risk groups. If they have achieved an MRD negativity, they have a longer PFS. And this is a very large meta-analysis, probably over 4,800 odd patients. I will come to that. And this is what we are looking at. Are people living longer? So this does say that actually at 5 years, the newly diagnosed as well as the relapsed refractory, they both are actually living longer if they have MRD negativity. 70%, 20% difference at 5 years. And again at 3 years, for the relapsed patients also, there is a difference of survival between MRD negative and positive. So it is actually conferring, a longer OS. That is what we always want to look at. The 44 studies were included, and actually 8,098 patients, but there were 4,297 patients actually identified from these studies. 23 studies were identified to assess the association between MRD and survival. And patients who achieved an MRD negativity had a better PFS as well as OS and improved outcomes. So what are the guidelines right now? Look at EHA, ESMO, induction, transplant eligible options are VRD and DARA-VTD. That's from Cassiopeia. And if these options are not available, VTD and VCD. If they're ineligible for transplant, then the options are DARA-RD, the triplet, and probably that was a Maya study, and DARA-VMP and VRD. These are the options. And obviously for the eligible, you go for a transplant with this melphalan, 200 mg per meter square, and followed by LEN maintenance, which is the standard. So these are the NCCN guidelines, a little conservative for a change. Thank God for that. And they have put category 1 VRD and VCD for those with acute renal insufficiency, and other recommended regimens they have added. It's probably category 2A if they have not mentioned the category, and it's DARA RVD, DRVD, that's a quadruplet, and obviously KRD is also there, and ixazomib also added. I don't know why. Could have avoided that too. So transplant ineligible patients, they have added the Maya regimen, Mayavi regimen, and DRD, that's the regimen. And then there are other regimens, the common ones are there. And then there are quadruplets, which are the other recommended ones. So that's DVMP and DCVD. That's another regimen which is there in the quadruplets. And that's in the transplant ineligible. This is the NCCN, a little conservative for a change. And let's see transplant eligible newly diagnosed multiple myeloma. What is the data? Cassiopeia, part 1 and part 2. Important study. This actually studied DARA in combination with the thalidomide, dexa, backbone, and bortezomib. And that's what it is studying. It was a randomized study, phase 3 study. DARA VTD versus VTD, and there was an induction phase, and then there's a consolidation phase after the transplant, and at each time point they're studying the MRD as well, and then after consolidation there is maintenance, and there is a slight difference in the maintenance. It's a lower frequency maintenance. It's at Q8 week intervals, and not like 4 weekly for daratumumab monotherapy, and the randomization also happens again at end of consolidation, and MRD is also studied there. That's the part 2 of Cassiopeia. So MRD, we have seen that meta-analysis. MRD is actually looking like a surrogate for OS, and in solid tumors we have not found such a beautiful study depicting such a surrogacy, because for TNBC we have been it has been ages, and we have been looking at PAT-CR and OS and PAT-CR and OS again. But not as clear as you have got the data here in Munshi et al. Study. So looks very convincing in the face. And this is the MRD negativity rates between DVTD and VTD. Look at the MRD negativity. It's 64% versus 44%. Looks quite impressive. The quadruplet has more MRD negativity, and which is a possible surrogate based on that meta-analysis. Then again, the patients are randomized to maintenance DARA versus observation. All the patients after end of consolidation. What happened after that? the depth of MRD negativity, the depth of remission again improved after even this phase of treatment with DARA. So it does, obviously eliminate MRD to quite an extent. The discontinuation rate in this study were, not very high, and they were in fact comparable between the two arms. In fact, it was lesser in the DARA arm, to my information, and the rate of depth of response was significantly better, improved with the addition of daratumumab at each phase and in each arm. There are multiple arms in the study now because there are two sets of randomization. You can see here the DVTD followed by DARA arm had the best rates of CR and also the rates of MRD negativity. The more DARA was there, the more DARA you put in, the more money you put in, better is the MRD negativity. See the charts here. So this is the updated analysis of OS also, and it looks like trending towards being significantly better in the DARA arm. The PFS also is better, favorable hazards 0.58, impressive. Again, you seldom get those kinds of hazards in solid tumors. Some rare trials do show those kind of hazards. And then this Griffin study, again DARA RVD versus RVD, another quadruplet, and this a similar kind of trial design, but obviously it was the DR in the maintenance phase. It was Q4 weekly or Q8 weekly, both were there actually. So the MRD negativity rate, which is what we are interested in right now, is 62.5% versus 27.2%. You can see between the two arms, and it is improved, definitely improved. So in the transplant ineligible patients, the data is even stronger. That is what it looks like. And the Maya study, it was a triplet, but it showed an improved MRD response. You can see here the update at median follow-up of about 36.4 months or so. So the sustained MRD negativity as well as MRD negativity is better in the DARA arm, although this is a triplet and we are not discussing triplets much today. This is the Alcyon trial, which is and the update on overall survival in the transplant ineligible patients, and that's where probably the data looks even stronger. And this was DARA VMP versus VMP, and again followed by a maintenance phase. And let's look at the MRD. That's what we are mainly interested in. It's a surrogate, it seems. And there's a fourfold higher rate of MRD negativity with DVMP, 22% versus 6%. And then updated analysis showed 28% versus 7%. And sustained MRD negativity, which is lasting more than a year, is 14% versus 3%. So this is also worth taking a note. The OS is improved. Hazards 0.6. 42-month OS is 75% versus 62%. It is a significant advantage, and 40% risk reduction of death also in the DVMP arm. It's an important result. The AEs were also not very different from what we are aware of with DARA. And the rate of treatment discontinuation due to infections was 0.9% versus 0.9 and 1.4%. In fact, it was lower in the DARA arm than in the control arm, which is a pleasant result. So at a median follow-up of 40.1 months, DVMP actually reduced the risk of not only progression but also death, and there was a significant OS advantage with using DARA in the transplant ineligible patients. This is what Dr. Rahul Bhargar was also talking of, the master DKRD approach. And here there is in the untreated patients, induction is with DARA KRD followed by autologous consolidation, followed by another DKRD consolidation of 4 cycles MRD at each time point. And the goal is actually to achieve more and more MRD negativity. And then consolidation, another 4 cycles of DKRD, then LEN maintenance. Endpoint was also MRD negative remission. Look at the MRD negative response by phase of treatment. So 82% patients were actually able to achieve that kind of MRD negativity. And in fact, very high degree of 10⁻⁶ degree of MRD negativity was there in 63% patients, which is considerable. And this kind of approach is something which is we are going to look into the future, and there's going to be more trials in this regard. So my take home would be DARA-based quadruplets may be the future. Are they the present? Are they the present in India? Are they the present for me? I'm not sure. Internal debate. So master strategy can achieve more functional cures. Place of HSCT, to my mind, it's still secure. MRD negativity is the goal of treatment. Yeah, looks like that. Is MRD testing reliable in our country as yet and standardized? Okay, we will look into that also. And do I have enough money? Question mark. Thank you. And this is one thing which I wanted to mention to everybody here. My first independent album, Dil Besabra, will be live on all digital platforms, December 22. Please listen, stream. The more you stream it, the more funds will go to cancer patients. And if you like it, do stream it. If you don't like it, it's okay. But if you like it, please stream again and again. Thank you so much.
Hello. Thank you, Prashant. Hello.
Yes,
Yeah,
sir.
you're audible. You're audible.
Yeah. So thank you, Prashant, for this wonderful. So couple of questions, Prashant. First of all, is there a class 1 evidence based on a randomized trial saying DARA VRD leads to a better overall survival? Because the critics will always say it's an expensive medication. There are two aspects to that. One, they will say
I also said that.
It's a long-term strategy. Do you have any data from this DARA VRD strategy followed by a transplant for an Indian audiences that they can be given a finite amount of DARA and then they can be transplanted? Is there any data like that? That you give 8 injections, 10 injections, because you get some free also from the company.
Yeah.
Is there any data that can also lead to a better outcomes than not giving DARA at all?
So some DARA or some DARA or lot of DARA or no DARA. So the trials which if you extrapolate from the data, the more the DARA, the better the MRD negativity. Less the DARA, less the MRD negativity. But between no DARA and some DARA, the MRD negativity is better with some DARA. So now you decide.
Okay. So what we have started doing, Prashant, is saying we give 8 injections of DARA as an induction strategy, then give only VRD, and we are still seeing the better MRD negativity rates in these subsets.
You will see, because that is what the data is also showing. The data is also showing the same. The more the DARA, the higher the negative. The longer the DARA duration, the more the MRD negativity. That's clear from the data.
Sir, may I interrupt and ask what is the cost that we are talking about? I mean, how much is the difference? Because as a surgical oncologist, I am not aware of the cost. So just what is the cost difference that we are talking about? Prashant?
So the cost of DARA is approximately 1.6 to 1.8 lakh rupees a week injection.
Okay. Right.
So second question, Prashant, is what about the stem cell harvest in DARA VRD? And second, what are the rates of infection in these subsets?
So you're asking me the data for infections with DARA?
DARA VRD.
Data,
yes, DARA VRD.
The data did not show a high increase rate of infection, but in India, I get to see some, little bit more infections with patients on DARA. That's
Okay,
a general
and what
experience.
about the stems? Yeah, and what about
I don't think the stem cell yield is affected.
Okay. So it means that it is quite safe, except the financial toxicity. It seems that DARA VRD seems to be doing very well in inducing the MRD. And does MRD translates into progression-free survival, Prashant? Is there any data to suggest that?
Yeah, that already I showed in my slides. That data is there. PFS as well as OS. There is OS advantage.
So it means
Munshi et al. Meta-analysis of 8,000 odd patients. So the question is not about OS is better. OS with MRD is a surrogate for OS in myeloma. That's confirmed now with this data. But now the only question is the cost. And because it's a long-term administration, how long it can be stretched, and how many patients can take it in India? That's the question.
Okay. So do you think DARA VRD, there are some proponents in India, they say use DARA VRD only in high-risk patients. And on the opposite, I say use it in all the patients because you might get the best benefit in the low risk patient. What is about you say?
So
What do you say about it?
that's the same with AML. So in the good risk population, if you give more, you get better results. So myeloma, simply if you want best results as per the data says use it in all.
Okay.
It doesn't say high risk.
Okay.
Yeah.
So
The
people
world is going to adopt.
across the risk factors are going to get benefited of DARA VRD.
Yeah, that's the data is there. All risk stratification, all kinds of patients, ineligible, eligible. In fact, the data is stronger for ineligible because the OS advantage has been directly shown. But in eligible, the OS advantage has not been shown directly, though the MRD points towards an OS advantage, the MRD rates.
So Prashant, can you tell me few of the subsets? Okay, probably the country might not be able to afford, but can you enumerate from your vast experience what are the absolute places where you would like to use DARA in your setting? In what kind of a myelomas or amyloidosis where it is must that we should use?
So to my mind, I think the renal recovery would be better in patients who have a major renal insufficiency. So that is where I would be a more stronger proponent of using a quadruplet, and that is one area. High disease burden, extramedullary disease, lot of extramedullary disease, maybe those areas, not necessarily high risk. Not necessarily that,
but
yes,
amyloidosis as well.
Amyloidosis as well. They also seem to do better.
Okay, with daratumumab. So I think it's wonderfully presented. 2 trials, Cassiopeia and Griffin, seems to be going strong. There will be a further data which will be presented in this coming ASH.
Yeah.
And probably we are looking
the master
at
update also probably.
Master update also. The quadruple therapies are now becoming the standard. And Prashant has very well laid down the benchmark for showing us the trials that how myeloma world is moving in spite of the newer medications. The DARA VRD followed by transplant remains the standard of care. And that's what the audience should remember, that this is the way we should treat multiple myeloma wherever possible. A definitive or rather than an infinite or indefinitive DARA, definitive amount of DARA plus transplant and followed by maintenance therapy is the way go forward for Indian subset.
I think with the aspect of finite nature of treatment, CLL is doing better than myeloma. In CLL, we are moving towards finite treatment, but not yet myeloma. Myeloma is kind of never ending. That's something which is disturbing.
Yeah.
Continuous treatment is disturbing.
And that too, we are also...
And all the trials, including master, they just seem to carry on. And it is mind-boggling and it is shocking. Such kind of approaches cannot be done. Like a master approach, 4 cycles and 4 cycles and 4 cycles after transplant and 4 cycles more. It is near impossible to achieve for patients in India. I don't know. Not even the cost would be a hindrance. It will be a lot of other factors. It is very, very difficult.
Absolutely, Prashant. Even with consolidation, we talk about post-transplant.
And I'll tell you the real world what happens. In the real world, I am aware of 2 patients. I got called for second opinions. There's one patient who was transplant ineligible, started on DARA and VCD probably, and he is bed bound after about 6 weeks of treatment. He may have achieved an MRD, I don't know, but he's bed bound completely, and he's lost all weight, cachectic. So a lot of issues may happen in our country. You have DARA in the second line, you can use it. And MRD negativity, if it is the goal, you see the data from Munshi et al. MRD negativity in patients who were relapsed refractory, if you achieve MRD negativity there, they also live longer. So what is the cost of what we are doing? Are we, using all the data used in the Western world too early for our population? We have a lower BMI, we are cachectic. When we are diagnosed, we have infections. All of us have infections when we are diagnosed. We have pneumonias. We have, higher rate of problems. Neuropathy probably we have more. We have more myopathy. Proximal myopathy I see a lot in myeloma patients in long term. So we are not as, robust as some of the Western population. Our BMIs are lower. Lot of things to think about. internal debate, as I said.
Right, Prashant. Uh, what I get is that new drugs will give us a lot of new more ways to treat cancer and treat myeloma in a better way. We wish we had Dr. Uday to speak for VRD, but I think Dr. Rahul Bhargav and Prashant did the discussion in a way that we
I,
got to
I,
hear.
I spoke also in favor and
Yes,
against both.
yes, yes. I could
And
make,
Dr. Rahul, Dr.
I
Rahul,
could,
Dr. Rahul also spoke in favor and against.
I could make it out, Prashant. Thank you so much. I could make it out. That what you were doing and how Dr. Rahul pulled
And
it off.
I was not aware that Uday is not there.
We
Still
didn't
I
we
still
didn't
I
let you we didn't let you know that Dr. Uday was not there because we knew I told I like giving you difficult tasks and you always come
you
to
gave me
it.
a difficult task again.
But let me tell you one thing about Prashant. Even if you don't like his album, please stream it. Although it is not going to happen that you don't like it, but even if you don't like it, stream it because it is being money will be generated for a good cause. So thank you so
But
much.
and I'm hoping that you like it.
Yes,
Lot of effort.
definitely.
Thank you so much.
So thank you,
Thank you,
Dr.
Prashant. Thank you.
Thank you so much, sir, for the invite. Thank you so much, sir.
Thank you, Dr.
Thank you, Prashant.
Anupam.
Thank you.
Thank you, Dr. Rahul. Thank you, Dr. Prashant. I think it was a
Thank
very
you, sir.
interesting
Thank you.
session. Thank
Thank
you,
you.
Dr. Anupam. I must say that, swimming into pediatrics and hemato-oncology for somebody like me, surgical oncology is really a new field, but every time I hear it, I feel that I'm missing something if I don't attend it. So thank you so much. And we will move on to the third session, the second session, actually, the third topic, which is head and neck malignancies. And I would request Dr. Neha Sehgal to please come up and introduce the topic. For the chairperson, Neha, let me do the job a little bit easy for you. That let me introduce the chairperson. The chairperson is Dr. Mudit Agarwal. Sir is director of head neck surgery at Rajiv Gandhi Cancer Hospital. Dr. Sudarshan Day is also supposed to join us, so he will join us in a minute. Can I ask Dr. The backend team to allow Dr. Neha to share her slide so that she can introduce the topic?
I would.
Please share, ma'am.
I'm sorry, I don't have the slide, but.
No problem, Dr. Neha. No. Yes.
Yeah. Thank you, sir, for giving me this opportunity. So far, so good. We are almost on time. Sir did the part of introducing the chairperson. So this topic of that PNI is not a good enough factor for adjuvant RT in early stage node negative oral cancers with no risk factor. Per se, me as a radiation oncologist will whinge if I go against this topic. And let's see, for adjuvant treatment, we know the adverse features like ENE with or without margin. We do need post-op RT and closed margins. We have resection and so on and so forth. But let me share one thing. The recent NCCN, which is like the updated one right now, it does recommend that adjuvant RT alone is a risk factor. Sorry, PNI is a risk factor, and it does say that RT alone is a treatment option for that. It does recommend that, but I'm not here to debate on this. As a radonc, I will always be in this favor. So I would request the chairperson, Dr. Mudit Agarwal sir, to please introduce our speakers for and against the topic, and let's see how this debate continues. Mudit Agarwal sir, please. Sir,
we have a recorded video by Dr. Saurabh. Can you please play it?
All right. We will play that recorded video.
We are debating on a topic which is very, very important. Presence of PNI is not good enough for adjuvant radiotherapy in early stage node negative oral cancer with no other risk factor. I am talking about for the session. I am Dr. Saurabh Arora, Director of the Department of Surgical Oncology. So why we are debating this today? What are the patients for whom we are debating? Are we debating for T3, T4 patient, node positive patient? If the patient with depth of invasion is more than 1 centimeter or other factor like LVI or WPOI? I don't think so. And these patients will definitely require radiotherapy, and these are not patients we are discussing today. So from where this discussion has come up, so there was a paper from the Tata Memorial Hospital in head and neck. The perineal is the independent prognostic factor in the oral cavity that warrant adjuvant treatment. So now we will go through this paper, and they have told in the paper only, this being a retrospective study, various parameters such as location of PNI, number of nerve involved per section, PNI density, and pattern of PNI could not be assessed because it is a retrospective paper. So they were not sure about the pathological extent of PNI for which the paper was written. They came up with this slide, and that the adjuvant RT increased overall survival in these patients T1, T2 with node negative. So who were these patients for where they have inference that these patients will be benefited from adjuvant RT? There were only 60 patients out of 1,500. 465 patients, out of 465 patients, around 10% were PNI positive in this group, T1, T2 with node negative. 45 were subjected to adjuvant RT, that is 34 for more than 10 millimeter, that is with new AJCC classification, these patients were T3 patients, and 11 were poorly differentiated carcinomas. So the remaining 15 patients has not been given radiotherapy. On basis of this second arm of remaining 15 patients, we are debating if the post of adjuvant RT should be given or not. In the conclusion slide, they have written that aggressive treatment of the primary cancer may, by adding adjuvant radiotherapy in these patients, the addition of adjuvant RT may add survival benefit. So they were also not sure. They have given conclusion that it may add survival benefit. They were not sure. There are different type of perineal invasion, but we know it has not a well-defined term. It may be intratumoral, extratumoral, it may be multifocal, unifocal, less than 1 millimeter or more than 1 millimeter size of nerve. And when you go into the literature, there was in Journal of Surgical Oncology, there is a paper on perineal invasion on the oral squamous cell carcinoma, and they have quantitative subcategorized this perineal invasion. What they found, if there is a unifocal perineal invasion, then there is no difference in overall survival when you compare local regional failure. When you compare with a multifocal perineal invasion, there is a difference in the multifocal perineal invasion, not in unifocal perineal invasion. Same, they have inference if it is less than 1 millimeter of nerves, is the perineal invasion is there, they behave like same as the no perineal invasion. So there is no local regional failure. Only in the multifocal there is a local regional failure, and also if the nerve is more than 1 millimeter. So different studies has taken different instances, different parameters for perineal invasion. So adjuvant therapy was administered to 138 patient, 43% patient in this study. This include 22 with a unifocal and 41 with a multifocal. And patient with unifocal PNI that did not receive post-op radiation had no increase in risk of local failure or disease-specific mortality. This is the other paper, the impact of perineal invasion or lymphovascular invasion on the survival of early stage oral squamous cell carcinoma. This is from Taiwan. And they have also shown that there is no difference in cumulative survival when there was a post-op RT was given or not given in early stage diseases. This is also paper from Taiwan only. And this study investigates the role of PNI in T1, T2 oral squamous cell carcinoma with focus on controversial issue of neck management and postoperative adjuvant therapy. And they come with a conclusion, if the neck dissection has been done in PNI positive patient, there is no need to give post-op radiotherapy. It will not improve the local regional failures, the post-op RT. Now the systemic review, and it is very important, adjuvant radiotherapy for early head and neck squamous cell carcinoma with perineal invasion. And they have also concentrated their study on the early stage uh, diseases, whether adjuvant RT improves loco-regional control or survival in patient of early stage head and neck cancer. With PNI is the when the PNI is the only indicator, which is our debate is today. And they have included 8 study after extensive search. What they come with, the most of the studies support the hypothesis that the neck dissection is sufficient treatment for patient with PNI, and that adjuvant RT provides no additional benefit. Also, adjuvant RT in patient with PNI as their only indication for for adjuvant therapy. At this time, there is insufficient evidence for that. So it should be an individual decision rather than a blanket decision for adjuvant therapy. So loosely assembled evidence we have for this. For early stage node negative squamous cell carcinoma for oral cavity, there are only few patients. There is no prospective trial, and PNI is not well defined till now. So yes, PNI is an aggressive factor, but will be wrong to subject all these early stage patients for post of adjuvant RT only on basis of PNI till the time we have robust data. Thank you.
Hello.
So you're audible, sir.
But my video is, I think, is not
Working?
Yeah, 1 minute. Yeah, they
Yeah,
have
it's
started.
working.
Yeah, yeah. So I think Dr. Saurabh has well elucidated about that why PNI is not aggressive factor, sole factor for in head and neck cancers. So, but we see all across that PNI people as a sole factor, most of the radiation oncologists will be giving radiation therapy in adjuvant setting for most of our patients. So let's hear, I think what he has brought down very salient point, but one study which was from India, from our institute only, which he has not quoted. So we'll see that next speaker who will be associating on the role of adjuvant radiation in case of PNI. So I think that is a larger study. Okay, we'll see. Dr. Saurabh, you have done a good job. Yeah.
Hello.
Thank you.
You are hello. Hi. Good evening, everyone.
Yeah.
So again, my topic is a very controversial one. And as Dr. Saurav has said that there is no consensus about whether we should give, or we do not have the robust data about that, the sole criteria for PNI. But I have certain things to put forward in view or in favor of radiation even in the early stage T1, T2 head and neck cancers. Please, slides, please. Hello.
So you had shared the slides?
Yes.
Oh, okay. Backend team, can we play Dr. Manoj's slide, please?
Just a moment, sir.
Now, PNI as a sole indication for adjuvant radiotherapy in head and neck cancers. Next slide, please. Now, I came across exactly same case a few days back, in which previous slide, please. In which is a 65 years male with a COG PS1, no comorbidities, CA floor mouth. He underwent surgery, and the post-operative report was around tumor size is 1.4 into 4 into 2 mm, and the depth of invasion in 2 mm, margins free, LVI negative, PNI identified. And worst prognostic factors is 4, all nodes negative. Now, this is the case scenario, early stage T1, N0, M0, no other poor prognostic factor, but only the PNI. Now, here, what I want to say that the PNI identification is a very varied process in different institutes, and sometimes they do not even tell us whether it is a unifocal, multifocal, small nerves, larger nerves,
which all Dr. Saurav has said that thing. Next slide, please. So the question arises, what we should do. Now, what is perineural invasion? If we go for the perineural invasion, is a histological finding of nerves invasion by tumor cells. It is generally considered as a poor prognostic factor in head and neck squamous cell carcinoma and has been associated with increased locoregional recurrence and decreased survival. And it can also predict the concurrent cervical lymph node metastasis. Next slide, please. Next slide. This is the histological diametric views showing a nerve surrounded by the tumor cells. Next slide. Now, how perineural spreads? Often PNI is the only mechanism of tumor spreads in the head and neck cancers, and usually the spread is either a retrograde towards the brainstem or antegrade. Cutaneous spread can occur. Cutaneous spread at the nerve branching points. And the most of the time, trigeminal and the facial nerves are the most commonly involved. Next slide. Now, PNI impact. If we say what is the impact of PNI, there is a study called by Fagan et al., and they observed that if there is a PNI positivity, then there is a higher rate of local recurrences, 23% versus 9%, and the disease-specific mortality is more, 54% versus 25%. And sorry, please, last slide. And the author therefore recommended that the adjuvant RT for patients with PNI to reduce the risk of local recurrence. Second slide. Again, a study by Lenzer et al., which shows that patients with PNI were more likely to develop both ipsilateral 26% versus 6.3% and the contralateral 8.7%, 7.7% cervical lymph node recurrences than patients without PNI. The author recommended adjuvant RT to decrease the risk of regional recurrences. Next slide. Again, Lee et al. It is around 17 studies, around 4,455 patients, and this showed that the presence of PNI was associated with higher risk of locoregional recurrence, worse overall survival, and disease-free survival. And PNI had an impact on locoregional recurrences in early stage tongue cancers. Now, what basically I want to tell all these things, that if there is a PNI, the patient will have increased local as well as regional recurrences and decrease overall survival. Now, what to do for that? Now, PNI as a sole indicator for adjuvant ABRT, external beam radiotherapy. Few studies directly compared to outcome of patients with sole PNI who were treated with adjuvant RT to those who were not. Next slide. One study is a Chin et al. Though the number of patients was less, performed a subgroup analysis of 20 patients with the PNI, and despite the T classification, the 14 patients with PNI who were treated with the adjuvant RT had significantly improved locoregional control compared to the 6 patients who did not receive adjuvant RT. However, the author in this study found no improvement in the overall survival in patients who received adjuvant RT. Next slide. Now, with major trial, whether it is RTOG 9501 or EORTC 22931, both the major studies said that patients with isolated perineural invasion fall into the intermediate risk category and they are the candidate for adjuvant RT. This point one should consider because these are the 2 major trials. Next slide. Now, size of nerves, it is important. Yes, adjuvant RT may be beneficial for patients with PNI. It shows that, but some says that like Bendwin, the large nerves more than 1 mm in diameter was a worse prognostic factor than PNI of small nerves. Next slide. Now, what is the Indian experience? The TMH experience. already explained beautifully, but few points in which they said that the perineural invasion is an independent prognostic factor in the oral cancer that warrants adjuvant treatment. And in this study, next slide, and this study shows that incidence of PNI was higher, around 20.3% in the tongue cancers. And patients with early node-negative oral cavity with PNI are more likely to develop recurrences and have mortality. However, the addition of adjuvant radiation in these patients showed improvement in the survival. This is one of the few studies directly comparing radiation with no radiation, giving improvement in the survival. And another study that is by Dr. A.K. Anand, and they have said that the significance of perineural invasion in locally advanced buccoalveolar complex treated with surgery and post-operative radiation plus minus concurrent chemotherapy. Again, next slide. Again, it is a study of 83 patients and univariate or multivariate analysis. PNI was found to be an independent adverse risk factor. Whether small, large, unifocal, multifocal, doesn't matter. It is an independent risk factor. And the patient with PNI positive disease had significantly worse 2 years disease survival, locoregional cervical overall survival as compared to the PNI negative disease. And they suggested that adjuvant radiotherapy should be offered for the patient with PNI positive disease with buccoalveolar complex cancer, irrespective of other risk factors. Some international studies like Jardim et al. They also they also state that, excuse me, previous slides also said that the multivariate analysis showed PNI to be an independent predictor for overall survival and the disease-free survival. The next slide, please. And same thing, Tai et al. Had shows that PNI was associated with poor disease-specific survival. These are some original and the international studies. Second, now what NCCN says. NCCN 2021 says in the case of CLIP, T1, T2 early cancer, positive perineural or vascular or lymphatic invasion, one should give radiation. Next slide. Now, if we see the oral cavity tumors T1, T2, the adverse feature with adverse features other risk factors, which includes the extranodal extension, positive margin, closed margin, T3 or T4, PN2, PN3 nodal disease, and PNI. If it's there, we should consider for radiation. Next slide. Even the ESCO guidelines. Now it clearly shows that patient with oral cavity squamous cell carcinoma, adjuvant radiotherapy should not be denied. The patient with pathologically node negative or PN without extranodal extension after a high quality neck dissection, unless there, this point to be the noted that unless there are indication from the primary tumor characteristics such as perineural invasion, lymphovascular space invasion, or T3, T4 primary. Next slide. So what is the take-home messages? PNI should be considered as one of the major poor prognostic factor. Presence of PNI needs to be considered for adjuvant radiotherapy. Now go to the first slide, please.
Please go to the first slide. Please go to the first slide.
In which as a point said, to make. Which I have said that even in this second.
Next slide, please.
Next slide. Even in these scenarios, though we have a T1 lesion, floor of mouth lesion, lateralized small lesion, but we have a PNI, one should advocate or one should give the post-operative radiation therapy to this patient. So these are the different studies and points in which I think I know that there is no hard to not very large studies, phase 3 trials to see whether we should give radiation or not give radiation. But seeing all these factors, one should not deny a patient for adjuvant radiotherapy. And because we know oral cavity, in oral cavity tumors, recurrence is a very big challenge to treat further. Now it's
Okay,
to
Dr. Manoj.
the
Yeah. But now we will give the opportunity to our first debater, Dr. Saurabh, for the rebuttal. What he has to say about it. Dr. Manoj, what Dr. Manoj has said.
So number one, Dr. Manoj has not shown any study which has only patient with the early stage, which we are debating. He has shown the studies where T3, T4, late stage tumors, most of the studies like that, except for one Tata study that I had refuted in the beginning only, because there were only 15 patients were there in the early stage where the RT was not given. So we can't take it at it. And he has shown that they have concluded that it may benefit. They have not concluded that it will benefit. The second thing, I agree with him that the lymph node metastasis chances are more. And I have shown in a study that the lymph node dissection, neck dissection should be done in the patient with PNI positivity. Third thing is he has shown the NCCN guideline, very important. In NCCN guideline, they have shared that the high risk factors are extranodal extension, positive margin, close margin, PNI, LVI, etc., etc. But when you see in the chart, in the NCCN guideline, they were definite that the extranodal extension and positive margin, they should go for RT or CTRT. But for others, they have given others criteria. So others means they should not be one criteria. They are including all other criteria, not only one criteria.
No,
only.
what
Otherwise,
I want to know how much
sir,
criteria?
this is
How
not
much criteria?
this is not
Which criteria you will consider for post-operative radiotherapy and which
sir, one
criteria you will
second,
not?
Okay. Okay, you will get, Dr. Manoj, you will get your time. Okay. Let him finish.
Yeah. The other thing, Max study he has quoted. I am from Max. I have not quoted that study. There should be some reason behind that.
That is a locally advanced. Okay. Yeah.
They were locally advanced, 85 cases. They were all locally advanced cases. There were no early stage cases. We are discussing early stage cancer, T1, T2, M0. Next, last he has told about the ASCO study, ASCO guidelines. ASCO just mentioned in one comment that if these factors are there, they should consider radiotherapy. And after that systemic review has come, which I have shown in the last. That has come because the ASCO has given this one. I have not shown complete paper because there was no time, but that paper start with that the ASCO has told that they have mentioned that the PNI should be, patient should be given the radiotherapy. So then they come with the systemic review.
Okay. I think, come on. Yeah,
and last is Thai study. I have also mentioned that he has just take out the slide very fast. In the Thai study, last they have given if you have done the neck dissection, there is no need to give radiotherapy.
Now, the thing is, Dr. Saurabh, there is no question of giving radiation in advanced disease. Okay. The thing is that because we do not have phase 3 trials of large studies comparing the early cases of squamous cell carcinoma in head and neck cancers between PNI positive and the negative, and with RT and without RT. Now, what we do, if we see all the scenarios, one thing is sure that if even a sole PNI is there, that is a poor prognostic factor. That is an independent poor prognostic factor that we all qualify, all admit that it is a poor prognostic factor. Now, what to do? Suppose what the patient I have shown that T1 and 0.
So Dr. Manoj, that patient which you showed, you gave radiation.
Dr. Mudit will decide now.
Yeah. So you tell me, Dr. Manoj, that patient which you showed, did you give radiation therapy to that patient or not?
Yes, I discussed this question to our tumor
Tumor
board
board, yeah.
specialty.
What did the tumor
Yes,
board say?
and definitely even surgeons and us, I am advocating because it is 2 days back, and even surgeon says yes. Now, because I don't want to have to with this patient the recurrence one, and it's better to give radiation one. The tumor board
Okay,
discussion
okay,
is
okay.
that one should give the radiation.
So please give it out of Manoj. I think you are biased because of your radiation oncology surgeon. If you go through the evidence, I think both of you have not quoted one of the largest study of from Rajiv Gandhi Cancer Institute, which is titled Oncological Benefits of Post-op Radiation in Node-Negative Early Stage Cancer of Oral Cavity with Isolated Perineural Invasion.
Okay.
Which has got 118 patients. Okay.
Okay.
So in that, they have answered the same topic which you are discussing, right? The same topic was discussed, and in that it's a retrospective study as compared to other studies. This is the largest study, Deepa Nair from Nair also, and in our study they showed that OS was not different, but DFS definitely improved in patients who underwent adjuvant radiation. So so it's like this. I think you missed. It was published in 2019. It was in British Journal of Oral and Maxillofacial Surgery. So,
okay.
So it says that, okay, in Indian data, if you say that benefit is there for adjuvant radiation for PNI, but I think if you go into detail about it, we need to go in detail about PNI. It's not, that's why if you say AGCC, they brought in things now. Like for ECS, they made it minor or major criteria. Same for PNI also, they made it, it's not the isolated PNI that PNI is there. That whether it's intratumoral PNI or extratumoral PNI, whether you have a number of this density, the density of the perineal invasion is there, or how much is it, more than 1 or less than 1, whether the nerve involvement is less than 1 millimeter or more than. So we have to go in detail. We can't just say PNI
Sir,
is there and we
I am very much convinced about these things, but the most of the times what we are getting reports from
so you have to ask the pathologist. Okay.
In our centers, does definitely we know and we quantified all these things, but most of the time when we got the HPR from the other centers and they did not.
So Dr. Manoj, let me ask Dr. Saurabh.
Yeah.
Dr. Saurabh, which patients do you think you will go for adjuvant radiation? Yeah, Dr. Manoj, just a minute. Dr. Saurabh, in your institute, what is your practice, and which patient do you think in this scenario you're going to give adjuvant radiation, or you will just keep this patient observation? In isolated PNI, if you say more than 1 mm, if you say extratumoral is there, so what is your take on that?
So it's very important to discuss the things, and you should be the panelist. When you discuss all the things, you will be much wiser.
Yes,
so
I am much wiser you have
today.
To become now. You are a clinician.
So I am
now.
much wiser today.
I am asking you
in which so multifocal more than 1 millimeter nerves, the radiotherapy should be given.
So now things have changed a little bit because we have come into the panel and we have read and we have talked about. So we know about that panel. This PNI is not small thing that the PNI, if pathologist writes and we go for it, we have to go in detail about it. So AGCC has told that we have to record it. Now pathologists can't go away like that. ECS now it's major or minor. So if ECS is minor, you can just, they have same OS like you have a normal N2 and 3 disease. But if you go to major, it has got a worse. That's why we are over treating these patients who are less than 2 mm. So they are recording the data. Still, the word is still not out. Same for PNI. AGCC also, they have started recording that all the pathologists, if you go to the CAP guidelines of the head and neck, they say that you have to record it now. They will not say, we can't institute the therapy till now. That's a confusion for the clinicians till now, that we can't institute the treatment. Like for ENE, if they have written ENE, straight away CTRT, whether it's 2 mm or more than 2 mm, it doesn't matter. Because once it goes to the tumor board, it's ENE means no guidelines are there what to do. Same for PNI. If PNI is the isolated one, in our institute, our radiation oncologists and everybody and our data is that they say we will give adjuvant radiation therapy.
I agree with that. My team, my institute has, when I told that this topic has been given to me, they said you will lose hands down. So, but I told them let me figure out the literature.
Yeah. So
Okay.
literature, so yeah, I think Dr. Saurabh has done a good work. Dr. Manoj, I think we are not denying radiation therapy because we are oncologists. We want everything to be done, but we have to have some evidence and something which really benefit, because we know that radiation is a very big tool for treating squamous cell carcinoma. So we should not lose that, because these patients are going to have second primaries, third primaries. So we should be very judicious in using it. So it's not that, so we have to now after reading, I think we have become wise enough what pathologist we have to ask that, okay, we have to tell in detail about the PNI. Then we decide on key adjuvant radiation to be given. And then, because there are certain patients who refuse and they do fine. And so, because if you see the Western literature, as Dr. Saurabh put, there are literature where they don't recommend radiation, but there are small series. So we can't do each and every, like ARES trial is there. For DOI, they're doing it. So if we can do something like a data, we have a data like a randomized trial, then we can give an answer, real answer to that.
Yes,
So I think
basically we
yeah.
should have a large data to answer this question, and that till then we should give the benefit of doubt to the patient, so that no patient should come with the recurrence. If we save 5 to 10% recurrence, then I'm very happy.
Even Virat Kohli didn't get the benefit of doubt yesterday.
Sir, can we move to the next topic?
Yes, I think Shubham will be. I think I congratulate both of the debaters. They have done a really good job. And I think we also, and who are listening, I think we become wise enough now that PNI is a factor, but we need to look into it deep. Yeah, we move on to next session now. Yeah.
Thank you.
Thank you.
Yeah.
Thank you.
Bye.
Thank you, Dr.
Thank
Saurabh.
you, respected speakers, for a beautiful debate. We move on to our next session, which is basically immunotherapy. The topic is immunotherapy is a better alternative than re-radiation for inoperable, previously irradiated recurrent head and neck squamous cell carcinomas. Now, NCCN does consider that immunotherapy is an option for all patients. It does say pembrolizumab with platinum and 5FU is a category 1 option on the basis of Keynote 048. But it does mention in the discussion that only for patients who have, no surgical or no radiotherapeutic option. So that said, let's move on to the debate. May I request Dr. Mudhaj Agarwal sir to please call upon the speakers for this session.
So I think Dr. Bhavat Chugh is there. He will speak for the topic that immunotherapy is a better alternative than re-radiation for inoperable recurrent head and neck squamous cell carcinoma. I welcome Dr. Bhavat Chugh.
Thank you, sir. Thank you, Mudhaj sir. So I'll start with sharing my screen.
Yeah.
You should be able to share your screen, Dr. Bhavan.
Yeah, I'm just trying that. 1 second. Okay. There is some. Can I just correct from a different one thing? I'll just come back in a minute. Sorry. Dr. Abhishek, you want to go first? I'm so sorry. There is some technical problem. I'll just come back in a minute. You can go ahead. I'll come back in a minute.
So let me introduce Dr. Gulia. Dr. Gulia is Associate Director of Radiation Oncology at JP Hospital, Noida, and he will be speaking against the motion. Dr. Gulia, you can actually go first then.
Yeah, all right, I'm ready. Let me begin with sharing my screen. So a very good evening, everyone. And as far as this topic is concerned, the topic is immunotherapy is a better alternative than re-radiation for inoperable previously radiated recurrent head and neck squamous cell cancer. And I am going to speak against the motion. To further dissect out the topic, I guess we'll be not speaking on the metastatic cases, although they are also inoperable in a technical way. And we'll be concentrating on the local and loco-regional recurrences, which can be operable, which is not the topic. And so inoperable, local and loco-regional recurrences is what we are going to debate today. What are the issues basically in this scenario? Now, the loco-regional recurrences are fairly common in 15 to 50% patients. The squamous cell carcinoma is very infiltrative and aggressive kind of a malignancy, and multiple factors have to be considered before we finalize a plan for a recurrent head and neck cancer patient. We have to consider patient factors, the disease-related factors, the prior treatment and its toxicities, and the reported survival, if we leave these patients untreated, is to the tune of 3.8 months median survival. The patients who are selected for and undergo are amenable for salvage surgery, the reported median survival is 21.5 months. For re-radiation patients, it is 8 months to 1 year. And then systemic therapy offers a median survival of 7 to 10 months. Now, do we have some recommendations? So thankfully, we have NCCN guidelines, our beloved guidelines. What they say about the recurrent and persistent disease, if it is a loco-regional recurrence after prior radiation and it is unresectable, then the option given is re-radiation with or without systemic therapy. Another option is listed as systemic therapy, but there is a rider. We have to see advanced 4, and when we go to advanced 4, it is clearly clubbed. These patients are clubbed with patients who are having distant metastasis. So all these advanced 4 and these systemic therapies are more or less palliative kind of therapies offered for distant metastatic patients. Now, so this leaves the option of re-radiation with systemic therapy. Any other recommendations? We do have ESMO, European Society of Head and Neck, and ISTRO combined guidelines published in 23rd October 2020, which gives us a table with a plethora of immunotherapy and systemic therapy combinations, including pembrolizumab, nivolumab, platinums. But when we go into the details, we can see these all options are for recurrent disease, which is not amenable to curative RT or surgery. So basically, if a patient is amenable to, if the curative RT is feasible, then we should go for curative RT first. We should offer that first, and then these therapies are to be offered. Do we have some Indian guidelines? Yes, we do have a paper published in 2014 in which there is a flow chart for our help, in which we have to classify whether the recurrence is loco-regional or systemic. And then we have to rule out any metastatic, we have to rule out metastasis. And then based on ECOG performance status, if the performance status is good, then the patient is resectable, patient goes to a surgery, but that is not the topic of debate. If the performance status is good, but it is inoperable, then the patient has to be assessed whether the previous RT was given more than 12 months ago or not, and the candidate is, whether the patient is candidate for re-radiation or not. And if yes, then the patient goes for re-radiation. If the candidate is not a candidate for, if the patient is not a candidate for re-radiation, then he goes for palliative chemotherapy with or without immunotherapy, as we can see in the first line options and other options. Do UK guidelines suggest anything different? So we have a 2016 paper, which is the official United Kingdom guidelines. And this also has a recommendation about this. So they recommend that chemo re-radiation appears to improve loco-regional control, may have some benefit for overall survival at the risk, of course, of considerable acute and late toxicity. Benefit must be weighed carefully against risks and patient must be counseled appropriately. Now we do have an Italian paper published as late as May 2021, in which there's a discussion about combining the loco-regional and systemic therapies. They also offer a flowchart illustrating the therapeutic options in recurrent head and neck cancer cases. And the loco-regional recurrences who are having favorable features should be taken up for salvage surgery, but that is not the topic of debate today. The patients who are inoperable should be taken up for re-radiation. They have category mentioned it as preferred modality of treatment. The patients who are not amenable for re-radiation can be taken up for various options like systemic therapy, like immunotherapy, chemoimmunotherapy, and etc. Now, what does actually re-radiation offer to these patients? So this is a published, I got a table from a paper in 2014. The late toxicity in these patients ranges from 9 to 29% to 35%, while the 2-year overall survival, which is reported, is 27 to 40%. Now we have newer modalities in re-radiation. We can offer SPRT as well nowadays. And does SPRT make a difference in overall survival? Yes, it does. The reported overall 2-year survival in SPRT is 41%. In a trial, it is 30%. 64% at 2 years, and 59% at 1 year. Now, the question is why none of the guidelines recommend usage of immunotherapy as a first line in locally or loco-regionally recurrent head and neck cancers, which are amenable to local therapies. Why nobody does that? So this is a very landmark trial, Keynote 48 trial of pembrolizumab in this setting. And the authors in this trial have themselves acknowledged that patients who are recurrent or metastatic and are not curable by local therapy are to be included for this kind of treatment. So same is the study Checkmate trial, in which also the authors have acknowledged that patients who are not amenable to local therapy with curative intent, and they've mentioned the local therapy as surgery or radiation therapy, they are to be included in this trial. And these therapies are to be considered for these kind of patients, because if somebody is amenable to local therapy, he goes for local therapy, which is surgery or re-radiation. Now, what does immunotherapy offer actually? Now, this is a table which shows that immunotherapy offers, as of now, it offers a dismal response to overall response, ranging from 13 to 18%. Now, does adding a second or third immune checkpoint inhibitors improve outcomes? We have studies like Condor trial, we have studies like Eagle trial, and other studies like Checkmate 714 trial, which are negative studies which have shown there is no benefit, unfortunately, even if we do a second or third checkpoint inhibitor. And last but not the least, the financial impact. So we have a plethora of publications on this aspect. This is a publication from Canada, which is a rich country, and they have concluded that as far as cost effectiveness of nivolumab in recurrent head and neck cancer is concerned, it is not cost effective. Another rich country, USA, University of Pittsburgh, reporting in 2018 that nivolumab was not cost effective for head and neck cancers. What does the Society of Immunotherapy has to say on this? So they have a consensus statement on immunotherapy published in 2019 on the use of immunotherapy in this setting. And they have in the answer of the first key clinical question, which is how should immunotherapy with PD-1 inhibitors be integrated into the treatment of recurrent head and neck squamous cell cancer? The authors have said that patients with recurrent disease who were considered incurable by local therapies, pembrolizumab was approved for frontline treatment of these patients. And they have also listed out the NCCN official guidelines list these agents second-line systemic therapy for recurrent metastatic head and neck cancers without a salvage radiation or therapeutic options. Now to conclude, for inoperable locally recurrent head and neck recurrence, re-radiation with concurrent systemic therapy is the modality of choice, offering a chance to achieve long-term survival in carefully selected patients. The treatment plan should be finalized in MDT after consideration of patient factors, disease factors, prior treatment, and its toxicities, and obviously economic profile of the patient. Immunotherapy offers promise, but certainly, as at this point of time, can't replace re-radiation in this category of patients as a preferred modality. Combining re-radiation, newer techniques like IMRT and SBRT with immunotherapy holds promise and needs to be further evaluated systematically. Thank you.
So, Dr. Bhuvan, are you ready?
Yeah.
Thank you.
I just
Thank you,
can't
Dr.
switch on
Abhishek.
the video. The administrators have to allow it. Yeah. Can you just allow me to switch on the video?
Yeah. It's all right.
Just a moment, sir. Just a moment.
And I think I can share the content. If you can, let me just try to share the content, please. Yeah. Thank you. Hi, good evening, everyone. I hope you can see my slides. So I think very well presented by Dr. Gulia, and he has, very smartly hidden the facts which he wanted to hide. So speaking in the favor of immunotherapy, around 15 to 50% of the patients of head and neck cancer, they recur. And, they can be local regional recurrences or metastatic. And as he rightly said, we are not talking about metastatic, and I will not. The options include re-surgery, re-irradiation, and systemic therapy. And obviously, he has spoken in favor of re-irradiation. And for an inoperable patient and to a novice, such as him, the option of re-irradiation may appear appealing. But that would have been the case in the 20th century, but sadly we are not in the 20th century. Even in that case, the chemotherapy, a double agent chemotherapy, would have given an OS of 7 to 9 months. And then came the era of EGFR targeted therapies, in which the extreme trial was there, and the extreme trial showed an overall survival of 10.1 months, with services 7.4 months without the addition of cetuximab. Yes, there were 82% grade 3 toxicity, but majority were myelosuppression, hypomagnesemia, and skin reactions. So why is toxicity important is because as we go down the slide set, we'll realize that what happens if we ever treat, or if we ever wish to re-radiate a patient. So in the current times where we are, and as he rightly said in a keynote 048, it changed the way the recurrent head and neck cancer was approached. There are durable responses, and then, yes, he did say about the overall responses. Now, what he needs to realize is, he being a radiation oncologist doesn't understand the way immunotherapy works. The response rates has never been a footprint of immunotherapy treatment. It's always the durable responses, and the way the immunotherapy works is it kind of gives you a very durable response. And I know that the data says for itself. The patient were obviously evaluated for tumors with CPS more than equal to 20, more than equal to 1, and the entire study population. And if you look at the data which was given to us, the patient who had pembrolizumab plus platinum and 5FU, 85% of patients who had a CPS of more than equal to 1. The 2-year overall survival was 35%. In a CPS of more than 20, it was more than 31. It was around 31% in the CPS more than 1. That is more than 85% of the population had a 2-year overall survival of around 31%, and the entire study population had an overall survival of 29%. So it's now in the data which he showed, I think the figures were all probably lesser than it was. And we looked at the only pembrolizumab, the safest of the therapies. The 2-year overall survival is around 38% with the CPS of 20. And CPS more than equal to 1, the 2-year overall survival with a single agent pembrolizumab is 30%. And the total study population is around 27%. And the adverse event rate, the grade 3 or above, it was 55% in the pembrolizumab group only and 85% in pembro plus chemotherapy. Now, what were the adverse effects? The adverse effects were anemia, which could be easily managed. It was neutropenia, which is, I think it's a domain of every medical oncologist to manage the neutropenias and thrombocytopenias. It was fatigue, mucosal inflammation, and stomatitis. Now, re-radiation. It heavily depends on patient selection. You cannot go ahead and treat everybody. Tumor is radio-resistant if it recurs in 6 months. And I think he'll have to be honest in telling us the word curable. He kind of showed 3 trials, where in all of the 3 trials, it said that the patient do not have a curative intent. And I think he needs to be honest when he says curative intent is something which is really not available. Curative intent is not possible before 1 to 1.5 years. And sadly, mostly 60% of the patients recur within 1 year, and more than 85% recur within 2 years. So when you say that the patient has a curative intent when they give re-radiation, I think that's not entirely true. There are issues with tumor volume and dose distribution. The dose required is more than 50 gray to yield a substantial response and to have a meaningful effect. And then there are comorbidities, there are feeding tube dependencies and wound complications. And if you look at the outcomes to it, the outcomes of re-radiation at a 5-year overall survival was 20. This was before immunotherapy, by the way. It was 22% with the CT, 19.44% with the radiation. CTRT had a 22.7%, and yes, a re-surgery had the maximum survival. Now, if you have the pooled analysis for it, the RTOG 9911 had a 2-year overall survival was 26%. The pooled analysis, so it's all somewhere around. So if you look at the keynote trial which you have, there's a 2-year overall survival is 29 to 38%, and all the other trials which had a re-radiation in them, the overall survival was around the same thing or lesser. And then there is toxicity. Oh my God, how can you live with a carotid blowout? There is osteoretinal necrosis. Then there is orogutaneous fistulas. There is permanent feeding tube dependency. And there is a trismus. If you look at the toxicity of it, I really can't imagine somebody doing this to a patient. And these are not rare. There is a 75% risk of grade 3-4 toxicity. RTOG 9610 reported 9 to 11% deaths due to the re-radiation, and the grade 3 to 5 toxicity was 33%. Only radiation also results in around 30 to 40% severe toxicity. And unlike this toxicity seen in systemic therapies, this is distressing, it's troubling, and it hampers the daily life. there's a very poor quality of life left. So the take home is, with the recent development, there is hardly any role of re-radiation. So you may consider it in elderly, with patients who have high comorbidity index. Then also in those also single agent pembro is a better option. And there is a significant troubling toxicity with no effective way to prevent it. So where would I give re-radiation? If the patient has recurred after 2 to 3 years, you may want to call it as a recurrence. I may just choose to call it as a second primary. It's small size. It is somehow still inoperable. It's away from the vital structures such as cord. And the patient is a frail elderly patient with a high comorbidity index and has contraindication to immunotherapy. I think for everything else, you should sincerely try immunotherapy plus minus chemotherapy. That'll be from me. Thank you.
I think, thank you, Dr. Bhuvan. Dr. Day is there or is not there? Shubham?
Sir, he's
Dr.
not there,
Shri-
but Dr. Pawan is there.
Okay.
There is an interesting question actually by Dr. Nitesh that you can take it at the end also.
Yeah.
That I think you can take the discussion forward, sir, but do take that question.
Okay. So just a time for Dr. Abhishek for a rebuttal, what he says about what Dr. Chugh has said. Abhishek, are you there?
Somehow I'm not able to switch on my video, but
No. Yeah, we are hearing you.
Yeah, I congratulate Dr. Bhuvan for making a case out of no case. He did a very good job actually. All the guidelines against him, even the Immunotherapy Society guidelines against him, the NCCN guidelines, which is often quoted against him, everything against him. But I'd like to stress upon the fact that basically when we quote about TOG 9610 study, which was a landmark study in re-radiation cases, what they did in that case was they did a twice in a day kind of radiation. So that's how the toxicity was significantly high. And when we talk about the grade 3 and above toxicity, it's not only radiation which does this. The chemotherapy and immunotherapy are equally, or in fact, they're more potent in delivering these kind of toxicities. In fact, in Keynote trial 048, the P plus pembro plus chemo regime had a grade 3 and more toxicity of 71%, which is very high then as compared to a 65%, which is still lower as far as radiation is concerned. And definitely, I saw the question Dr. Nitesh posed in that chat box. Why not combine this? So this was so since it's a debate, so I couldn't emphasize on this part, but definitely the last conclusion remark was that both the modalities should be definitely combined. We are not competitors. We are like collaborators. Nobody would want patient to have unreasonable toxicities, neither you nor me. So we should combine. The best way is a combination, I guess. Thank you.
So I will ask both of them because it's a debate. So you can't. You have been given a topic, so you have to say for or against for it.
I don't have to say all the guidelines. That's the gods.
Yeah. So Dr. Abhishek, I will just ask you the practical scenario. So in your clinic, which are the patient who goes for? How do you choose for patient for re-irradiation, and which patients do you think that the immunotherapy should be given?
So the patients who have a considerable time from the last radiation, I consider that one of the most important factors. Some people in the conventional teaching, it was like more than 12 months should be there, but now we are sort of deliberating with playing with SBRT. So even after 6 months, I think I can consider that. But while considering that, I have to see the toxicities, the conditions of the tissue, how supple is that, how much is the fibrosis, what is the weight of patient, the performance status, whether he's able to eat, how much the toxicities the first treatment has left. And obviously the first chance goes to the surgeons if they can take it out. In that case, I'd like to go for adjuvant radiation. But if it is not operable and the tissue condition is good, the patient is eating well, performance status is good, there is a 6 months gap between, at least a 6 months gap from the last radiation. And so much so that if the gap is still 6 months, and sometimes what we do is we do a systemic therapy to buy more time. We go till around 12 months, and then we try to integrate this systemic therapy and local therapy.
Any role of proton therapy, because now proton is there. So what do you suggest about that?
So as far as the biological effectiveness of proton vis-a-vis photons is concerned, photon is what we, the lesser mortals, all of us use. So it is only 1.2 versus 1. So it's not very different. But yes, proton does has a role. But when we use SBRT, it is more or less equivalent.
Okay. So, Dr. Pawan, any comments from your side?
Yeah, I just wanted to ask another important thing. Like it was a wonderful presentation by both of you, Bhuvan and Abhishek. And it seems both of you are on the winning track, but and it's a debate. So one have to suggest better, which is a better modality. But just one thing that I also wanted to ask Abhishek, how about this brachytherapy? Like in certain cases, can we go for brachytherapy as a re-radiation modality? The other thing, like about the photodynamic therapy, if any one of you would like to suggest as a modality of treatment for this recurrence patients.
Yeah, so brachytherapy is definitely a very good modality to deliver the radiation dose. In fact, when we talk about SBRT and protons, I must say that brachytherapy is the most conformal way to deliver radiation. Although it does require a skill set and a technical expertise, but as far as most better way to deliver a high dose without any spillage to the normal organs is brachytherapy, followed by proton therapy, which is more or less equivalent to SBRT. So that is the sequence I see it. And about photodynamic therapy, I'm sorry, I don't have any, I don't have much knowledge on that.
So I just have a comment to make here. So sorry.
Yeah.
So
I was asking you only. Yeah.
So there were 2-3 points which so obviously if you can have a curative intent, there's nothing like it. And I sincerely think that a local modality which can give you a curative intent, there's nothing like it. But then a lot of many times radiation oncologists, when they try starting it, they go with the intent of curative, but then with the, it's not unusual when they end up having some kind of residual disease left. So when that residual disease is left with the toxicity which we are giving to the patient, and that's what the concern is. And then the patient has to be on a systemic therapy for a rest of the life anyhow. So I think that's where my concern lies, and that was the one concern. And then the other thing was the risk of metastasis in a recurrence. So when somebody has a local recurrence and we try to irradiate it and give it a cure, how sure are we that we should not be giving them any systemic therapy after that? And what I couldn't find the literature on the risk of metastasis in a patient who has had a local recurrence. And is the RT good enough for that? I think that's what probably pulls down the overall survival in such patients. That was second. And I think the third part, which, yes, I read Dr. Vinita's comment that I had a biased view, but ma'am, this was the data which was there. It's not biased. I think the authors and the editors are biased these days. But yes, with SBRT coming in and the IMRT coming in, the overall toxicity has gone down. There's no doubt. But coming to it, I think my only thing is with the durable responses immunotherapy is showing, I totally agree with Dr. Nitesh that it's RT and aside from the debate, it's radiation plus immuno combined, that'll be the way forward. But for the sake of the debates, I think this is where it is and this is what should be. And I sincerely think the curative intent should not be given off. But if you're not sure you'll be able to give a curative intent, I think leaving it to only systemic therapy and bringing the case to the tumor board is a better way out than simply re-radiating.
I think that's the way forward. Yeah, that's what Dr. Bhuvan and everybody agrees. I think it's a combined treatment which has to go forward. So anybody has the experience of electrochemotherapy in this one? Because this was one of the things actually Dr. Dev was trying it out in All India Institute, that giving a local chemotherapy injections and with electric currents, some special machine is there. So I was seeing one of the Abhishek Gulia's guidelines when he was showing it, that European guidelines, in which one ECT was given, electrochemotherapy. So it was one of the in palliative setting it was there. But it is, I don't think so. Dr. Dev has tried in few cases. We tried in one cases, but we failed. In recurrent cases of scalp tumor was there, but we failed in that. So any comments? I think what we have discussed around here is immunotherapy is there, like in practically what we follow is where local therapy can be given. I think local therapy is always a preferred modality, but if we can combine both of them, it is very good, like immunotherapy. So same thing for surgeons, as we in salvage setting, when we do surgery and we again find a T3, T4 tumor, we don't have any adjuvant treatment to give because we don't have data, because radiation cannot be given. It's less than 1 year. They will not give chemotherapy. Medical oncologists will put forward that we have no data. So you just, if patient recurs again, then we'll give chemotherapy. That's what's the answer we get. So I don't know, because in salvage setting, we don't have really adjuvant treatment to support us. That was the thing. And same, I think, for re-irradiation also to support immunotherapy after that. How is the data there? Bhuvan?
Sir, again, there's no data because the immunotherapy came in like 2019. I think the data still has to evolve in that.
Okay. So I think I thank both of the speakers. They have done a great job, and both have stuck. And now we have come to the conclusion that we are all friends together and tumor both.
we are all friends together, and we can meet up for a drink tomorrow at Radisson at 2 o'clock. For the physical session. So I just reiterate my invitation to come tomorrow. Dr. Mudit will again be seen as a panelist now for a robotic surgery. So he's a multifaceted personality. And thank you so much, Dr. Mudit and Dr. Pawan for chairing this session, and Dr. Abhishek and Bhuvan and Dr. Saurabh and Dr. Manoj for being such interesting panel. You know, we made it a point to make it a cross specialty discussion. You know, it was always surgery versus radiation, radiation versus surgery. We never kept two topics of the same specialty just because we wanted to make it more and more spicy. And when we say biases do creep in, they do creep in. And that is why the tumor board is so important, where we keep each of us in check. With that, I conclude this session. Thank you so much, Dr.
Thank you.
Everybody for joining in. Thank you.
Thank you, Shubham.
Thank you, sir. Thank you.
Bye.
Right.
Thank you.
So yesterday, when we were discussing lung, we had an opportunity to discuss about non-small cell lung cancer, and somehow, somewhere, somebody mentioned that small cell lung cancer is missing, and we have not discussed that. But we were very thankful to Astra when they actually suggested us a topic where we would talk about the experience on using durvalumab in extensive stage small cell lung cancer. And to share that experience, we have with us Dr. Deni Gupta from Dharamshila Narayana Super Speciality Hospital. Dr. Deni is a senior consultant in medical and hemato-oncology department at Dharamshila, and today he'll be sharing his experience on durvalumab in the extensive stage small cell lung cancer. Dr. Deni, sir, please, you can share your slides.
Yeah. So thank you, Shubham, and organizer, and obviously AstraZeneca for giving me this opportunity of speaking in such a large forum. So here we are going to discuss another IO, that is durvalumab, and its role in the we know that there is a role in small cell lung cancer limited stage after giving the adjuvant treatment, even in non-small cell. But here we are going to discuss extended spectrum small cell carcinoma, where we don't have any newer data emerging, but of late we have this newer IO durvalumab, which needs to be given in combination with the standard chemotherapy combination, that is platinum and etoposide. So we will be discussing the role of durvalumab and some trial point, starting with the case. So here we have a case, a 35-year-old gentleman who presented in June 2020 with a complaint of change in voice, which slowly progressed to aphonia or dysphonia, and there was no comorbidity. Smoking history was there, and then he visited some ENT specialist, and he was diagnosed with vocal cord palsy. And then he underwent CT scan, brain, head and neck, and chest. So in August 2020, that CT chest showed small, mild enhancing tissue, soft tissue, with surrounding fibrosis in left apical segment of the lung part, and multiple conglomerate necrotic lymph nodes in the hilar and paraesophageal. So aortopulmonary window also showed nodal mass compressing over the left pulmonary artery. So what happens quite commonly in our country, based on this CT scan finding and patient complaint, so he was immediately started on ATD. Howsoever, his condition worsened, and he also had an episode of seizure in September, started on anti-epileptic drug, follow-up MRI brain was done, in which it was done in October 2020 only, and in which they have shown that around 2 centimeter to into 1.9 centimeter size marginally enhancing intraaxial lesion was there, in the right temporal lobe with surrounding edema without any appreciable mass effect. Apart from that, there were multiple subcentrimetic lesions in the bilateral temporal and frontoparietal occipital lobe also. And then CT chest was also repeated, in which they saw that there is a mass lesion in the left upper lobe with mediastinal extension and encasement of left pulmonary artery. Along with mediastinal lymph node were there and some consolidation in left upper lobe. And these were the PET CT scan pictures, in which we can see that there is a huge local growth going into the mediastinum, and opposite lymph nodes are also enlarged in the hilar area. So this was a PET scan picture along with the MRI finding, where there is a lot of edema along on MRI brain, and lung biopsy have shown the small cell neuroendocrine carcinoma. PDL1 was also done, TPS 3 to 4, although this was not relevant in this case also, as such. So final diagnosis was made of small cell lung carcinoma with brain metastasis. So it is an extensive stage. And what do we do next? So there were three options: either straight away to go for brain radiation and then followed by systemic therapy. Second option, we have only chemotherapy. Third option is chemotherapy along with IO, that is durvalumab. So there was a paper publication last year only, how we can go ahead in this scenario where the small cell lung cancer with brain metastasis we come across. So there was some conclusion of this study. If patients are asymptomatic, so chemotherapy alone is the most commonly recommended regime. Limited brain mets, so higher preference still is for the chemo. But patient is symptomatic with the brain mets, so whole brain RT is obviously we give first, then followed by chemotherapy. So this was the most commonly followed regime. Even if you see the NCCN guideline, latest guideline is 2021, any patient with extensive stage comes with the brain metastasis, if it is asymptomatic, we can still administer systemic treatment before giving brain radiation. But patient, once he is symptomatic, so we have to give brain radiation first before completing our systemic treatment. Regarding chemotherapy options in extended spectrum small cell lung cancer, we know that there was an old age regime, that is CAV. After that, we have with us platinum and etoposide combination. So there were a lot of study design in the past, and all the study design we can see that EP was compared with CV, with CEV, IP. So all these trials have shown that median overall survival in these settings, we were not able to cross around 10 months or so. So, and overall response rate was also limited. So this particular case, he was started on chemotherapy in November only with the standard doses of etoposide and cisplatin. And then radiation was also given to the brain with hippocampal staining followed by the 9-day pulse section to the gross lesion. If we talk about the what is the standard option as per the NCCN guide in this stage, whenever any patient small cell extensive stage comes to us, so they have given the preferred regimen labeling to the combination of IO with the chemotherapy. So there are three options they have mentioned: carboplatin, etoposide, along with atezolizumab is the category 1, obviously followed by the maintenance atezolizumab. Second option they have given same chemo along with durvalumab, followed by the maintenance. Third option, we can replace the carbo to the cisplatin. So these are the three preferable options, and all these three have got category 1 recommendation. Other recommended regimen they have given without IO, which we were following most commonly. Regarding radiation, I think this is a newer emerging concept that any patient extensive stage have minimal residual disease, no extra thoracic bulk elsewhere. So definitely we can consider local RT to the chest also, and with a limited doses, around 30 grain 10 fractions. So this particular patient, after this chemotherapy durvalumab was added in the standard of 1500 milligram every month. The role of this immunotherapy durvalumab, which we are discussing, a little bit of mechanism if you see that how they are acting. So we all know that now these are not new immuno-oncological drugs. Once we give the chemotherapy, there is a cytotoxic drug. So when there is a tumor cell lysis, so these antigens, tumor antigens are released and they got exposure to the immune cells. We know that there is PD-L1 overexpression over the tumor cells, and when they get engaged with the T cells with some co-stimulatory signals and other things, so there is a decreased immunosurveillance. Whenever there is decreased immune surveillance, so tumor gets aggravated. And once we inhibit this third part, if once we give the inhibition by the PD-1 or PD-L1 inhibitors, so we can restore this tumor-specific T cell immunity, and thereby reversal of immune suppression is there, which leads to the deeper and more durable systemic anti-tumor response. So to corroborate this like approval of this new drug, there was a landmark study that was a Caspian study design, which was phase 3 global randomized open label study. And inclusion criteria: treatment naive extended spectrum small cell lung cancer patient were taken, PS0 or 1. Asymptomatic or treated and stable brain metastases were included in this study, with the life expectancy of more than or equal to 12 weeks. Obviously, with the miserable disease as per RECIST version 1.1, roughly 800 patients were taken into this trial, and they were randomized into 1:1:1. One arm, upper arm was durvalumab along with some investigation rate plus EP, followed by only durvalumab maintenance, same dose, 4-weekly interval until progressive disease. So this investigation drug was anti-CTLA-4, that is temozolomab. Although data have not come in favor of this combination, so we are discussing only this second arm, that is durvalumab plus etoposide and platinum, and followed by durvalumab maintenance. So third arm was standard etoposide and platinum combination up to 6 cycles, and then followed by optional PCI as per the physician discretion. So primary endpoint as per this trial was overall survival. Secondary endpoint, they mentioned progression-free survival or response rate, safety and tolerability, and patient response outcome. So what was the key points, salient point in this particular trial? That this drug was added with chemotherapy from the very beginning, given for 4 cycles, followed by maintenance until progression as a maintenance sort of treatment. So second point was, highlighting point was that they allowed either of the platinum to choose, either cisplatin or carboplatin, which we are deciding based on the patient performance condition or various comorbidity. Third point, they said oral survival, which was the final primary endpoint. Control arm could receive up to 6 cycles of platinum etoposide, which is also as per our real practice, which we are doing. Optional PCI was offered to the control arm, not in the IO arm. Asymptomatic as well as treated and stable brain metastases were included. So we know that these IO are known to cause a prolonged durable response. So the question arises, is this 1 year OS is good enough to make this treatment choice a sustained and durable response with IO? If we see the other arm, there is the other arm, another IO, that is atezolizumab, as per IM power 1333. So 1 year OS data is almost similar, but the difference with this new IO, which we are discussing, durvalumab, 2 year OS data is also there, which is roughly around 23%. And of late, 3 year data is also published, presented in recent conference, that is roughly 70.6%. And we don't have any data as per the atezolizumab. So as I said, this was the latest presentation, ESMO 2021, this year only, in which they have shown that 3-year outcome. So median follow-up in these patients was around 40 months. So we can very well see that patient at 1 year, the upper one is a Kaplan-Meier curve in this blue line is showing at 1 year, there is a difference around 12% difference. At 2 year timeline also, there is a 10% difference. At 3 year, if you see at 36 months, 5.8% oral survival with the only chemo arm, as compared. On the other hand, 18% with the IO combination with the chemotherapy. So 3 times higher oral survival at the 3 years. So OS was sustained, and it is the only approved IO to demonstrate 3-year oral survival in extended spectrum small cell lung cancer. Apart from that, they have analyzed those patients who have brain metastasis at the baseline. So in those patients also, this combination of IO with chemotherapy this has consistently improved overall survival as compared to chemo alone. On the left side, if you see that with brain metastasis, blue line is above. It's roughly 3 to 4 months higher than the only chemo arm. And if we without brain metastasis, also this is better in the median overall survival response. If we see the overall survival subgroup analysis, so this forest plot is showing whether patient has brain mets or not. The response is in favor of durvalumab only. Apart from this brain metastasis, if you see the other subgroup also, either male, female, or various geographical variation, Asian versus non-Asian, all are favoring the durvalumab combination. If we see the objective response rate, which was a secondary endpoint in this particular trial, there is also 10% difference in the durvalumab combination over and above the EP. On the other side, this curve is showing that once the patient has got some response, so how much durable is that response? So at 1 year, we can see that the lower curve is showing 6.3%. With the chemo alone, upper one is showing that 22.7%. So much higher durability is there with the IO combination. So again, back to this particular case, he has received radiotherapy, chemotherapy, immunotherapy combination. After this, they have done the follow-up PET-CT scan, and in which we can see that whatever gross disease was there in the lung parenchyma infiltrating to the mediastinum or hilar lymph node, they all have gone. Even brain metastasis, this parenchymal lesion is not there. And on follow-up, at last follow-up in April 2021, so he has received up to 10 cycle of immunotherapy. And after this 10 cycle, again, there is a decrease in the size of area in the brain, as well as in the lung parenchyma. So these are some of the difference, because we have 2 IO only which are approved for this subset. The one is atezolizumab as per the IM power 133. Another is durvalumab as per Cashman study. So what are the differences? So in both trials, biomarker selection was not required. So we don't need to do any study like PD-1 or PD-L1. And brain metastases were included in this Caspian study, but they were excluded in IM power. And PCI were allowed in control arm in both studies. In the experimental arm, means the durvalumab arm was excluded, although PCI was allowed in IM power 133, and up to 6 cycles were allowed in this Caspian study, but in IM power only 4 cycles of this chemo was allowed in the control arm, and cisplatin was excluded. Only carboplatin was allowed in IM power, but these platinum were allowed in Caspian study. So these were the difference as per these 2 trials, making it a more favorable trial which we can adapt in our day-to-day routine practice. So to conclude my talk, so first line durvalumab along with etoposide and platinum has shown sustained improvement in overall survival as compared with a robust control arm that is reflective of real world scenario which we are practicing quite oftenly, that is 6 cycle of EP, and then use of PCI was as compared to results in the other study. This is the only IO that provides flexibility of choosing the cisplatin or carboplatin. Benefit with this combination was observed across all subgroups, including the brain mets group. More than 17% patients are surviving even after 3 years, showing the prolonged survival benefit. Maybe we will get longer data in due course of time that this combination provided higher response rate. And this durvalumab offers convenient once monthly dosing regimen in the maintenance phase, only 4 weekly. So safety finding remains consistent with the known safety profile of durvalumab and etoposide platinum combination. Thank you. So back to the organizers.
So, sir, just a question that how much Durva you are now using in your practice for patients with SCLC? I mean, the number of patients which are on presently with Durva in your setup.
Frankly, I have only 2 patients right now. One is with after CTRT, which we are giving, 1 approval. Another approval is small cell lung cancer extensive stage. So we are not having much patient. Still, we have 80 to 90% of patient practice we are still stuck to the standard practice, only chemo only. So only right now I have only 2 patients.
Right, sir. Dr. Nitesh, are you around? No worry. So, sir, what about the toxicity profile for Durva, especially in Indian patients? Because some of our patients who have been on Durva, they do not tend to complete it. So I'm not talking about the financial toxicity, but because patients start it only once they have those funds. But what about the toxicity profile in your set of patients?
See, I have seen durvalumab. Currently, I have having 2 patients, and before that also. So I don't have much data, but yeah, 5 or 6 patients. So I have not come across any toxicity like that. I have to stop the durvalumab. Although small cell extensive stage, it's the first case only for me. So, but in adjuvant, which we are giving for only 1 year, there is no toxicity issue as such.
Right, sir. Right. And what about immunotherapy along with the chemotherapy? Does it have added advantage in this set of patients? Adding one more drug to Durva.
Yeah, definitely. I've shown the data Caspian study. So we are experiencing also that although they are very chemosensitive tumor, but still, if you see the over response rate also and durability, response is also higher. Or survival, we see the data up to 3 years. After 3 years also, still ongoing only, as per the Kaplan-Meier curve. So I think it's definitely adding much benefit over and above the chemotherapy. It's there is no doubt there about that.
Right. Perfect, sir. I think this is one place in lung where we are seeing a lot of development, and both with the EGFR and immunotherapy making good strides in treatment of advanced lung cancer. I must say that EGFR is making a good strides even in early lung cancer, that we are seeing a lot of survival improvement in survival, and I hope it goes the breast way. I am a strong believer that if any survival benefit that we are going to see in lung cancer, it is going to be because of medicinal therapy. By medicinal, I mean in form of new drugs, in form of better drugs, in form of better affordability and availability, accessibility of drugs, because this is what has happened in breast also. Drugs have made all the difference in the usage of availability of treatment from 2012 when we started our training. Trastuzumab, the HER2 positive inhibitors used to be very costly and we had to super select patients, but now it is a thing which is given to every patient, every eligible patient. So I personally feel that all the survival advantages that we are going to see in lung will most likely be due to addition of new medicines in the treatment. Thank you so much, Dr. Denny, and we are very thankful to Astra for giving us those insights from Dr. Denny. Thank you so much.
Sure. Thank you so much.
Thank you. With this, we'll move on to our next session. We have covered peds, hemat, and we have covered head and neck, and now we are moving down. We are going down to the thoracic cavity, thoracic space. One point has already been covered by Dr. Denny, where we spoke about extensive stage small cell lung cancer. But now what we have is a metastatic NSCLC, and just like what we saw in a setting where we gave Durva post CTRT, we have an option of giving upfront chemo IO versus doublet IO. And to speak in favor of upfront in favor of doublet IO, we have Dr. Manish Singhal. Dr. Manish Singhal is a medical oncologist, senior consultant at Apollo Hospitals, New Delhi. And to defend upfront chemo IO, we have Dr. Bharat Vaswani, who's a senior consultant hematologist and medical oncologist at Yashoda Cancer Institute, Secunderabad. So can we have first Dr. Manish Singhal, sir, please? Dr. Manish?
Yeah, hi.
Hi, sir. Hi, sir.
Just give me a moment. Let me sort out my slides.
No problem. No problem. I think we are ahead of time for a change by a minute or so. No problem, sir.
Okay. One second, just a second. कंप्यूटर बंद होगा देता है.
I hope it's not a patient who you are shushing, sir.
The slides are visible?
Yes, visible.
Yeah. So thanks for giving this opportunity. Honestly speaking, IO chemo is the new way of thinking in while treating advanced non-small cell lung cancer. And I have to defend something which I don't do. So it's always, very heartening to read about something which you don't believe in much, but then you while preparing for a subject like this, you get to know something which we would not have known otherwise. And there is definitely role of an IO-IO combination in advanced non-small cell lung cancer. Of course, it's not for all comers. There is a merit in both the ways of treating, but there are certain insights which I would like to throw upon and enlighten our other members about the role of IO-IO in advanced non-small cell lung cancer. So how do we decide upon therapy made for patients with advanced non-small cell lung cancer? Of course, disease stage, the histology, the presence of targetable mutations, the PD-L1 expression, and other patient-related factors such as the goals of therapy, the preference, the history of autoimmune disorders, overall health status, organ dysfunctions, and organ functions. So a lot of things which go into the mind of a treating oncologist before we decide upon therapy. So if you look at the first-line treatment options for advanced non-small cell lung cancer, and the NCCN guidelines does support the use of IO drugs with chemotherapy as far as treatment of advanced non-small cell lung cancer is concerned. It does give you an option of treating certain patients with Nivo-EP combination, and it does, in parentheses, describe in special circumstances or in special cases that this can be considered as IO-IO combination. So who are these special cases where one can consider IO-IO combination? The other standpoint of using an IO chemo combination is you never know what is the proportional benefit of chemotherapy vis-a-vis IO drug, because you are giving a combination therapy, so we don't know the proportional benefit of each of these agents. Moreover, I feel that it may not be cost effective also, because it is possible that the patient may not be harboring any benefit from an IO drug, but still is spending on the IO drug, which is quite costly. And ultimately, you may come to know that it was only the chemotherapy part which was working and not the IO drug. In an IO-IO combination, the benefit is that you know that you are depending only on an IO-IO combination and you're keeping chemotherapy for a later date. So there are definitely merits of considering IO-IO from that perspective also. Nonetheless, these are the various clinical trials and progression-free survival hazard ratios for various combination immunochemo combinations. And we know that the PFS stands strong at 0.45, 0.6, which is like 40% reduction in the risk of progression. And the overall survival also stands at around 0.56, which is again almost about 40 to 30% risk reduction in terms of demise. So the FDA approval stands strong, and we know that it is there. But the IO-IO combination, which was studied in the Checkmate 227 study, which had two parts. One was in the PD-L1 more than 1%, one was less than 1%, and they subdivided these patients to Nivo-EP in both the arms, versus histology-based chemotherapy or histology-based chemotherapy plus an IO combination if it was less than PD-L1. So there is definite very large, robust data set regarding an IO-IO combination. Now let's look at the 4-year overall survival of PD-L1 expression. This is one study which has one of the longest overall survival curves. which stand quite strong. So irrespective of the PD-L1 expression, what you see over here is a very strong overall survival curve of around 30% for the more than 1%, and which is around 24% at 48 months, which is standing quite strong at 24% median overall survival. So this is one of the longest survival, and it's not very starkly different between more than 50% versus less than 1%. So it highlights one very important aspect, that the median overall survival is quite well preserved with an IO-IO combination, even at 48 months, with median overall survival standing at around 24% for less than 1%. And for those who are more than 1%, it's 29%. For those who are more than 50%, it's 37%. That is one out of 3 patients is a long-term survival. Yes, safety concerns are there. We all understand that IO-IO combination does entail a lot of safety concerns, and there are patients who will encounter grade 3 toxicities, and one may have to discontinue therapy, and we'll talk about this later also. Coming to immunotherapy options for advanced non-small cell lung cancer with high PD-L1 expression, and these are just to put into perspective, the overall response rates in the IO alone with pembrolizumab, atezolizumab, cemiplimab is almost around similar, but I have to defend the point of IO-IO. It stands at around 45%, with the median duration of response being slightly in favor of the IO-IO combination in 227, in the checkmate 227, and the median overall survival is in excess of 20 months. If you look at what is happening in PD-L1 negative population, we have data from the checkmate, the keynote 189 and 407. Yes, the 2-year overall survival mark is 39 and 30 months, which is slightly lesser with IO-IO combination. But if you look at the long-term survival at 48 months, it is standing strong at around 27% and 39% for high PD-L1 expression, and low, it is around 25%. So 1 in 4 patients. So this is the overall survival curve of PD-L1 more than 1%, it is 29%. And we don't have that long follow-up data for other studies. For more than 1%, be it non-squamous and squamous, it is again 20% and 32%. And even for less than 1%, it is around 25% and 22%. So it is standing strong for both non-squamous histology as well as squamous histology. And you know that you are depending on only IO-IO combination. You don't know what is the proportional benefit coming from either chemotherapy or immunotherapy. If you look at the keynote 189, which is perhaps the most talked about study over here, is PD-L1 less than 1%. You see that perhaps the PFS is not really improving with the addition of immunotherapy. Yes, overall survival is, but we know that overall survival is dependent on post-progression therapies. And we don't know how this immunochemotherapy makes the post-progression therapy work better in those patients who have been exposed to immunotherapy. So it's the post-progression therapy which is leading to overall survival improvement in the keynote 189. And when we talk of less than 1%, we are talking of almost 50% of the total population of lung cancer. Whereas in the checkmate 227 study, we have seen that be it be 1%, be it be less than 1%, be it be more than 1%, be it be more than 50%, the 4-year progression-free survival is quite robust. Nivo-EP 14%, more than 50%, it is around 20%, less than 1% is around 12%. So it is standing quite strong even for less than 1%. And this is the duration of response. Again, for more than 1% and less than 1%, the duration of response seems to be standing strong at 38% and 35%. So if you're a responder, then you're likely to be a responder for long duration. And we have data up till 48 months. We talked about the toxicity. Yes, there are certain concerns about toxicity, but even if you are a discontinuer, if you have discontinued therapy because of toxicities, you're likely to behave even better than those patients who are continuing therapies. So those patients who had discontinued therapy at 48 months, their median overall survival is even better. That means toxicity may be a biomarker of long-term response. So one need not be afraid of toxicity. We need to understand how to manage the toxicity, but toxicity cannot be the only concern. So to quickly conclude, I think it is definitely an option as a non-chemo option, especially in patients like renal failure. We know that platins and pemetrexed cannot be given in patients who are renal failure patients. PD-L1 negative patients, squamous patients, because the squamous data is not that strong with IO chemo combination, and we know that IO-IO is something which can re-trigger immune response, and long-term survivals are better off with squamous histologies. Elderly patients, low disease burden patients, those who have limited symptoms, and smokers, where IO-IO combination can really make immunotherapy work better, and those who have brain metastasis. So this is the population where IO-IO combination definitely holds ground. With that, I thank you for your kind attention, and over to the organizers.
Manish, can I ask a quick question while we are
please.
waiting? So, has anybody done the same calculations with smokers? Because you brought up the question of smokers, but my feeling is when it comes to IO and that long-term survival curve, especially not crazy large volume disease, actually smokers IO may, I think we're taking back from RCC kind of thing that highly immunogenic tumors may be very long-term survivors on this. What's your view on that?
So, no, the problem is nobody has compared an IO alone with IO plus chemo. So we don't have that, or a IO chemo combination. So we know that if the patient has been a smoker, they're likely to have more tumor mutation burden, or the tumor mutation burden did not come out as a biomarker of response to IO. But the basic concept of smoker causing or smoker being a biomarker of response to an IO drug was based on the hypothesis that they have more tumor mutation burden. But tumor mutation burden as such was not a successful biomarker in the Checkmate 227. So we don't know what's exactly happening, but that's where I think is that these patients definitely have something in them, that there is a tumor mutation burden which may make an IO combination work slightly better off than IO alone or immuno alone. But of course, the jury is out because we don't have a head-to-head comparison of that. And we are only doing cross-trial comparisons.
On that thought, may I invite our next speaker actually, who will be speaking for chemo IO, Dr. Bharat Vaswani, sir. Dr. Bharat, please.
Good evening. Let me thank the organizers for the kind invitation. The topic that I am debating today is IO plus chemo should be the first line treatment in de novo metastatic non-small cell lung cancer. So in other words, I'm trying to answer one important question. On a Monday morning, if I have a patient with metastatic non-small cell lung cancer, what will be my first choice of treatment? So the answer is, it should be a combination of immune checkpoint inhibitor and chemotherapy. Now, how do we decide which is the best combination, whether it is IO chemo or a IO-IO? So the answer is very simple. A combination having the best response rate, a better progression-free survival, more importantly, a better overall survival, and last but not the least is a manageable toxicity. So when I discuss a combination of IO with chemo, chemo potentiates the immune response by causing immunogenic cell death, importantly, reducing the regulatory molecule, including myeloid-derived stromal cell and Tregs, and more importantly, increasing the infiltration of tumor-infiltrating lymphocyte and causing an inflammatory milieu. Now, when you look into the pivotal studies of IO chemo versus IO-IO, the most important 3 studies are there, including Keynote 189 and 407, and IM Power 150 and 130. Of course, I will give my dear colleagues the option of even discussing Checkmate 9LA, but basically it is also a combination of chemo plus IO-IO. So when I talk about non-squamous or adenocarcinoma histopathology, 3 pivotal studies, a Keynote 189, Empower 150 and 130. So let me discuss the first important thing, the response rate. When you look into the combination of IO plus chemo, the response rates are quite impressive, around 50 to 60%. More importantly, a disease control rate of 80%. As I'll be discussing in the last, IO-IO gives you a response rate of only 27%. The second important thing, a progression-free survival. Now, rather than looking into the numbers, let us discuss what is the hazard ratio, because that gives you a difference between the chemo and the combination of IO with chemo. As you can see in all the 3, there is an impressive PFS and the hazard ratio. There is a reduction in the risk of progression by around 40 to 50%. And the most important thing, the overall survival. Even if you look into the overall survival, the most important study, Keynote 189, as what we practice in our practice, the hazard ratio is 0.6. Please remember these hazard ratio because this is the way we can do an indirect comparison and say which is the better. So around 40% reduction in the risk of death when you use a combination of IO with chemo. And that is what the main important message is. Now, when you discuss the most important study of Keynote 189, a combination of Pembro with the Carbo and PEM followed by PEM and a Pembro maintenance, what is more important is the absolute number. The survival was 22 months irrespective of any PD-L1, 40% reduction in the risk of death, and more importantly, a long-term 3 years benefit of more than 30% patients surviving on this combination. Now, what about a PD-L1? Now, I will like you, most of the time we always discuss our IO with chemo in more than 50 TPS, but I will like you to concentrate on less than 1 also, because that is where my debater will discuss the importance of IO-IO. Even in those with a TPS of less than 1, the hazard ratio is 0.52. Of course, the quantum of benefit 17.2. So these two numbers are important. Of course, in more than 50, 27.7, and in 1 to 49, 21.8 are equally impressive. But I will like you to concentrate even on TPS less than 1, which is as impressive as the other two numbers. Important thing, the subset benefit is in all the subset, but I will like you to concentrate on never smokers also, because this is a subset where the combination of IO-IO does not work. So one more added advantage of giving chemo plus IO. Now, when you look into high-risk subset, please look into the quantum of benefit also. Again, impressive response rate, impressive overall survival, and more importantly, there is around 40% reduction in the risk of death in this high-risk subset also. What about TMB also? Of course, a combination of IO and chemo, the TMB is not important because the quantum of benefit, whether it is TMB more than 15 or less than 15, this quantum of benefit remains the same. Now, when we discuss about our squamous histology, that is a Keynote 407 and IM power 137, again looking into the response rate, in fact, better than what we had in a non-squamous, around 58% response rate. But more importantly, I would like you to concentrate on PFS, OS. Again, this improvement in risk of reduction in the risk of progression is more than 40%. When you talk about overall survival also, there is an impressive number with more than 30, around 30 to more than 30% reduction in the risk of death. The most important updated analysis, this OS benefit even come now, the hazard ratio is 0.64, which is 36% improvement, impressive overall, more impressive progression-free survival. Now, when you look into again into those subsets with less than 1 to 50 and more than 50, this quantum of benefit remains more or less the same. The hazard ratios are impressive. Now, my dear friend will discuss about a checkmate 227, which is the most important study, and checkmate 9LA. Now, when you look into the side effect or the drawbacks of this study, look into the earlier part. High mortality in the earlier part of the curve, a poorer response rate of only 27.3%. Now look into the hazard ratio. In PD-L1 more than 1.76, PD-L1 more less than 1%, 0.64. And when you remember your Keynote 189, this hazard ratio is far better in Keynote 189. So less impressive hazard ratio on a cross-trial comparison. All the advantage that we discuss about IO-IO is in PD-L1 less than 1% subset. Please remember, this was not a primary endpoint. This was an exploratory endpoint. So on a Monday morning, can I change my practice based only on the exploratory endpoint? The answer is a big no. And we have to always be aware of a high incidence of a immune-related adverse event, which is more in the combination of IO-IO. When you discuss about our checkmate 9LA study, they try to reduce this early side effect or the first disadvantage of early mortality. Again, the hazard ratio of overall survival is 0.72. I agree there is a benefit, but the quantum of benefit IO chemo is more. And more importantly, in a never smoker, this combination with chemo also does not work. So in all the parameters that I discussed, the combination is inferior to a combination of chemo-IO. Although we should not do a cross-trial comparison, but I have made a point just to discuss the cross-trial comparison and see the checkmate 227 and a combination of IO. A lesser response rate, a PFS which was not statistically significant in the combination of IO-IO versus around 40 to 50% benefit in the combination of IO-chemo. And more importantly, the benefit that is with chemo-IO in fact, is better than what we get it with IO. We may deliberate about our squamous cell less than 1, but these were all exploratory analysis and were never mentioned as a part of a main publication. So these were all which were taken out subsequently. So on a Monday morning, I will choose my chemo and immuno as a first line combination based on a better response rate, which is nearly twice, impressive PSS, which is significant. More importantly, the quantum of benefit with OS is better than the combination of IO, and the toxicity, which we know is predictable. And more importantly, there is toxicity, but lesser grade 3 and 4 immune related toxicity. So I end my talk by telling that the 3 parameters on which we should decide our treatment are better in the combination of chemo IO. And I thank you all for a patient here. Thank you, everyone.
Again, can I ask a quick question to Bharat? Bharat, thank you very much. Unfortunately, I think you had a better or easier job to do than Manish had.
Sir, whatever given, I tried to make my point very clear in the slide.
Okay, why is 9LA not a part of the discussion though?
Sir, absolutely part of a discussion. Actually, the thing is, it also took the advantage of a chemo for the early part of the curve and then subsequently tried to get the long-term advantage of IO. Now, what 9LA told is, sir, that you can get away with the early mortality by adding 2 cycles of
Correct.
Now, the point where 9LA really came out in the discussion of ESCO that in less than 1 squamous cell, the hazard ratio was 0.48. But sir, again, if you see the main presentation of that was never discussed in the main part of presentation. We have that the discussion where the IO comes is again in less than 1%, probably in squamous more. So the thing that I remember is what I wanted to tell was that was never discussed in any of the presentation when they started it. It was subsequently when they took out the analysis, these came out. I'm not telling, it is a part of a debate that we are doing. But my point was that what data available with the maturity of the data and with the strong data is with IO chemo, even in those with less than 1% also, because you cannot have a cost trial comparison first. But if you want to do it, the hazard ratio is 0.52 in Keynote 189. And if you take out Keynote subsequent in the exploratory, maybe it could match that. So for a very small subset of patients, you may think of giving a IO, that too on an exploratory analysis. I'm not disputing that is not a good combination. The debate that I wanted to make was this is probably even a better combination in even those subsets, because this has never, since it is good so much, it has not been discussed less than 1%.
Thank you.
So, Dr. Manish wants to make a rebuttal, or we all agree that chemo IO is a better subset, and Dr. Bharat.
Manish is my close friend. He can always, but good.
It's not about being a close friend or a bad friend.
No, sir. The point is that we want two different point of views. Yes, we wanted 2 different point of views because yes.
So we all know that this is what we do always, and I never used to consider IO as a even a treatment option for most patients. But when you look at the data, the long-term survivability that is achieved with an IO combination, of course, with the caveat of early deaths and those patients. So that is a point that I made, that those who have low disease burden. So there is definitely a certain population who have renal failure or the creatinine clearance is less than 45, who are not very good candidates or are not likely to tolerate pemetrexate-based combination or a platinum-based combination. So perhaps those patients may be candidates, and those who have less than PD-L1 expression of less than 1% and have squamous cell carcinoma, perhaps an IO combination is something that can be looked at. But I think the IO
combination, what makes IO, which is Nivo-EP combination versus the Pembro chemo combination, the differentiation is Nivo alone. Nivo chemo does not really work. That we have seen in the Checkmate 227. And that's the reason Nivo works with ipilimumab in lung cancer. Otherwise, Nivo does not work alone. And that is the hint that we get from these studies. And that's the reason the Checkmate 9LA was planned, because they found that the early deaths which were occurring in Nivo EP could be taken care of by adding just 2 cycles of chemotherapy. So why Nivo EP and take more brunt of the toxicity of Nivo EP, and why not only pembrolizumab and chemotherapy? That's the most easiest combination and is unlikely to give the treating oncologist sleepless nights because of a Nivo EP combination.
Manish, because of the long-term survival, I'm still unclear on that. When we see the 3 year, 5 years,
we still
in
need
a few years' time.
long-term 48 months survival data from the keynote 189, and I think that will be that will be key to our decision making.
Especially again the 9LA back. So what will happen is when we have 5 years of 9LA and we then do cross trial with 5 years of 189, will really tell us whether there was any meat on that or not. But I won't
the
keep
same
too
thing
much.
we are coming from RCC. If you remember your checkmate 214, the long-term data of IO is very good. Unfortunately, in lung, we don't have that. We have not arrived for 9L8 is 2 years. And for checkmate 227, what Sir Manish told was 4 years. The problem is it works in lesser proportion of patients, but when it works in those for a long period of time. That is what we all know. Only thing is, at the end of the day, maybe in the future, you will decide your treatment for maybe adeno different, squamous different, less than 1. That probably will be way to go rather than putting it everywhere. Maybe the worst subset like squamous and less than 1. You may think of this combination probably as a better combination. Or
even there, Bharat, perhaps you will like to take checkmate 9LA as your treatment protocol rather than as IO checkmate 227.
I think so. Few of the bad things about checkmate 227 has been taken care by 9LA. And giving 2 cycles, I think so, is something that we are comfortable giving chemo. Probably the side effect profile has not detailed, but at least some lacunae of the checkmate 227 has been taken care of. So for me, yes, definitely, sir, that check 9LA will be a way to go. Maybe in squamous, yes, I believe there is some data and which is impressive data. Hazard ratio of 0.48 in a less than 1% squamous, it is something which has not been achieved in any of the subsets. So probably only time will tell us. What you said, we need some more time for long-term follow-up of 9LA, but sir, it looks good. We all know that once IO start working 2, 3, 4 years, you don't make much of a difference, it will not come. But yes, we need to, in future, need to find out what are these patients where you will give this one. Probably at present, some data is with only based on PDL1 only with a TPS of less than 1 squamous, but in future. But sir, what I believe is at present, the dice is in favor of IO chemo for most of the
Definitely.
things. IO maybe in future might make a way in few of the subsets. Manish, your comments?
My only comment is in an IO chemo combination, you don't know what is the proportional benefit of each of them. And it may be in a way cost ineffective, although cost may not be a barrier, but then you don't know what is the proportional benefit. And we keep on giving both of them for long periods till the time the patient progress. And we know that majority would progress. So, and we don't know what is the proportional benefit of each of them.
Right. I agree with all of you. And I, as a surgical oncologist, one very fine Saturday, I had a bright idea that let me unsolve the mystery of checkmate and started making a table of understanding checkmate. And by the time I reached the 4th checkmate, I was so confused that I stopped giving any attention to it. I thought I'll send all the patients anyways to Nitesh, so I will just not put my mind to it. So thank you so much to talk about this. And from these set of check to the next checkmate, which is checkmate 577, which is the new talk of the town, where the esophageal therapy has been put into a spin, where we talk about whether there's any more advantage of giving resected squamous cell carcinoma for esophagus adjuvant immunotherapy. And to discuss that, we have really, this is what we named it as hope versus hype, adjuvant nivolumab in resected CA esophagus. Can we have the speaker introduction slides, please? Okay, so I don't need the speaker introduction slides. So what we have for as the 2 presenters, the first presenter would be a surgeon who would talk why this trial appears to be a hype versus, and will be followed by a medical oncologist who believes that this could be the hope for preventing early recurrences delaying recurrences in CA esophagus. So for that, we would have Dr. Vineet Govind Gupta from Artemis Hospital, presenting after Dr. Archit Pandit, who will speak about why this trial is a hype. Archit first. Archit, please.
Thank you,
Dr.
Shubha.
Archit is a senior. Dr. Archit is an associate director at Max Shalimar Bagh Hospital, surgical oncology.
Thank you.
Yes,
Thank
Archit.
you. Thank you very much. Thanks to the organizers. Shubham, thankfully this time you have not pitched me against the radiation oncologists. Generally, you give me the task to debate neoadjuvant chemotherapy versus neoadjuvant chemoradiation. So
This new trial has come now. Because this new trial has come, so don't worry. Now it's going to be for 1 year. We'll go and talk about this only.
Yeah. Right. I think this is a very, very interesting trial. And just to put things into perspective for everyone, this is a 2:1 ratio blinded, double-blinded study, wherein they have taken those subset of poor group patients who actually did not achieve pathological complete responses after neoadjuvant chemoradiotherapy, concurrent chemoradiotherapy in locally advanced esophageal cancers. So something like the cross, but eventually you omit the pathological complete responders. So once you have the you have done the surgery and then you randomize them into into giving them nivolumab or giving them a placebo. So that is the whole thing about, and this is what we are basically going to. Okay. So this is what basically we are going to discuss. I'm probably not into a debate, but I'm definitely going to critique this article and of course debate our way through. So let's check our mate 577. I think we really need to check this mate. So my scheme of presentation will be very simple. I was envying the presentations of all the medical oncologists. The presentations are just amazing. However, this is just going to be very simple, just like a surgeon's work. So we'll be discussing something good, some good things about the article, the bads and the ugly. So ugly, please do not take it personally. Anyone, especially the medical oncologist, it's a desperate attempt to win the debate amongst the Mabians, the MABs, yes, that you have been discussing since morning. So the good thing about this article, I think it's a beautiful article. Finally, there is, there's a sense of a need to identify a systemic therapy, which has been realized because the recurrence failure patterns, as we have seen with the cross trial, the failure recurrence pattern of cross trial, that was the combination of the cross 1 and cross 2, had shown that the distant recurrence are still a matter to which is unsolved and needs addressment. A subset of patients which may not do good in future. These are the subsets. These are the poor prognostic groups. That is those which have not achieved complete pathological response. We saw that in cross trial, the pathological complete responders, they skewed the whole graph to their this thing. So skewing the graph problem with the cross has been also been tried to address. However, I was a little disappointed that if I had a subset analysis of the cross trial who did not achieve pathological complete, this would have been actually a beautiful study to compare with. So we have well elaborated protocols and a beautifully written article. The best part, however, I saw that two pages have been dedicated towards the funding, from where the money goes, and probably that is now I totally understand what is BMS stands for, Merck, AstraZeneca, and now I know all the pharmaceuticals involved in this. So it's a really thing to go through that, but that was just pun intended. Well, the bad thing per se is the data. Okay, now let's see what the data says, how they have collected the whole study. 29 countries are involved, starting from United States, Europe, Argentina, Brazil, Asia. I think the only thing that they did not include was Africa. 170 oncology sites, 794 patients recruited, probably on an average 4.6 patients per center. Now, that reminds me of the lap cervical trial that was there.
Sorry, could you say that again?
Sorry. So a standard regime I feel this kind of an accrual also weakens the control arm, and that is what I'm going to highlight in the further slides. That I feel personally that the control arm, the placebo arm, was weak, and if you pitch anything against a weak control arm, a benefit is definitely there to be shown. The second thing about this study, which is a probably major turnoff, is that they are considering disease-free survival. They are median disease-free survival. They have not considered overall survival, and bringing a completely novel drug which has never been given in an adjuvant setting in the gastroesophageal cancers as an adjuvant space. So when you give a drug, to my understanding, when you give a drug in the adjuvant space, you are probably looking into cure, right? And when you're looking into curative option, when you're trying to achieve cure or trying to cure the person, you really need to look into the overall survival and not the disease-free survival. And that is what this completely novel and completely new class of drug which has come into the adjuvant space is something a turn off for me. I would say that, oncology, the beauty of oncology is the evolution that happens. Just imagine if someone 30 years back would have told you that just do breast conservation surgery, you would have said that this is wrong. You have to go through that process of radicals and then get into conservation. So similarly, I felt the need to have an adjuvant chemo, or at least in the discussion part of the article, was a very important thing. Now, they have not taken overall survival, and to support that, what they say is that so I quote from the article, evidence to support disease-free survival as a surrogate for overall survival among patients receiving adjuvant therapy led to protocol amendment in which disease, blah, 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 and whatever thing. So I happened to see this article, Journal of National Cancer. Now, this is about adjuvant cytotoxic chemotherapy and not nowhere relates with the immunotherapy per se. So I really didn't really get through or didn't understand that. So anything in an adjuvant space, I would suggest, I would feel like to see a curative option, and definitely then I would like to see an OS rather than a DFS. And however, the primary endpoint in this study was not the OS and the disease-free survival. Now, I also feel that this is actually a trial which also is trying to see early nivolumab to probably an eventual nivolumab therapy. So let's just imagine that we have given chemoradiotherapy, concurrent neoadjuvant chemoradiotherapy. We have done the surgery. A pathological complete response has not been achieved. We have given nivolumab as the NCCN now suggests, as the ASCO guidelines also now suggest, and Vineet is also going to pitch in for that, and a relapse happens. Oops. Then what? So that's a totally, so that is where the overall survival will not actually be the DFS will not be a surrogate marker for an OS, especially in a setting where you're giving nivolumab as an adjuvant. So that was my whole point in this, and probably a chemoradiation followed by surgery, and if a relapse, you give chemotherapy and then you try out nivolumab, which is already recommended for this. Now, the other major issue with the whole study was that, if you remember, before this 2020-2019 NCCN guidelines suggest that for adenocarcinomas who have who have undergone neoadjuvant chemoradiation followed by surgery and have undergone an R0 resection, the need for adjuvant therapy is chemotherapy. And now that was the NCCN guideline, and if that is a category 1 evidence, now that is changed to adjuvant nivolumab, unfortunately for me. But if that was the standard of care, then why are we giving placebo in this trial when the standard of care for adenocarcinomas is adjuvant chemotherapy as per the NCCN guidelines? Now that is very, very simple philosophy which I did not understand from this study. So I think the BMS people were in a hurry, and quite a hurry to actually jump onto nivolumab. Now let's have a look on what's given once the disease relapse happens in the placebo arm. Now this was astonishing for me. However, this does not relate to the per se the study, but this was the add-on which I thought that needs mention. Now 42% of patients in the study group received subsequent therapy. Now this tells us about the quality of the whole study. Once the relapse has happened, your work is done. That is where the endpoints happen. And why only 42% of patients have received subsequent therapy? Why not higher? They have relapsed, and 16% have received re-irradiation. So, probably a loco-regional recurrence, and then you are re-irradiating them. 16%. 8% received repeat surgery. I do not understand that viewpoint also. Now, this was something again which was a turner for me in this study. So, to again summarize, the control arm I feel is weak. I would like to ask the surgeons over here if a median disease-free survival of 11 months in the placebo arm, is that what the surgeons here in as the participants or in the panel, they look into achieving only a median disease-free survival of 11 months for your patients? You mean to say that 50% of your patients are actually recurring within 11 months? Is that what we are looking into? Of course, we are looking into a poor prognostic group, but certainly this is not the data that probably we have. There is no adjuvant arm. There's no chemotherapy has been given in the adjuvant arm. In majority, about 70% of these cancers were adenocarcinomas. The NCCN guidelines as a standard of care has been ignored. When 70% of your population is adenocarcinoma, then only 29 or 30% are squamous cell carcinomas. Now, what are the issues with the control arm? First, as I mentioned already, that there's no adjuvant chemotherapy given despite 70% being adeno-CS. A poor median disease-free survival of 11 months in the control arm makes it a very weak arm. A surgical, I do question there, and I'm not shocked, because if 170 centers, 170 institutions are participating, there will be a diverse kind of surgical participation, which will definitely bring in the poor quality of the control arm. I wish there was a subset analysis available of non-PCRs of the cross study, which I would have compared here, but we do not have that. Also, there was another very astonishing thing that I noticed in this whole study was that the median disease-free survival in the control arm, that is the only placebo, the arm which received neoadjuvant chemoradiotherapy followed by surgery only and placebo, the median disease-free survival was 8.3 months for esophageal cancers as compared to 20.6 months for GE junction cancers. Does that mean that the surgeons were more qualified to deal with GE junction cancers? I mean, there's not a huge difference between distal esophagus and GE junction cancers. I do not understand that. Well, so I looked into the surgery only arm, which of course we cannot compare the two, I understand, but cross trial also included locally advanced cancers. And if you see the surgery only arm, they are doing fairly well. The surgery alone arm is doing a DFS, disease-free survival of around 17 to 18 months as compared to 11 months of a neoadjuvant chemoradiotherapy for the Checkmate 577. Now, this is where, if you see that the placebo group, that is the control arm, had 8.3 months of disease-free survival as compared to 20 months. So, and the GE junction cancers were actually equivalent, almost equivalent in the two. So that is the one thing that I want. So to conclude my talk, I just want to ask these 4 questions to the other side. That is, in presence of a weak control arm, are the benefits reasonable? It's just like the Swedish and the Dutch trial of the rectum, wherein if you're not performing a complete mesorectal excision and you're giving radiotherapy, the benefits are definitely seen. And why no adjuvant chemo to control the arm when the standard of care is adjuvant chemotherapy? Is 11 months a good disease-free survival? To all the surgeons, I would like to ask this. I think the disease-free survival, median disease-free DFS of 11 months is pretty low to be a good control arm. So I do doubt on their surgical interventions. So the rationale to bring a novel agent, completely different class in an adjuvant space, I think it is again a definitely no for me. So, that was the ugly thing, and I really do not want to piss anyone off. So this is definitely from Marcia Angel, and so that was my desperate attempt at winning the debate. Thank you so much.
Thank you, Dr. Archit. A lot of points raised, and I will move on to Dr. Vineet to actually defend the study, not the study as such, but the concept of giving adjuvant nivolumab in the resected CA esophagus. And then I think we'll have a good discussion about the merits of the paper. Dr. Vineet, please.
Thank you, sir. So actually, I had sent my slides beforehand. Can the team please put it up?
Yeah, sure. Backend team, can we have the slides? Yeah, sure.
Okay, so good evening, everybody. And thanks to Dr. Archit for very nice presentation. So actually, I have to see he's a very good debater. So he has nicely brainwashed you all into thinking कि ये drug बकवास है. But it gives me the tough job of, bringing you back to the side of science from the side of emotion. So I'm going to just get into this study and actually discuss what unmet need this drug is filling. And we'll also discuss some of the objections raised by Dr. Archit. So next slide, please. So this is the presentation. We have already discussed it in the previous presentation. Next slide. Okay, so I'm just going to summarize the trial, just one-page summary of the trial. So population are esophageal adenocarcinoma or squamous cell carcinoma who have received neoadjuvant chemoradiation followed by surgery, undergone an R0 resection. So only those patients who underwent R0 resection, only they are permitted in the study, and who are not in pathological CR. So it is a very selected population. So first of all, I will say it is not correct to compare it to cross study. So cross study will be the first bullet point only. But what we are dealing with here is a very selected population who have undergone NSCTRT, undergone surgery, undergone resection, and are not in path CR. And these are fit patients who get nivolumab versus placebo, with the primary outcome as DFS and secondary outcome as OS. So this was a pre-specified endpoint in the study. It is not a new endpoint. Next slide. And this is the result actually for DFS benefit. And you can see that after roughly the 6th month, there is a quite comfortable separation of these two curves. Next slide. So what actually I have not seen all these slides of Dr. Archit beforehand. So I charted up a list of possible objections. So one objection which you might have is that control arm is not appropriate. And it was also mentioned that it should be chemotherapy. So if you look at the NCCN guideline, both the guideline mention that for squamous cell carcinoma, the standard of care after CTRT followed by R0 resection is observation. No, please don't. I will tell you when to move this slide. Thank you. Yeah, is observation for squamous cell carcinoma, and for adenocarcinoma, there is an option of chemotherapy or observation. So both options are there. And next slide. So my contention is that you are right that perioperative, that is NACT surgery adjuvant, improve OS for adenocarcinoma compared to surgery alone probably. But it is not established that adjuvant chemo actually improve long-term outcome after NACT-RT. And current guidelines accept that NACT-RT followed by surgery is adequate treatment for both squamous and adeno. Next slide. So one objection which we read many times is that DFS in control group doesn't look that great. So maybe the treatment was not appropriate. So I just want you to bring to your attention, don't focus on just our experience, because the experience is fallible. We are dealing with a very selected group of patients with very bad prognosis. So next slide. So this is a large study. There are almost 200 patients actually. There are almost 160 patients in this study, if I remember. And these are patients who actually represent the study population. And these are patients who did not have complete pathological CR after chemo radiation. And you can see that in the control, in the arm where there is no path CR, the 5-year DFS is only 25%. And the median DFS, you can see the brown lines, it is little more than 1 year, which is similar to what we saw in this study. Next slide. Next slide, please. In this slide, one more study where they have again looked at the same question. You can see that the median DFS is 1.1 years in the arm where there is no path CR. So it is pretty typical. In the study, it was 11 months. So I would say it is comparable. Next slide. Next slide, please. So some other issues actually. So one topic which was raised that there are only 4.7 patients per study. Isn't that a positive? It is a large multi-center study involving multiple countries across multiple continents, and it actually proves that the benefit seen in this trial, it is applicable to our population also, because there are multiple centers. It is not just one center which is following one practice, which is giving one study. And also the intervention control groups are well matched in the trial. So I don't think it is the right thing to say that no control group is not appropriate. And one thing is that the studies which I showed you just now, in fact, they are retrospective studies. So retrospective studies always have little bit better outcome than prospective studies. Still the median survival is only around, median DFS is only around 1 year. So some points to ponder. Next slide. And one objection, which actually I agree with partly, that there is no OS benefit yet. DFS is not good reason to change practice. So I would agree with this on some level, but I just want to raise one point. Next slide. Next slide, please. So what is the prognosis of recurrent esophageal cancer who has failed CTRT and surgery both? So what would be the prognosis of this patient? You need to actually look at the prognosis to understand the need for this study. Next slide. So this is a, next slide please. So this is a very recent paper actually. It is from 2021 GI Cancer Symposium, and it is a European study. So the treatment is mostly sponsored. There are no cost issue. Patient is getting all the treatment, and patient has access to very good quality European surgery and all the approved drugs. So what do you think is the median OS in this population? Next slide. So the median survival ranges from 4 to 5 months actually. So patient who had locoregional recurrence only were able to get 7.4 months. If distant relapse, it was 4 months. Patient who had got prior definitive CTRT, the median survival was 5 months. So these are very dismal outcomes actually. Next slide. And if you look at the toxicity from nivolumab, which has been conveniently ignored, it is nothing like chemotherapy. You can see that the grade 3-4 toxicity is almost same between placebo and nivolumab, and only fatigue seems to be the major grade 3 to 4 toxicity. All others are less than 1%. So such a non-toxic drug, next slide, with such a dismal outcome without after recurrence, it is quite likely that with longer follow-up, you will get a OS benefit also. I agree on some level that drug is costly, but drug is not toxic. So you should, if you have a well affordable patient who wants the best treatment, I don't think it is wrong not to use this drug, keeping in mind that outcome of this patient is very poor. So you need to keep this option available. Of course, for general use, you might want to wait for overall survival. And one more thing I want to actually say is that nivolumab is not a new drug, as it was said multiple times. Attraction 2 study clearly proves that nivolumab is active in third line, and recent randomized trials have established nivolumab and canrelizumab both in the second line. So even it was discussed that nivolumab is a good second line option. So it is wrong to call it a new drug. Definitely it is a well-established drug. So next slide. So with that I will stop. Actually it is very difficult to counter Dr. Archit because he knows how to press all your buttons. So I also need to press your buttons, otherwise you will not listen to me. Okay. So I hope this was good for everybody and we can move on. Thank you.
So a very candid, a candid talk by Dr. Vineet, and he had me when he said कि पूरी दवाई निचोड़ दी है, ऐसे बेकार की दवाई है नहीं, मतलब I got it. It is coming from the right heart. But before I invite Archit for the rebuttal, let me ask Archit that we operate CA esophagus. We give a lot of time to CA esophagus. We discuss a lot of CA esophagus, and we send our patients for CTRT beforehand. It's not, we never fight against the radiation oncologist when they say that we need to give, because we are talking in the interest of the patient. It also hurts us when these patients recur, and most of the times they recur distally than locally, right? You have to accept the fact that there is going to a drug which is going to come and give you that survival benefit. The surgery that you are doing, the surgery that we are doing, it is the best that we can do. And even if you do a even better surgery, the survival might increase a little bit, but not to the extent which a new drug might be. So are you against the study, or you are against the drug which probably provides the ability to, like Vineet said, reduce the chances of the disease coming back?
I think that's a beautiful question, Shubham, and you have definitely pressed the right button. See, I'm definitely not against the drug. Okay, that's why I did not even mention even once about the cost, because we are talking about science over here and not about the cost. Now, the drug is fine by me. The problem is that I cannot digest this study because of the DFS. If there was an OS, then there was an intent to cure the patient in the adjuvant space. Again, now if you are bringing this kind of a drug out of the blue, a totally different class of drug into the adjuvant space, I need an OS, because ultimately, so my question would be, if this recurs, if the patient recurs after nivolumab, what next? What next? So if nivolumab is good enough to achieve that flat plateau line and keeps on going, then in that Kaplan-Meier curve, then I am very happy. Okay. Secondly, now if I have to rebut, see, I think beautifully Vineet has made all the points, and just couple of things which were actually missed. See, one of the study that Vineet mentioned over there was from 2018 by SOROR, SOROR. Now that is only 50 patients, right? So I don't think we really need to mention. And even though the median DFS was around 13 to 14 months, now medical oncologists, they are very nice guys, See, look at the smile on his face. Sufficiently, conveniently, what he'll do, he will talk about 1.5 month benefit survival on some XYZ checkmates and keynotes, but he will forget the 5-month disease-free survival that he's getting in the control study. The other study which Vineet showed, that also has a median DFS of more than 14 to 16 months as compared to 11 months in this study. See, I'm just saying that the third thing was, see, why I said that the control arm is not good. The sole reason was that Vineet and Manish was there, Nitesh is here. See, when you are giving chemotherapy across 170 units, the same nivolumab will go in, the same dose will go in. You sit in Taj or you sit in a nursing home, it will bring in the same effect. But surgery, it doesn't work like that. Surgical standardizations is a totally different ballgame together. Across 170 institutes, oh my God, I can't imagine. Now that is the reason that there's a debate on East versus West.
Yeah, we got that, Archit. So I'll ask Vineet, we will go to the DFS later, but tell me something. Archit spoke about a weak control arm. Now, there was 10 years back, there was a study where they said that adjuvant chemo versus no adjuvant showed that there was no benefit. Probably because the benefit was there, but it was so little that we did not consider it to be a significant benefit, and we removed adjuvant chemo from the management of CA esophagus, right? That is one thing. Now, when you compare this adjuvant nivolumab to a placebo. You could have compared that adjuvant nivolumab to that adjuvant chemo, and you would have found out that the incremental benefit was not significant, and then you would have never advised adjuvant nivolumab. So how correct are we to choose an arm where there is no adjuvant treatment given, although that is the standard of care? We agree to that. The mathematics is correct, but is the science correct? Because mathematics will win over science, because you always take in you always factor in the unknown with the mathematics, but for the science, is it correct? And secondly, we have accepted ADAURA for the simple reason that the magnum of DFS benefit was so huge. The surgeons are burdened under the magnitude of DFS, 0.17, 0.17, 0.17, that we have accepted ADAURA. But here, the magnitude of DFS is also not wonderful. So how good is DFS? And now to Amit Agarwal sir is also here, that he says that this is even good for science. So sir, you can join in. You can join in the discussion also. And Vineet, how good is the science versus the maths?
Also, Shubham, I would just want to reiterate again the same thing. See, NCCN, the standard of care is not just observation. Observation was category 2A. This is category 1, says adjuvant chemotherapy in adenocarcinomas. Now, this study has 70% adenos. So you cannot ignore that.
Right, Vineet.
Okay, yeah. So first of all, I want to say that all the points raised are not wrong. Because see, because I have to be in the debate, I have to take up a contrary position. In fact, before the study, my practice for patients who are not in PAPCR is to give them adjuvant chemo. I don't observe them no matter what NCCN says. Okay, so I will agree with you there that ideally it should have been chemotherapy in the adjuvant arm. But nevertheless, if you go by the data and if you go by the guidelines, because see, in everything else we are following guidelines, but when we don't want to agree, we say no, I will not follow guidelines. So what I would say is that as per guideline, it is not strictly wrong, but I do agree with you also and Dr. Archit also that adjuvant chemotherapy would probably have been a better control arm. I do agree there. Yes.
Archit, I think I found a new topic for debate for you from now on for the next 1.5 years, and I'll get different speakers for you now next time. Don't worry. So, but I will end this discussion, wonderful discussion, with what Dr. Haroor said, that we need to identify the right adjuvant drug, because believe me, the survival advantages and the better survival will be with better drugs, but which drug, which subset of patients to give, and how strong is the evidence, is that we are here to discuss. So thank you, Archit. Thank you, Dr. Vineet. And with this, we conclude the thoracic session. But Dr. Haroor is here to stay with us, and to get the next session started, I'll invite Dr. Niranjan Nayak sir to actually introduce the topic and the speakers. Dr. Sahu is going first, followed by Dr. Haroor, Dr. Niranjan. Dr. Niranjan sir.
Good evening, friends. Yeah, that was a great discussion, very interesting discussion. And it was also part of GI. So now next session is for GI. And first, I think Dr. Shubham will be the chairperson for this session because he is taking care of everything. First and foremost, we will discuss about total neoadjuvant therapy for C rectum is here to stay. And to talk about, talk for this, Dr. Tarini Prasad Sahu is with us. He is consultant medical oncologist from Bhopal Silverline Hospital. Dr. Sahu, yeah. Over to Dr. Sahu.
Okay. Thank you for the invite. Hi, Anil. How are you?
Hi, Sahu. How are you? Good to see you.
You know, Dr. Sahu, when we told Dr. Haroor that you are debating, he said, yes, it's going to be a spicy debate. So we are expecting one.
Both Dr. Sahu and Dr. Haroor, both are good friends of
All are friends, sir. All are friends. But not in a debate, huh? Not in a debate.
Not in a debate, yeah.
So coming down to the topic, and I was told to tell that total neoadjuvant therapy is here to stay. And Dr. Anil, any doubts about it? I feel if you have doubts, then I feel then you are not well read and you have not read your things for the last 2 years. You are not updated, only operating and only operating. So let's get back to maybe 10 years or 15 years back. And this update was also presented as a 12 years follow-up. And this was the TME trial all of us speak about. The short course RT plus TME versus the TME, the large 1,861 trial. If you look at the data, the addition of radiotherapy did look at the loco-regional control, but there was no survival benefit. There was a selective survival benefit in the stage 3 with the CRC margin negative, but overall for all patient data, it was a negative data. Now coming down to the point that if you operate, and we as medical oncologists give chemotherapy in this subset of patients of rectum, do we benefit? And if you look at the larger trials, because there's a lot of debate on in this oncology forum, that do rectums at all benefit with a new adjuvant with the adjuvant treatment? And there is a meta-analysis to tell you that if you are doing adjuvant, it does not benefit. And that is a meta-analysis which is putting all the trials which are ever there with oxaliplatin, without oxaliplatin, with 5FU, without 5FU. And the take-home message is there is no definitive level of evidence to show that post-surgery adjuvant treatment helps. And look at the stage 3 patients, which are the most of the high-risk patients where we advocate chemotherapy on adjuvant setting for colon. When it comes to rectum, the advantage just goes away in this meta-analysis. Now coming back to what are the problems with adjuvant? Because when we're talking of total adjuvant therapy, neoadjuvant therapy for rectum, we have to tell what are the problems post-surgery. Around, if you look at it for this data, which is a little old, but you pull across trials, 30% do not start adjuvant therapy post-surgery. So you have 1/3 of the patient who were to receive therapy could not start adjuvant treatment. And then we look at the National Cancer Comprehensive Network analysis, and this is again a large data, and we had patients of approximately 8,300 odd patients. And if you look at one more interesting data from here, 30% could not, and once you start the treatment, 30% do not complete. So basically 2/3 of a patient are not able to complete what you intended to do. And that is why when you start, and at all you start in the 66%, 30% do not complete the scheduled adjuvant treatment. So you are very likely not to get the desired benefit. Again, post-surgery, all of us know, and this is the data which has come in the JAMA, association from the time of initiation of adjuvant chemotherapy and survival in colorectal cancer. If you delay it by 4 weeks, mind you, 1 month post-surgery, the benefit of chemotherapy is decreased and the hazard just goes away, and you do not benefit much if you are delaying and if the chemotherapy first dose is beyond 4 weeks of surgery. And mind you, what I'm presenting you, Dr. Anil, look very carefully on the screen, is level 1 data. I'm not talking of the small trials of few patients. These are level 1 data. Now coming down to why at all should I go for a treatment which we have been not advocating till now. Look at this. All patients, if you have a very good PAT-CR, that is a blue line, you would be doing, you would be achieving a recurrence-free survival which is statistically significant than patients who are T3, T4, N0 or who have an N1 positive node. In contrast, also you find this data which I showed you in adjuvant stage 3, you do not benefit, but if this patient do benefit from a neoadjuvant approach and achieve a PAT-CR, that's again the blue line, in the stage 3, they again benefit in terms of recurrence-free survival. That is the data. So this gives us a rationale of achieving a PAT-CR. And how do we do that? So to brief it up, problems are plenty. We do not have any proven benefit of adjuvant chemo. Most of the features, most of the failures, what we get in a rectum are distant. 30% do not start adjuvant therapy. Another 30% do not complete the therapy. So Dr. Anil, 30% formula for you, all the 30% here. And better outcomes with a higher PAT-CR. So we must do better. I don't think that is good enough for our patient. Our patient deserve better. And can we do better? Yes, we can do better. So for this, what is the data? We have the Rapido and we have the PORIS 23. And if you look at two things, what it points to is, let's go to the first one, the Rapido trial. It's a short course RT, 5 grain to 5, chemotherapy followed by surgery. That's the thing. Normally what we do is we do the chemo radiation, go for the surgery, and then give chemo afterwards. When you look at these both their arms, you find 28% of patients achieving PAT-CR in contrast to 14% in the chemo radiotherapy. So you have doubling of a PAT-CR, and that has increased, that has benefited in terms of better treatment failures, lesser treatment failures, and lesser recurrence. For the PORIS 23, again the arm is chemoradiotherapy, surgery, FOLFOX or CAPOX for 4 to 6 months as we have normally done. Suddenly we add a modified FOLFIRINOX, then go for chemoradiotherapy, and then operate and then give 3 more cycles, and look at the astonishing PAT-CRs, which is again more than double. So look at the Rapido. It was a 900 odd patient trial, phase 3 randomized open label. And if you look at it, it had patients of T2, T3, T4, majority of patients were T3, T4, what we would look to have. And out of the node positive, majority were node positive. And in this patient subgroup, which can be considered high-risk patient subgroup, when we give the treatment, we found that the experimental arm, that is the neoadjuvant approach, did benefit in terms of the patients had lesser disease-related treatment failure, patient had lesser distant metastasis, and patients were having lesser loco-regional failure. In contrast, if you look at it, the distant metastasis was also lesser to a tune of around 15% if you took a total neoadjuvant approach. Now, the PAT-CR, which is more significant because all of us know if you achieve the PAT-CR, you're going to do well. It was, as again, 28% versus 72%. That's what it is. That patient who did undergo this, actually the PAT-CR doubled from 14 to 28%. So now coming down to the PORIS, one of the larger trials, here it was modified FOLFIRINOX. What they did was put in the best possible chemotherapy and put it in the neoadjuvant approach, then go for a concurrent chemoradiotherapy. And once we do that, we do the surgery and followed by adjuvant. Or we do the classical chemoradiotherapy and the surgery followed by the adjuvant. And this was again the subgroup of patient whom you would consider high risk. What important thing happened is this toxic? Because the point that surgeon comes and tell us that aapka FOLFIRINOX modified to bada toxic hai sir. And look at it, 90% of the patient or more than 90% could complete 6 cycles on a trial setting. That's important. And if you look at it, the 3 years DFS and the metastatic free survival was statistically significant towards this, and the PAT-CR was higher for the neoadjuvant approach. And if you look at the other prognostic factors, for all the poor prognostic factors, stage 3, stage 4, irrespective of location, irrespective of the CRM positive or a close CRM, it was statistically significant towards the arm of the neoadjuvant approach. And last most important, consider that chemotherapy is toxic. That's what the surgeons have it in mind. And look at the global quality of index data. There is no deterioration actually. The trend was towards improvement for the patients who took this neoadjuvant approach. Safety, neutropenia, only 2.5%. I would not be bothered of that neutropenia and there were no deaths actually. And look at the post-operative stay and hospital, again in favor of the neoadjuvant. I do not know. I'm sure Anil did not operate this patient, but there was a 3% post-op mortality in the total non-neoadjuvant approach or the classical approach. So why the hell should I not go for this when my survival oncological benefits is there? There is a survival benefit, and I have lesser post-op morbidity and mortality for the total neoadjuvant approach. What stops me from not doing this approach? And look at the safety. Exactly, it's found that it is a totally safe approach. The DFS and the OS, the so-called gold standards, were superior for the experimental group than for the control group. And this is something, look at the OS Dr. Anil put through into this picture. The hazard is 0.67. So if I just change the way I treat the patient, I would be giving a 35% advantage of the patient surviving more at the 3 year points. What more do I want? And even look at the Lancet, how they have quoted. The PORIS 23 trial, along with the Rapido, which also reported a total neoadjuvant therapy approach compared with the standard of care, will be a practice-changing approach. And if that is not enough, what would you need to not to offer total neoadjuvant? You have superior compliance. You have lesser metastatic disease because the metastatic diseases were much lesser for the total neoadjuvant approach. You have superior DFS and lesser local recurrences. You have lesser toxicity and you have better quality of life. And apart from that, what more do you want? Which parameter did I miss? Did what you would not have got? And again, go back to, if that is not enough, and in a in a wave 3 COVID that is lurking over us, you are lesser hospital stay with this neoadjuvant approach. And that is again at 12 days versus 25 days, just half these stays in the hospital. And where are we moving to? This is my last slide actually. There is a trial being conducted that if you do a total neoadjuvant approach and you have a radiological CR, there is an option of waiting and deferring surgery. So it might be after 5 years, we would be having the surgeon sitting in the balcony and watching us giving chemotherapy and the radiation oncologist giving radiotherapy and surgeon waiting for the day, ये wicket कब गिरेगा और मैं batting के लिए जाऊंगा. That is the day we are approaching, Dr. Anil, because this is where the world is heading to: lesser surgery, later surgery, more of achieving the path CR. But mind you, Dr. Shubham, there are people who never change. And I'm telling you, I'm very sorry. Anil is a good friend and he's one of them. And I think he still will remain a friend because I have to accept him as he is. And that is where I stop. Thank you. And I would like to have Anil have his debate.
Thank you, sir. I think that was a very passionate, and if Dr. Herur heard what Archit had to say, he was in the same vein, you know. But believe me, sir, I do a lot of thoracic, and once Adora came, I was very scared what will happen when new Adora will come. You know, all the tumors will disappear and I will have nothing to operate on, probably nothing, and whatever will be left will be taken by the SBRT. But I can see that Dr. Herur is a true surgeon and we look up to him and people like him. So I will ask sir has actually sent his presentation. Sir, I am sure it will not be as forceful as Dr. Sahu was. So do you want to switch on to a live mode and start batting from the front foot, or you want me to play the video?
No, I think you can play the video mode, because the network here is, I'm not so sure. Okay, but definitely I think Sahu is a very dear friend, and I always enjoy talking this with him. And I feel that medical oncologists have this belief that, you know, everything is going to be chemotherapy. They have had this for the last 25, 30, 40 years, but nothing has happened. Surgeons are going nowhere. And it is going to be, you know, we have to be there and take out the tumors, however complications, however the difficult stage the patient is put in after taking all the loads of chemotherapy. So if you can just switch on my this thing, I focus mainly on the Rapido, because I think that is where the main contention is, and let's then have a discussion after that.
Thank you, friends, and I must thank Dr. Shubham Garg and all the organizers at Oncology Forum for having this excellent conference and making me a part of it. And not so much thankful for putting me in a tight spot, because I have to speak against one of the finest orators of oncology and talking about chemotherapy against him. So that's a very, very tough task, but I'll do my best. So today, talking about the Rapido trial, which is something that has taken the surgical world by storm. And why not? Because it is always talked about as something called as total neoadjuvant chemotherapy, which means there is nothing for the surgeon to do. But my surgical friends, surgeons are going nowhere. हम इधर ही हैं, हम किधर नहीं जा रहे हैं. Because remember, the trial talks about rapid rectal cancer and preoperative induction therapy followed by dedicated operation. So if at all Surgeons are not only there, but very much in, and they are supposed to be surgeons who are dedicated to the treatment of rectal cancer. So no way that the surgeon is still going out of the picture. Now, I won't speak much about the study design. My friend has already alluded to it. I will just point out to 2 or 3 glaring things that I personally felt were a little raised a bit of anxiety in me, which was one was the timing of surgery. As surgeons, we know that timing of surgery does make a difference, whether you operate at 4 weeks, 6 weeks, 8 weeks, or whether you operate after chemotherapy, it makes a lot of difference. Secondly, the adjuvant chemotherapy after the surgery, it was left to the treating institution. Does it make a difference? We shall see. And the third most important thing I would bring to your notice is this is mainly a trial which was done in Western Europe. Only one center in US, most of the centers were in Western Europe. Does it make a difference? Let's see. It was in these countries, friends, local recurrence is no longer now a big problem. They have managed to control their local recurrence rates below 5%. For the past 10 years, they have had excellent results. Their local recurrences are not an issue. With us, is it the same? We have to see. Now, that is why the entire aim of this trial was to reduce distant metastasis. Secondly, most of the European centers reported low compliance for adjuvant chemotherapy once the surgery was done. So, will the patient take chemotherapy before surgery? We also have this experience that once surgery is done, tumor nikal gaya saab, abhi kahan humko chemotherapy lene ko bolte ho? Abhi to bimari nahi rahi na, to chemotherapy kyun? These are things that we are asked. It is the same across the world, and that is why they thought of giving chemotherapy before. Now let me come to the very basics. Let's see the patient characteristics. These are older patients. The average age of these patients is 62. Mind you, we know that older patients have better disease, younger patients have aggressive disease. This is an adage that has been going on right from the beginning. Secondly, look at the choice of the disease. Nearly 20 to 25% patients were in upper rectum. More than 10 centimeters, to my limited knowledge of rectal cancer, is upper rectum. Why? Why give neoadjuvant therapy to an upper rectum? Why not operate them upfront? I don't know. If it was an Indian paper, probably this would have come back. But it's a paper done by Western centers, Western European centers. So I don't know whether upper rectum qualified for giving neoadjuvant therapy. Thirdly, the adjuvant therapy was left to the treating institution, and we shall see the effect of that. This, according to me, is another very, very important feature. Poorly differentiated cancer was less than 10%, about 10% in the standard arm and 9% in the experimental arm. For our patients, this is completely different, as we shall see. So these were the messages that the trial gave: 7% lower disease-related treatment failure, 7% lower distant metastasis, doubled PCR rate. So that got everybody excited. Oh my God, this is really, really good for treatment of rectal cancer. We are going to see better survival. Did it do that? At 3 years, no difference. Of course, no different toxicity and no different quality of life. Now, my first question is, are we dealing with the same problem? Are our patients the same? Let's start at the very basics. Look at this. Poorly differentiated cancers make up nearly 20% of our patient population, and this is an audit from Tata by Professor Saklani's team. Stage-wise, obviously, this is third stage. Obviously, this is not something against the trial, but our disease is a little different. Signet ring is nearly 13% of these tumors. So we know the relationship between signet ring and chemotherapy. So our disease has more than 1 in 10 patients is going to have a signet ring histology, and almost 2 patients are going to have mucinous histology, both of which are something that chemotherapy finds very, very hard to deal with. So we deal with this kind of bulky tumors. When we say bulky, they are Gobika pools, not some nice dainty looking tumors which are sitting there. They are really huge, they are humongous, and the nodes are bulky as well. This was a study done to study the impact of chemotherapy on various histological subtypes, and as is expected, signet ring does worse. So again, more signet ring population in our country, less signet ring, less poorly differentiated in the trial. So are we dealing with the same problem? My question again. So secondly, this was a study done again by Professor Saklani's group, and I have borrowed these slides from him, that whether chemotherapy is going to improve your R0 resection rates, because this is the kind of response that you see in a lot of these patients. Your CRM is still positive. It's a signet ring, it's mucinous. So do you want to give chemotherapy and then operate? So they tried that and they could achieve R0 in 62%, which means 40% patients are still not going to achieve R0. Now, what does a CRM positivity do to your local recurrence rates? We all know. So there are too many variables in this trial. There is almost 30% upper rectum. The timing of surgery is different. Who receives what chemotherapy is different. So it's quite confusing. It's quite a mixed match of a lot of variables. All of us know in good centers, when dedicated operations are done, loco-regional failures do not come up in 6 months or 1 year. They usually come up after the 3rd year. And lo and behold, even in Rapido, the difference in the curves have started occurring at 3 years, with the experimental arm showing more loco-regional failure. Again, our patient population, bulky disease, signet ring, less responsive to chemo, more prone to loco-regional failures. Are we dealing with the same problem? Secondly, this is disease-related treatment failure. When your chemotherapy was left to the treating institution, the point moved closer to unity, showing that if the institution was taking the call as far as the chemo was concerned, then the results were better. Again, has it affected the results of the trial? The jury is out. Overall survival, same. For all the effort that has been taken, no, there is nothing to show at the end of at least 3 years. Maybe after 5, maybe after 7, we don't know again. Now, this is something for surgeons in the group, and this has had me, at least as a surgeon, worried. Your conversion rates in the experimental arm were higher than the standard arm. Now, these are trained centers. These are centers, dedicated centers doing rectal cancer surgery. Why should their conversion rates be different? Though they are not significantly different, they are still higher. Is it an effect of short course radiotherapy? We don't know. Now, we all know that conversion is a negative prognostic factor. In most of the laparoscopic versus open trial, conversion has been shown to be a negative prognostic factor. So this may have an effect as we go analyze the long-term results at 5 years or 7 years. We don't know, but it has me worried as a surgeon. Not a big difference, 3% difference, but it is there. Secondly, the intactness of the TME as assessed by the surgeon. Now, this in the experimental arm was 78%, whereas standard arm was 85%, almost a 7% difference. Is it something to get us worried? I leave that for the surgeons. And intact TME, isn't it the most important thing that a surgeon looks for? Higher in the experimental arm. Now, quality of life. Quality of life was similar, but there was a little more plexopathy because of the short course radiotherapy, and this was what was published in this paper by a part of the group which did the trial. Now, if you compare it with the Polish trial, you will see the Polish was another large trial which talked about consolidation chemotherapy after short course radiotherapy. It had not such a great dramatic difference in PCR, and the loco-regional failure was also similar. So PCR probably did not have any great effect as far as CRM, R0 resection, or multivisceral resection is concerned. So just to summarize a few of my observations on the trial, we don't know the effect of short course chemotherapy and consolidation chemotherapy in the young population. Our population is closer to 45, 50, 10 years younger than the population in the Rapido. 32% of the tumors were CT4, 22% were lower rectal cancers. For us, that figure is much higher. And low rectal cancer is where the proof of the pudding is. And we are in the trial deals only with 10% poorly differentiated. We are double that figure. There was progression among non-responders while on consolidation chemotherapy. That, according to me, is a worrying part. Are we delaying surgery and causing harm to the patient? DFS benefit does not translate into OS that we know. Contrasting results in terms of metastasis-free survival as if you compare it to the Polish study. Too many variables, and there are some surgical differences as I noted there. Lot of interest now in this TNT approach. There are a lot of trials going on, as you can see here, and some of them have actually left radiation completely out. You can see this trial, TNT without RT, TNT with or without RT, Folfox with Bev. Here there is Folfox plus CRT or Folfox alone. So no radiotherapy, but my surgeon friends, nothing yet without the surgeon. So surgeons are very much there. And my humble submission on this trial is that the jury is still out on this one. Thank you very much. Thank you, Shubham, for this opportunity. Thank you.
Sir, I'll get Sahu sir in first, sir, before I can say something. Let's get Sahu sir first.
It is very clear. Anil just did.
Can you put my video on?
Yeah.
Can we have Dr.
Just a moment. Just a moment.
Yeah.
Yeah. So specifically, he just missed out on the Porridge 23. It is as good a trial, as large a trial, and you had this FOLFIRINOX. Mind you, the chemotherapy skeleton is important. So it is that it's a modified FOLFIRINOX, and in Rapido it was a FOLFOX and Capox. So my point is two things very clearly now. Apart from the debate, I need to look into what benefits the patient. Nowhere the surgeon is out. The debate was never into the surgeon being out. It was, should we be going the total neoadjuvant approach? I think, Shubham, I think you should read the thing aloud to Dr. Anil so that he remembers this. The debate was about the approach that we needed to do. And important is the adjuvant chemotherapy. There is no large trial in rectum till date, which shows that there's a benefit of adjuvant chemotherapy in rectum. Colon, yes. Rectum, no. So when there is no benefit on an approach and you have a benefit of a neoadjuvant, total neoadjuvant approach, and the skeleton has to be, to my feel, is the modified FOLFIRINOX. 6 cycles at 14 days interval, 3 months, then the chemoradiotherapy, and then you operate and go for 3 more doses of the modified FOLFIRINOX. That is the approach, what I feel will be the way to go ahead. If you are doing the Rapido thing, I think the skeleton is the only thing that's different and the number of doses is different. So I would be more comfortable if I do a total neoadjuvant with the Porridge type of chemotherapy. And I've done 2 patients till now, I'll tell you. And we have operated both the patients, and both the patient, maybe the early luck is there, have been PAT-CRs for us. So it is not that every next patient is going to be a PAT-CR. Second point is I just can get away without the adjuvant therapy. And anyway, I'm not taking out radiotherapy at all. And I think this is the way I would approach this. And for the middle and the upper and middle, which Anil told, if you look at the Porridge, and there is the very good Porridge nahi bhai, Amit bhai, it is Porridge yaar, mera transition aise hi hai, kya karu main? ठीक है. So I hope we are understanding what I meant. So in the middle and the upper, there was no statistics.
भावना महत्वपूर्ण है.
Protease, sir. Protease study.
It is a one word difference, yeah.
Sir, protease study.
When neoadjuvant trials come, medical oncologists think of the Porridge.
Protease, sir. Protease.
That is like Porridge to them.
Okay.
Protease study.
Okay. Will the skeleton change anyway? I think that is the skeleton that will be.
So sir, in defense of Dr. Herur, you know, he submitted this video.
Last line and last line.
Yes,
middle
please,
and the upper, what you told Dr. Anil. If you look at it in the trial of the Bharat bhai, which is bol, naam kya hai?
Protease study.
So if you look at it, that the benefit is actually similar. But actually the middle, the hazards was more in favor of 0.5 versus 0.7 for the upper. So that part of the upper and middle and lower does not hold good because it is beneficial irrespective of the arm. I take your point, what you meant to tell us. But I think that we are moving towards this approach. And if there is no detrimental effect, there is no post-operative morbidity that's going to happen. There are lesser hospital stay and 90-95% of patients are able to take the therapy. In contrast, where 70% only are able to take adjuvant therapy, I think this is the way the world is moving forward. That's all.
So, sir, just in defense of Dr. Anil, he submitted this video 10 days back, actually, where there was no discussion about the surgeon going out of the way, but it is you finish with the slide that, the surgeons might be sitting in the balcony, but Dr. Herur already knew that you were going to say that, so he had incorporated in the slide 10 days back already. But my question to Dr. Herur, sir, in principle, the study looks good, other than the patient subset, other than the type that we have a different subset in the Indian subcontinent. So if the similar study was to be done in the Indian subset of patients, then you would agree to the results, right? And then we will move to a TNT approach.
The debate, the issue of just a debate and the light humor apart, yes, I think neoadjuvant, total neoadjuvant chemotherapy is definitely something which is very exciting. What I really want to know is how will patients tolerate this? Because see, today we know that 30% patients are not going for adjuvant therapy post surgery. If the opposite occurs, then what happens is nobody has measured, right, because that situation has never been analyzed before. Secondly, nutritionally, our patients are poor. For somebody who's nutritionally poor to tolerate irinotecan sometimes becomes a little tough, and for them to then go ahead with surgery. So I think there are issues. I think it is not that we should not embrace this approach, because there are going to be there are these patients who will refuse surgery or who will refuse any kind of treatment just because they are going to end up with a permanent colostomy. So if these patients are going to benefit from this approach, we definitely I think it is it's a nice way to go. There is no doubt about that. In the current, what I objected to was in the current form. I think these trials, I have not. I thought the entire thing was about Rapido in particular, and that is why the entire presentation was designed like that. But I think these trials, especially, I think we need to have a hard look at them. We need to duplicate those results in our settings and then go ahead. That's my only point.
The last point that I want to just very quickly is the Prodigy. If you look at it. Bharat, मैंने correct कर लिया अपने आप को.
You are always correct.
So the completion rate of 6 cycles was 91%, Dr. Anil, which is very good in compared to what was the Western data of 70% for adjuvant. So the worrying about patient not able to complete, and we as medical oncologists vouch for it, that neoadjuvant approach, people do tolerate chemotherapy and complete it much more than in the post-op setting. Because a lot of these patients have complications and have these wounds not healing up nicely, and they have these problems. And because of nutritional study, what is told, the healing effect takes a lot of time actually. And the delay which I showed, if you delay the therapy beyond 4 weeks, that is the effect again goes down of adjuvant treatment. And if you can practically ask all the medical oncologists here, how many of them start in a rectal surgery, chemotherapy within 4 weeks, nearly 50% of the patient would be starting after 4 weeks. So that is also a point of the time frame. So we have something which is there, that in the eligible node positive patient, that's pretty clear, T3, T4 node positive, so-called high risk. This approach could make more patient eligible for chemotherapy and systemic therapy. And because 30% of the disease are metastatic to pain, and this approach would be something that has to be looked at. And for the OS, 3 years data from the date trial shows us there was a benefit, and the hazards was 0.67. I think this is a very attractive approach, and this approach is going to be explored further.
Right, sir. Right, and I think Dr. Herur has made that submission that if this was to be proved in an Indian subcontinent setting, we would be very happy to take this. And believe us, surgeons, we are very flexible, sir. We change with times. So we have taken up the robotic approach once the robot is available. So we will take the TNT approach when it is there. And the study is very good. And this is what Dr. Amit Agarwal has been saying on that chat, and he has been making all khichdi with porridge and curd and everything. So with this, I thank Dr. Sahu and Dr. Herur for making this a very interesting session. Dr. Bharat was also there. Dr. Amit was there. There is somebody by the name of Zoom user, which I don't know who, but they have also put in a comment on the OS. So with this, I thank both Dr. Herur and Dr. Sahu, sir. Thank you so much, sir. And to Dr. Amit Agarwal, sir, all porridge and curd would be served tomorrow at the physical conference at Hotel Radisson, Sector 18, Noida for the lunch. So please be there. with this, we'll move on to the last bit of the academic session, which is again, I'll tell you the concept. We kept all debates cross speciality. So there was always medical radiation, surgical radiation, medical. And similarly, on those lines, we have this debate on the role of radiation in neoadjuvant setting for GE junction adenocarcinoma. No, this is like a switch on, switch off thing. One study says there is, the other one says there isn't, but still there is probably it hanging in the middle. And to debate on this, we have two very good speakers. For the motion, we have Dr. Piyush Bajpayee. Can I have the next slide, please? For the motion, there is Dr. Piyush Bajpayee, who's the head of medical oncology at Manipal Hospital, New Delhi. And against the motion is Dr. Shikha Haldar from BLK Super Speciality Hospital. And we will start first with Dr. Piyush. Dr. Piyush, sir, you can start presenting. Please allow him to share the slides.
Yeah, good evening, Shubham. Good evening, Shubham, and thanks for this opportunity. I hope my slides are visible.
Yes, they are, sir.
Yeah. So
you just need to make it full screen.
Is it fine? Yeah.
Perfect.
Yeah. So my role is actually to tell that there is no role for radiation in neoadjuvant setting, and I'm talking about GE junction carcinomas in particular. So this is just a background that how the evolution of neoadjuvant and perioperative therapies has taken place, and we have seen increase in survivals from just doing surgery to the addition of chemotherapy anteriorly. So just the primary two trials which actually added to this information, and MAGIC was followed for quite some time, which had patients of GE junction. Nearly 11% of them were GE junction. Esophagus was 15%. Good trial with a good number of patients of 503 nearly. And it led to almost 13% increment in the overall survival at 5 years. Likewise, this French trial also, here there were 64% of the patients who were actually GE junction. And it again, the important thing over here actually questioned that whether we can just do or go ahead with just a doublet. And we found that results were quite similar with what was actually the MAGIC results. The survivals were coming quite near to that. And so how to build from there? Actually, there were efforts to add radiation therapy anterior to MAGIC strategy and bevacizumab, but none of them actually appeared to succeed. So changing the strategy towards taxanes, and yes, this probably worked. As we see that what we see over here, the baseline characteristics were interesting over here, that 56% were GE junction tumor, and there were clinically T2 and above TN stages taken into consideration. The FLOT strategy is using docetaxel 50 mg per meter square, which is every 2 weekly, along with oxaliplatin, leucovorin, and 5-FU. This was compared with the MAGIC strategy. And just to talk about the baseline characteristics, we see that good representation of GE junction tumor in this particular trial. So there was nearly 200 patients, and that is so important. If you also look, there are patients who are actually above the age of 70 years. And that is again an important point when we look at this particular strategy. So look at the numbers over here. 716 patients were taken and nearly 200 patients of GE junction. And eventually it led to an increase in, there was an increase in R0 resection as compared to the MAGIC strategy. Also, we actually, there was a build-up on the overall survival of what MAGIC was achieving, and median overall survival reached up to 50 months. So looking at the various subsets over here, well, elderly definitely was benefiting. Barrett's esophagus, with a background of a Barrett's esophagus and adenocarcinoma, there was a benefit. Signet ring subtype also was benefiting. Node positive was also benefiting. So you see hardly any subset which is not benefiting with this particular strategy. Now, if we look at the cross-trial comparison, very difficult thing, but if we have to do it, we have to do it this way. Look at the hazard ratios. So you look at MAGIC versus no chemotherapy, and you get hazard ratio in overall is 0.75 and pretty impressive in GE junction. And from there, FLOT built up. It actually was compared with MAGIC strategy. So it actually still there was a good impressive hazard ratio present in the GE junction tumors. So this was all about raising the bar from no chemotherapy to chemotherapy, and then the addition of FLOT. That is the taxane strategy. And now coming to the cross strategy. Now, this is always impressive. You know, we think always that multidisciplinary is important. Yes, two different strategies are always attractive. But over here, you see this cross trial in particular, there are just 24% of the patients who are GE junction tumors. So good trial. Otherwise, there is a good overall survival ratio, overall survival. But if you look at and dissect the curve, then you get the major advantage from this for the squamous cell carcinoma patients. Now look at the baseline characteristics. Okay, how many patients of GE junction were there? Actually, just 39 patients. Wow. And in FLOT, where the debate is going on, for GE junction, it is actually having 200 patients nearly. So there is a stark difference over here, as we can see. Now look at the N1 nodes, or look at the performance status. So you have performance status 1, just 19% of patients. So you can see, already imagine that they have not taken any clinically T4 patients at all. You can see the 0 over there. So you see that probably the reason why they are PS 0, you can understand that they were quite early disease patients. Now look at the forest plot over here and look at the various subsets. Okay, look at the whether females are really benefiting from this strategy. Probably there is a doubt. Then what about clinically end stage? There is again a doubt whether this is the hazard ratio do not look impressive as compared to N0. And what about adenocarcinoma? Again, the graph is lagging behind as compared to squamous cell carcinoma. Of course, look at the performance status 1. Again, the graph is lagging behind. So ये क्वेश्चंस तो जो है पूछता है भारत इस समय कि ये कहाँ ये कौन आंसर करेगा. So cross strategy, 366 patients, and you have chemo, RT, and surgery over here. Now, what Dr. Shekhar is going to project that, okay, 92% was R0 rejection over there, but actually intention to treat population में तो it was only 83%. So 5-year overall survival was impressive, but okay, this is across the board data and not just GE junction tumor. So talking about just a comparison of this these two trials on the how to go about it. Look at the number of patients. FLOT definitely has more, and already I told how many were GE junction over there. Now hazard ratio, definitely this is FLOT versus ECF and surgery, whereas cross is versus surgery alone. Of course, you have quite similar hazard ratios over there. Margin free rejection, as I told, that Dr. Shekhar is going to say 92%, but actually intention to treat population, it is only 82%. Consistency, well, there are several strategies. It is a strong, consistent data. If you look at all the various histologies, Barrett histology, signet ring, you have data. FLOT is doing impressive. There is no data for cross over there. And of course, PS1, there is definitely, better hazard ratio over there. Elderly, you have data. These are disease of elderly actually. So you have data over there. So, and mind it, I mean, once there are bad lungs in this particular age group, there is definitely a debate whether to give radiation or not. So definitely quality of surgery, FLOT, and FLOT has more robust data over there. Talking about pathological complete response, you have various data right from Albatran et al. Data. which is showing actually pathological CR going up to nearly 16%. So this is again established over there. Now, why it is that cross is not a great option, and we get to see from this microRNA expression that whatever gastric GE junction tumors are there are more actually similar to the gastric cardia adenocarcinoma. And we already know that radiation is not a great strategy in a gastric adenocarcinoma, and because of systemic spreads. So the molecular reasons are loud and clear over here. So basically, when we are actually talking about systemic responses, we cannot we cannot just miss the forest over there. So cross trial in G junction is actually equivalent to this BlackBerry phone, where you want both the worlds, but you fail to get enough of either. Thank you.
Thank you. Thank you, Dr. Piyush. I think you were doing a very good job, but the moment you touched about lung fields, I think you have incited the wrath of a radiation oncologist. How dare you say that we will make the lung fields go bad? So I now invite Dr. Shikha Madam to counter all that he has said, and he invoked Bharat also somewhere in between. So now it is for national pride of radiation oncologists that Dr. Shikha is speaking for. Madam, please, you can share your screen.
Thank you, Dr. Garg. And as I'll be presenting in my presentation, so sorry, can I share my slides?
Yes, please, madam, you can share your screen.
Sorry, I can't.
When they can't see your slide, yes.
Yeah, can you see my slides?
No,
not yet, ma'am.
You have to press share screen button.
Yeah, I did share. Sorry, 1 minute.
Yeah.
Ma'am, first you open your presentation, then click on share screen option, and then select your presentation.
Share screen. Yeah, can you see now?
Yes.
Yes, ma'am. Please start a slideshow.
Slide 1, madam, and then slideshow.
Yeah. Can you see now?
Yes, yes.
Yeah.
Yes, please.
Thank you, Dr. Vajpayee. I think you've made my lot many points for me to make it easy. So is there a role of radiation in neoadjuvant setting in gene junctions? I would say yes, definitely. So let me go through the little bit of history about the gastroesophageal junction, which is a very unique challenge housed between esophagus and stomach. It is in a no man's land. See, other problem is that its classification. There is no standard classification. Only CVIT classification, which divides it into 3 arbitrarily on a endoscopic location of epicenter. So identifying this epicenter is often difficult, as the intraluminal mass often overlaps these artificial boundaries. As Dr. Vajpayee was saying, kept saying whether it's a gastric tumor, but I would rather say when it is an adenocarcinoma, it's more of a G junction tumor. Adenocarcinoma and esophagus is more of a G junction tumor than it is a esophageal cancer. So, given it to the anatomic location, G junction tumors have been grouped either with esophageal cancer or gastric cancer in large randomized clinical trials. So, as Dr. Vajpayee did, so he selected only the trials which were with chemotherapy, and then they are mostly with gastric cancer. So, in the same way, I might be picking up the other set of trials. So, as we know, now, why are we using, why do we want to use radiation therapy? As we know, the prognosis of G junction is poor because of its high distant and local regional recurrence. Our goal is to find a solution to eradicate the micrometastasis and improve both surgical and survival, not to compete with medical oncologists or medical oncologists competing with radiation oncologists. So our strategy is to get the best outcome whether incorporating chemotherapy, radiation therapy, or both. So the rationale for incorporating chemotherapy and radiation therapy before surgery stems from the unique anatomic feature of the G-junction tumor spanning from distal esophagus to the proximal aspect of stomach. Because the esophagus is not covered by serosal lining and is in close proximity of organ structure, spread by direct extension is frequent. The rich submucosal lymphatic network of esophagus and G-junction leads to high risk of lymph node involvement. So furthermore, the data supporting trimodality therapy are based on high rate of local failure and after esophagectomy alone, and the concern for achieving curative negative margin resection. So way back in 2017, Intel 011 trial, it had randomized patients to cisplatin 5-FU versus surgery alone. Here, the local failure was 31% for patient who underwent R0 dissection and 61% local failure for patient who had who failed to achieve R0 resection or developed progressive disease on preoperative therapy. There are several small studies and meta-analyses which have demonstrated that association of positive circumferential resected margin also gives a very poor overall survival. So hence the potential for locoregional failure and positive circumferential margin resection after surgery has produced an interest in using radiation therapy as a part of the combined treatment. So Dr. Bajpai has mentioned all these trials, and along with cross trial, which he extensively explained. But I would like you to focus on this point. You can see, which he has mentioned earlier also, you can see the PATH-CR, which is very, very low in other MAGIC and Accord, except for in AIO trial, which has 16%, but nothing compared to cross trial, which has 29%. As I had mentioned earlier, to have a disease-free, local disease-free or an overall survival, a local-regional control is very, very important. So coming to the cross trial, which he has already mentioned, so he said that very few were G-junction tumor. I would refute that. There are 75% of adenocarcinoma, most likely because, it is very difficult to find the epicenter. So, that's the reason most of them were grouped in esophagus. So the randomized trial, they used chemotherapy that is included carboplatin and paclitaxel and radiation dose, that is 41.4. As far as a radiation oncologist, that is not even an adequate tumoricidal dose, microscopic tumoricidal dose. But still, the chemoradiotherapy group had 92% complete resection, whereas only surgery group had 69%. And PATH-CR was seen in 29% as we had mentioned earlier. And when you go by the toxicity profile, there was hardly any toxicity. So these are the Kaplan-Meier table. We can see the significantly better improvement, better survival with chemoradiation with surgery versus surgery alone. When we separated the group, that is squamous cell carcinoma versus adenocarcinoma, those squamous cell was small in number, had shown a better improvement, but adenocarcinoma has an edge over surgery alone. Again, he had a lot of things to say. Whatever it is, maybe less or more, but they all favor the concurrent chemoradiation group. They are not on the right side. They are not on the right side of the forest plot graph. So coming to this is a phase 3 randomized trial, a German trial, which is SUPPORT, which is a very, very important trial, though it was underpowered because the accrual was done, has to be done early because of poor accrual. The study had to be completed early because of poor accrual, reason unknown. So they had two groups. One is pre-op chemotherapy 5-FU and cisplatin followed by surgery. And the second group was pre-op chemotherapy followed by chemo-RT with the same disease. And the radiation dose was very small, that is 30 gray. But we have the long-term term data now, which throws some good light on this trial, which shows that local progression-free survival was significantly improved with chemoradiation, and the patient free of local tumor progression was much better with chemoradiation versus only chemotherapy, which was significantly higher. So here also we can see the survival curves the chemo radiation group has done much better than significantly better than the only chemotherapy group. The rate of post-operative in-hospital mortality was somewhat higher in concurrent chemo radiation therapy, but more patients were alive at 3 and 5 years after chemo radiation therapy compared to chemotherapy. That is 46% versus 26%. So resection margin, again, that R1 resection were more often observed with chemotherapy arm than with chemo radiation arm. So although the primary endpoint, overall survival of the study was not met, the long-term follow-up data suggests the benefit of local progression-free survival with radiation therapy was added when added to preoperative chemotherapy. So the optimum combination is still unknown. So there are some few trials going on. We are awaiting the result, which Dr. Amit has been, putting in the chat group. So that is, one is ESCOPEC. They are comparing with MAGIC regime with CROSS. And let's await the result. And the second was the neo-AGS. He mentioned that it has not shown any benefit, but I would like to get your attention here. Though it is, they have commented as that is, there is no difference. But if you check, factor by factor, definitely the CROSS trial is showing definitely numbers at least it is showing a better than MAGIC arm. So the conclusion was the RCT reveals no evidence of perioperative chemotherapy is unacceptably inferior. Mind that, inferior to multimodality therapy. That means it is not superior. So I rest my this thing. For local, I'm not talking about distant metastasis. At least for local regional control, radiotherapy is very important. Thank you.
Right, madam. Dr. Amit, you want to come online? You can switch on your mic at least.
What happened?
No, you had so much data. No. I just wanted to get you into it because Dr. Shikha also mentioned about the ESOPEC trial that you mentioned and about the neo-AGs, and Dr. Shefali is also with us. So in practice for G junction, do you actually see radiation being used, or the float is actually swept cross your heart, put your hands up and then say?
So are you asking me? So
yes,
I'm not
sir.
very clear.
First you,
okay.
Then Dr. Shikha.
So I was standard following CROSS trial for G junction adenocarcinoma. That was my preference till date. I'll be honest with you about that. But with the neo-AGs trial, in which an older chemotherapy, which is an EOX, which is an ECF MAGIC trial, has shown similar survival data. And we clearly know that FLOT is about 20% better than EOX and much more easy to get than EOX. So I now would consider keeping the patient on a neoadjuvant and an adjuvant FLOT trial, FLOT data set, because that's way better than ECX, even in its survival. And ECX is equivalent to CROSS trial in a head-to-head comparison in a survival data. I mean, we all are happy with the PAT CR and this and that, but eventually the patient wants to be cured and want to live without the disease. Yes. And the surrogate markers are disease-free survival for living without the disease, and OS is to a degree a surrogate marker for cure. So if ECX is equivalent to CROSS and if FLOT is better than ECX, then FLOT is a fair choice now. Obviously, unless until you have an ESOPEC trial in front of you, clearly proving this point, till the time both options remains open. But I think a neo-AGs trial has clearly opened up the fact that in a head-to-head, you can either use the two. And if you're a firm believer of FLOT, better than EOX or ECF, then I think that opens up a good standard option for the patient.
But I would like to ask, sorry. I would like to ask, sorry, sorry.
Good.
So I'd like to ask you a question. So when you say G junction, you would like to go for FLOT, but would you, divided between type 1, type 2, type 3, like rather type 3 you would like to go for FLOT, or type 1, type 2 would like to go for cross trial, cross regime?
We were doing only cross trial for type 1, type 2, cross largely speaking. But there is new ages coming up which saying that even in a type 1, type 2, you can get away with an ECF, ECX with equivalent survival. And we now have left behind ECF and ECX with a FLOT trial. I think pending SFX trial, I think it is attractive to use chemotherapy. Having said that, unless and until we are doing an indirect analysis, that is ECF is equal to cross, FLOT is known to be better than ECX, so we are using an indirect calculation. So therefore, an ESOPAC trial would actually answer the question largely, but an indirect calculation seems to suggest that that may turn out to be a better solution. So I'm gradually inclined to use FLOT now, but my standard of care was cross.
Right. Dr. Shefali, any comment?
Yeah, so I agree with sir. So basically the pathology, I think, should decide. So lower esophagus, if it is a squamous type, so obviously radiation is well into the picture. But if it is lower esophagus adeno or G junction per se, so I would also prefer a perioperative chemo rather than going for a radiation based. And now once FLOT has set a, index for that thing, so I think FLOT is a better choice for that. I agree with sir.
Right. So, Dr.
I think in a squamous carcinoma, there is no alternative. I don't think there is any choice in squamous cell carcinoma. There is no role of a neoadjuvant or an adjuvant chemotherapy. So the controversy is only in a G junction type 1, type 2, where both the options were open.
Right.
Both had a similar hazard ratio. But I think till the ESOPAC trial comes, both the options remain still open.
Yeah, I think
there is some hint. But I think, there is now.
Yeah, I think it's more of a
morphology.
It's more of a histopathology, sir. What I understand that guides actually adenocarcinomas have not shown so much of good positive results with the radiation in the neoadjuvant setting in any of the trials. So probably the results were all skewed by the squamous cell morphology. So again, now we have adjuvant nivolumab. That too, squamous cell shows more of a skewed results. So there are so much to compare and decide. Yeah.
Sir, I want to make again what Amit sir said, fully agreed what sir said. Once you are leading with squamous cell, the recurrence is also more local. So there is added role of radiotherapy. Now the subset of patient where cross really worked, if you see the subset is a squamous cells and not adeno, and they were predominant esophagus, what Dr. Shefali madam said. So probably now more or less we have this, what we do is adeno CA, the failure is systemic. You need better chemotherapy, you add FLOT. Whether radiation adds up, nobody knows, but the indirect comparison shows that cross result and FLOT are more or less equal. So we are basically adding RT in a adeno in a GE has not shown any advantage as far as indirect comparison. So what we follow as a medical oncology on most of the is squamous CTRT. The spread is local. These are more refractory. Chemo may not be sufficient to downstage or to get to a pathological CR. So CTRT and adeno, mostly they are GE junctions, so we get lesser, but FLOT probably because the spread is more systemic, these are better chemo. Then the indirect benefit is more or less equal to what we get.
A lot of people have spoken in favor of Dr. Piyush actually. So Dr. Piyush does not get a rebuttal, but I would just want some last parting words from Dr. Shikha madam before we close this session.
Definitely, I would like to, because nobody's mentioning the POET trial.
Yes.
Underpowered this thing, but it had compared chemotherapy versus chemotherapy followed by chemoradiation. Definitely, it had shown a local control better, and maybe we should and it was only G junction, mind you, that was only G junction tumors which they had seen. So I think we should not be so close-minded about because that has new ages long-term results have yet to come. So before that, we should not pass a judgment. Just adenocarcinoma do not respond to radiation therapy, and we should give only chemotherapy. maybe we should do, there should be another trial in lines of a POET trial so that we have a proper answer. I mean, I don't think there is any radiation oncologist to support me.
No, I'm supporting you. I'm the radiation oncologist.
No, we are all supporting you, ma'am.
So let me answer that question.
Okay.
So let me answer that question. The POET trial did not have a very strong team. But so it was a cisplatinum 5FU, some kind of an etoposide thrower. So there was a problem with POET trial in this context. But I think saying that squamous cell carcinoma needs radiation and adenocarcinoma does not need radiation, I don't largely agree with it. You need to have a head-to-head trial to answer that question. So that is why I said till the time we have an esophageal trial, we have both the options.
Right, sir. Thank you. Thank you so much. And with those last comments, I will close this session. And I thank Dr. Amit, Dr. Piyush, Dr. Shikha madam for being there. We have had interesting discussions from thoracic to GI, head and neck and everything. And this would be the last session for the day before we conclude with part versus part with bevacizumab combination for ovarian cancer. And for that, I will invite Dr. Nitesh Rohtgi to start the discussion. Dr. Nitesh, sir, please.
Thank you very much. It's actually been a fantastic day. I am hoping we have recorded this, and I'm hoping if we can somehow get these transcribed, they've been really very good things. Can I share my screen? Yeah.
Please share, sir.
Okay. So the topic, and thank you to the organizers for having me here. This is CIPLA's sponsored session, I think. Am I right, Shubham? So thank you, CIPLA, for actually organizing this conference with great help, along with all the other people there. But the key question here was maintenance ovarian cancer. Can I just see where my panelists are? I can see Amit there. Amit, you are here. Attendance. Okay. I can certainly see Shefali there.
I'm here and there. I'm drinking water.
I can see Suhas there. And can see Sujit there? Sujit is there. Yes, Sujit is there. And is there anyone else there who I'm missing?
Mudassir, sir.
Mudassir, I can see you. Okay, so let's start with Mudassir. This is our common problem, advanced ovarian cancer. The disease keeps coming back. Majority of women actually have relapsed, over 70%, and I think we already accept that the overall survival often remains 50% or less. So I think question number one is, do you believe that platinum interval really matters? And I'm really not talking about 6 and 12. I'm talking more than 12, less than 12. And do we ever think about these strategies to improve that first platinum interval from maybe 6-7 months to 12?
Yes, I definitely believe that the platinum interval matters. The patients who have less interval between the end of chemotherapy and the second and the recurrence, they seem to be the worst group as a whole. So it is prognostic. So I think yes, platinum interval definitely matters. So then the other thing is that if we use maintenance therapies, we are definitely going to increase that interval. Will that change anything? I don't know whether by principle it is a kind of it will change the biology of the disease, but it will certainly increase those months of for the patient. That's my personal take on it.
So I think what I'm trying to ask, Shefali, maybe you can take this, is that when we are looking at a patient at the end of the standard carboplatin paclitaxel, whether you're given 6 together or 3 surgery 3, are you really thinking about the response to therapy, the response to CA125? Are you using those parameters and thinking about what you can do to improve your platinum-free interval, or actually that's just something you do, whatever you do to everybody, and look at it retrospectively only? I think I'm asking, effectively, do you do something to try and increase that interval?
So, first question, I believe yes, that platinum interval matters because there is enough data to say platinum sensitive disease if it recurs. So again, the response rate and the chances of complete response in the second line are great with PFI of more than 12 months, then 6 months, and platinum refractory. So in that order. And what strategies do we have to improve first recurrence? There is ample data now, but how to select and choose is very important questions. We have niraparib, we have bevacizumab, we have bev plus olaparib, we have BRCA1 subgroup where the strategies are a little different. So these kind of things are there. So when I see my patient at the first visit, I try to think of, okay, in what subgroup can I fit my patient so that I can improve that platinum free interval. So that is what I think.
Okay, fair enough. So I think, Sujit, I'll let you answer the next question. I'll have few slides. Firstly, the fact that other than carboplatin, paclitaxel, everything has been tried and more or less failed, includes dose dense. What we have not put here is multiple therapies, put gemcitabine, lipodox, all in first line didn't work. Interpretally, we could say work, but you have to know how to do it. So it's almost not in use. And based on the fact that VEGF inhibition did work, it has been incorporated at first line in many consensus and guidelines. Further and separately, the BRCA and the homologous repair defect actually has become the two big things. So basically, we're talking BEV and the HRR or HRD or BRCA, whatever you call it. And I think that has become the two areas which we are very seriously looking at when we are testing these patients. The first thing, Sujit, over to you. Where do you, what's your take on BEV in first line maintenance? For whom? Not for whom? Where do you think about it? And also, do you do BRCA in everybody? And where do you think about PAP? Maybe I'll let Sujit you talk about BEV, and Suhas can then take the question on PAP.
Yeah, good evening. Bevacizumab, I usually don't start for everyone. For patients who have stage 4, I do offer them Bev along with chemotherapy and then as maintenance. And also, in case patients have not for high grade, but in clear cell carcinoma, I do offer them. And in patients who have ascites and post surgery, if I'm not happy with the, because suppose we give 4 cycles of chemo and then the surgery, there is enough residual disease, I do add bevacizumab for the 6th cycle or so and continue as maintenance. So not for everyone, definitely for higher risk like stage 4 or stage 3 whom there is significant residual disease, and for uncommon histologies like clear cell carcinomas. And now I tend to add them for mucinous also, because there is not definite I don't think paclicarbo is a real choice for mucinous carcinoma. So, but although that is the standard, I add for mucinous also. So I don't add routinely for all stage 3 or stage 2 ovarian cancers.
Amit, do you do that for mucinous, and do you do that for patients who present with upfront ascites? These 2 points push you towards use of early BEV?
No, I don't do it for mucinous. I can understand where Sujit is coming from. His answer has a logic behind it.
Yeah.
But I think the data set was very clear about high-grade serous ovarian carcinoma. So we don't do it, but I know where Sujit is coming from. There's a logic. There's a logic behind it. We're trying to use the logic of mucinous colorectal, I believe.
And what about the ascites question? Does patient present with high volume ascites? Does that push you for early institution of BEV?
Oh, if you the ascites was a subset analysis in GOG 218 data set.
Yeah.
In which they said that the presence of ascites is an indication of using adjuvant bevacizumab. This was an unplanned analysis on a smaller subset, so I don't use that as a criteria for using adjuvant bevacizumab.
Suhas, what's your take on PAP inhibitors in first line maintenance? For whom and for whom not?
The PARP inhibitors for me should always be used for patients who are BRCA mutated or have HRD mutation, which is generally not done in our patients. But for not whom, patients who are not non-BRCA mutated and who are also not having any HRD mutation, still that area is confusing whether to use PARP inhibitors or not.
And do you think it's time to test on everybody? It's almost almost free of cost in some patients, and about 10,000-12,000 rupees, much cheaper than putting a PICC line for everyone else. Would you
So
say?
I completely agree with that, and I completely would like for all my patients with high-grade serous ovarian carcinoma or advanced ovarian carcinomas to undergo a BRCA mutation testing.
It's a classical case where the test has been so cheap because the drug is so expensive. Okay, so a few more slides, and Amit, I'm coming to you because this is an interesting question I have to ask. So olaparib and Bev, Paola one, which is essentially kind of redefining the standard of care now. And the interesting part was the randomization was post chemotherapy Bev to olaparib Bev. So the combination, it was not a study of Bev versus olaparib, it was a combination of Bev versus olaparib, almost saying this was standard of care. And what was interesting in that HRD positive patients, HRD positive, even BRCA negative patients showed a clear response of separation, but the HRD negative did not. And the ones who did, actually, this was quite a phenomenal percentage, to have 28.1 months a medium PFS, which is almost close to 3 years, was quite a startling number when we first saw it. The safety was very manageable, not anything very unexpected. And when we look at the toxicity of PARP inhibitors alone, I think the combination did not actually add much also. So the question was that for the first time, now we have several options, HRD positive and HRD is negative. My question to you is, what's your overall take on Paola 1? And how do you compare it to Solo and GOG218, i.e. chemo, chemo Bev, PARP and PARP Bev? What's your overall take on this?
That's to me?
Yes, Amit. This question is only for you.
The question was long, so I slept in between.
Okay, so question is.
No. So I do not know how much was the benefit driven by bevacizumab. Now, because I do not know how much was the benefit driven by bevacizumab, so that answers some part of it. Must have driven some part of it. The average PFS benefit in a GOG218 was approximately 2 to 3 months of PFS benefit. Am I right? 2, 3 months, 3, 4 months?
Yeah, about that, 4 months, yeah.
Yeah, so the quantum of benefit that we have seen in Solo 1 and the quantum of benefit that we have seen in Paola 1 is enormous. Whereas the benefit seen by Solo bevacizumab was only 3.5 months. So I believe that the most of the benefit is being driven by the PARP inhibitor, be it the HRD positive or be it the germline positive. Now the problem is, if you have initiated somebody on bevacizumab because of eligibility and fair indication, then what are you going to do about it? Are you going to stop bevacizumab at the end of 6 cycles and go on PARP inhibitor, or are you going to add PARP inhibitor like in Paola? So that's where the problem is. But I think the major partner here is the PARP inhibitor. That's what my take on it is.
So the question is maybe less on PARP inhibitor, because that question is quite clear. Question is addition of Bev to PARP inhibitors or not, and once you've initiated Bev in the pre-chemo or in the pre-PARP setting, would you continue with Bev? That's exactly where the question, because although I agree, and I've just shown that the Solo 1 versus GOG versus Paola 2, it is quite interesting that the numbers set very high. Of course, the baseline was higher, it was 22 months, but 37 versus 56. I don't know how to interpret this. Hazard ratios are similar, but the patients on BRCA or olaparib alone had 56 months. So I don't know how to interpret this.
Yeah, I don't know.
So I think in both of the trials, sorry.
No, please. Yeah.
So in both of the trials, I think more of the results were skewed by the BRCA positive population. So that is why I think Dr. Amit was saying that what contribution is Bev making, we are not very clear of. So I think both of the approaches are equally okay if you stop Bev and go on PARP maintenance exclusively in a BRCA positive population, or if you continue with the Bev and olaparib in that population, for that matter, in the HRD positive or a BRCA mutated patient.
But that's
So
the
I think
problem, Shefali. That is exactly where the problem is. You see, the problem is because now you have data of Paola 1. Okay, so let me go backwards. Okay. We have accepted, Mudassir quite nicely put across, that patients who think we are high risk, we will add bevacizumab. In fact, Sujit added that he would add it to a few more group. We were not thinking about the mucinous. I was pointing out about ascites. Amit was right in saying that not always the case, but so there is a big group or chunk of patients who are, as compared to 5 years ago, getting bevacizumab in ovarian cancer, and we are all very comfortable with it. So now the question becomes, with Paola 1 being present, if somebody or few of them turn out to be BRCA positive and has a very good response, would you take bevacizumab out because the hazard ratio is 0.31 when compared to no olaparib? So that is what Paola was. There was benefit there. That was the question. Sujit, do you have a view on it? And then maybe Suhas?
Yeah, the trials with bevacizumab as along with chemo and then maintenance has clearly showed that if there is no maintenance after bevacizumab given along with chemo, it doesn't have benefits. So I think if you are starting with bevacizumab, ideally the benefit of bevacizumab will only come if there is a maintenance bevacizumab. But the toxicity that it is adding to the combination, that is a major concern. The hypertension is like 20% more, and it's as such. I believe that in an adjuvant setting or in a maintenance setting, the quality of life also depends on how many times the patient has to come to the hospital. Now, having an oral drug, taking it home and 2 months a visit is fine. Every 3 weeks to go to the hospital for blood test and doing BEV, I don't think it's really worth to go with a combination. So I think even if we have started it with BEV, at the end of 6 cycles, if this is a BRCA mutated patient, it's okay to stop BEV and go along with PARP inhibitor alone.
So that's
and Dr. Nitesh, one point more. If the population progresses on Bev plus olaparib maintenance, then you have eventually you don't have bevacizumab to offer in the recurrent setting as a maintenance to fetch that PFS again. So these are the points, I think, and like Dr. Sujit rightly mentioned, so taking some oral drug versus oral plus IV with the same PFS or hazard ratio, I think the selective subgroup who wishes to continue bevacizumab, it's that okay, but otherwise only PARP inhibitor is good choice in such population.
I have a point here. Actually, the thing is that we would have gained a lot if there was another arm in the Paola 1 with no bevacizumab and only olaparib. And unfortunately, we don't have that, and we will never have that probably. I think the bevacizumab, the addition of bevacizumab has a separate impact. You can't combine that with, we cannot combine, we cannot say. And the thing is that another thing which Paola 1 has added is that it has shown benefit in HRD population even without, BRCA mutation. So I think, that another subset of patients, what will you be offering them? Only PARP, because we don't have data on that. Only PARP in HRD only without BRCA mutation. Only olaparib.
No, so you have primer?
Only
olaparib. You have niraparib?
No, but we don't have it here.
So, I mean, I agree that is an extrapolation, but PARP inhibitors, I mean, so you can.
No, if they are all the same, then we can actually take any other data. We can use actually rucaparib also, and decrease the cost.
So I think we are confusing the discussion here. I firstly don't. I like to use my best treatment first in aggressive treatment. So that's one thing which I agree. Slight contradiction with Shefali there. I buy both Shefali Sujit's point that actually this is more difficult therapy in every way, but we're really saying that we have a difficult to treat population. The population is segregated into two groups: those where CA-125 starts at 5,000, drops to 500 by the end of 3 cycles, and those where there's a poor clinical response, there's a poor response, and these are the patients who, and there's not an exact biomarker, but these are the patients where by the end of the time when you have put them for surgery, stage 4 disease, for example, supraclav node positive pleural effusion, where they're going to be trouble very soon. And in those population, my feeling is, and please correct me if I'm wrong, maybe Suhas or Amit can take that this is the population where we actually start fairly early and we start getting very gung-ho about BEV. And then you start seeing good responses in at least some of these patients. And I'm very wary that when this population comes positive with HRD or BRCA, we get comfortable for the right reasons, for all the reasons which Sujit said and Shefali was saying, in taking the BEV out. But we have to remember that this was the group which even GOG 218 showed actually had benefit when we didn't have anything there. Suhas, do you have a view on that?
This is somehow similar to what you have said, that this was actually confusing in the way that whether we have to continue with BEV or not. But for me, again, as Dr. Sujit has already suggested, that this will hamper the quality of life continuing with the BEV in this population. So we can drop out BEV and can shift on to olaparib in this context.
Okay, so let me go back to Amit then. Amit, what's your patient for patients who are poor responders with neoadjuvant chemotherapy? What do you classically do with them?
So explain that, Nitesh, again. I'm slightly not clear about the question.
So I'm changing gears. Patients come, okay. Patient has stage 3C disease, and after 2 cycles of chemotherapy, CA125 has come to little drop by 25%, as not adequate clinical response. This is a small group of patients. This is not a majority of patients. But what do you do with patients who have had poor or partial response to neoadjuvant chemotherapy? And the other group is
no surgery,
residual disease.
No surgery feasible?
Surgery is still feasible. You operate on them and there was significant residual disease.
Okay. So we operate on them, we leave the residual disease behind. So such patients should be offered bevacizumab, if that's what you're trying to ask. And that's what the question is about.
And do you change chemotherapy in those patients? Do you take the platinum out? Do you change the platinum? Do you change the combination of taxane?
So it depends upon degree of response. So obviously it's sounding like not a very good response. Okay. So if I'm comfortable that the response has been much poorer than I would have anticipated, then I would definitely change the chemotherapy skeleton. But in a way, something which was completely inoperable has come down from 5,000 to 500 and has been operated even with a residual disease. Can it be called a completely refractory disease?
Okay.
I don't know. Great. So whenever I have changed from taxane to doxorubicin based regimen for a similarish kind of a patient, results remain very poor.
Okay, and I think keeping that in mind, this was very interesting that when we took the HRD positive population of PAOLA-1 and we divided that into the high risk group and low risk group, and we can see below the FIGO stage 3 disease with upfront surgery, residual disease, NACT, and FIGO stage 4, low risk was one who had complete response. We actually saw a very big separation of curves again. And so that doesn't surprise us. But the interesting bit was that the patient on olaparib BEV, this is in the high risk group, this is the group which worries us a little bit more, actually had a very good PFS of 36 months and a hazard ratio of 0.39. Shefali, your take on this?
So again, Dr. Nitesh, what we were discussing. So HRD positive population, BEV in both of the arms, lower risk versus high risk. So is BEV contributing to olaparib? So I think seeing both of the graphs, I don't think that BEV is making much contribution in such HRD positive population. So I think it's a PARP inhibitor. So in both of the curves, like BEV only arm, it's a poor response, whether it is a lower risk, whether it is a higher risk. So I think it's the PARP which is driving the way. This is my take on it.
But Dr. Shefali, if you just compare the curves of the BEV plus olaparib also, they are also different.
No, they are different. But in high risk, where we are contemplating, yes, BEV is the decision maker. So high risk group, all what we are talking about, BEV is not making that much of a difference in that curve. That is what I mean.
Say is even if you compare the two arms of low risk with two arms of higher risk, they are all actually falling down together. You know, I'm not saying it's not like that one is falling more than other.
this was the only actual data set of HR of BRCA germline and BRCA negative HRD positive patients, where there was a olaparib group and olaparib with not bevacizumab but another VEGF inhibition group. And there was some separation of curves on this also in patient with BRCA1, BRCA2 wild type or unknown as well. Any takes on this, Mudassir or Sujit?
So, sir, this is actually showing that the niraparib alone did worse than the combination.
Yeah.
So I think that answers the question, no? That the bevacizumab has a separate potential.
By itself, yeah.
Yes, by itself.
Yeah, which is what UG said. So I think a potential schema, and this is the last slide. I know we are very late. It's 9 o'clock and we do have to end. I would briefly take everybody's opinion on this. We'll start with Amit. If he can, this is kind of a schema which I think will become the standard in 2021. If everybody can spend 2 minutes, look at it and opine, and then maybe even we can circulate that around.
So what does it say? It says that somatic and germline panel testing. I would agree with that. If given this option available, I would do that. Tumor HRD testing, I would largely agree with that. Decision one is NACT versus PDS, carboplatinum practical cell BCG to bevacizumab. I would agree with that. Bevacizumab using chemotherapy and maintenance. HRD positive, Paula 1, HRD negative, continue there. What is, so I think, what is the point?
So I think rest is very clear. It is the question of bevacizumab. In HRD negative, we are adding bev in all patients who we have used bev in the maintenance setting. I think that's essentially what this is saying. Once you've taken a decision to add bev, you add it in maintenance. If you haven't decided, you've decided for good reasons, I'm guessing.
I agree. Besides Avalova trial that you showed, there are other trials even in the first relapses of ovarian carcinoma, in which that's called Trigo trial, something like that, in which they have used at first relapse a combination of PARP inhibitor and Avastin, and they could keep the patient off chemotherapy for a fair time, suggesting that there could be an individual role of bevacizumab. But in the absence of a solo one arm in the Paula one, it's anybody's guess.
Okay, Shifali.
Yeah, I would agree. So if I start with the somatic and germline panel and HRD testing, I agree on that. So decision on NACT versus PDS, I would rely on if it is a stage 4 with ascites and pleural effusion or a bulky disease in stage 3 where we cannot achieve a R0. I think NACT is the preferred way rather than PDS. And if it's an effusion, to add on BEV.
Stage 4 with BEV, always?
Yeah, no, not always. In the effusion or the high risk like bulky disease. So
stage
of
4,
course,
no effusion, lymph node positive, supraclav?
heavy nodal burden, yes.
Okay.
So these are the high risk disease. Okay. Then after surgery, so if it is a HRD positive population, then again tie between Paula 1 versus solo. And if it is a HRD negative, BRCA unmutated, so of course, BEV is a better choice in continuation if I have used in NACT.
You're almost saying that if patient has a good response, which is likely to heavy disease burden, and you already know BRCA, you may actually not start bevacizumab even if there's residual disease. Is that what you're saying?
No. So I'm not saying that. So adding a response, because if response is also criteria, I think in that subgroup of population which was high risk, response did matter with BEV. So I'm saying that high risk burden to start with NACT in those chunk of population, BEV adds a value. But whether in adjuvant setting, continuing BEV with olaparib in the mutated patient, I don't know whether it adds on or not.
Okay, Sujit, and then Mudassir, and then Suhas. Sujit, you're on mute, Sujit.
So one thing I wanted to ask the panel is that suppose the HRD positive group does not have the BRCA mutated segment, how much does the curve change? Is there something like that? Because all of the curves include the BRCA mutated. So in prostate, there is data from olaparib. There was a lot of thing that in HRD positive, BRCA positive prostate, olaparib works. But later on, it was seen that it only works in BRCA positive. It doesn't work much in HRD positive. So I'm not really sure whether this strategy is still useful for HRD positive, but definitely for all BRCA positive, I would, this is fine, paclitaxel, then as mentioned, stage 4 or having SCN node, mediastinal node, nodal burden, I will add bevacizumab. And at the end of it, if the patient is tolerating it well, definitely it will go to the Paolas with bevacizumab and olaparib. Otherwise, I will stop bevacizumab and continue only on olaparib. So HRD, I am still not, I don't know, I want to ask the panel actually whether if it's non-BRCA mutated but HRD positive, is the data as strong for olaparib?
Okay, so can I ask someone in the panel to take that, and I'll give my opinion. Amit, Mudassir, I can even see Bharat Vaswani and others there. Please feel free to put in. Piyush is there.
So I think I largely agree with this sequential first initially BRCA.
First, let's address Sujit's question that BRCA negative, HRD positive, is the data as strong and as pushing, i.e., in that group, are you more pushed to use bevacizumab maintenance than in pure BRCA mutation? Sujit, am I getting this question right?
Yes.
Yeah. We did not get that answer from the solo one because they did not actually do the HRD. So we have BRCA, support for that. But from Paula one, we know that the HRD, HRD impact is a separate and in addition to the BRCA impact. So I think that is clear that HRD definitely plays a role. We don't have a arm for that. I think probably I would extrapolate the results to that.
Suhas?
The same. Basically, from one of the subgroups from Paula one was that HRD positive patients were benefiting with the addition of bevacizumab to olaparib. So I like to continue with bev and olaparib in this subpopulation.
My personal view, Sujit, has been that it depends on how you do HRD. Please understand that HRD is almost a patented test, and we have done a combined cumulative error of saying if you've got a ATM and PALB2 positive and BRCA negative, you have HRD positive, which may be true in many patients, but not always the case. So to my mind, HRD in ovarian cancer is a strong prediction of PARP inhibition. I think I will not guess whether with time it will turn out to be as strong as BRCA or not. Generally, I am very tempted to give bevacizumab. I do know that it's a toxic drug, but somehow I'm very comfortable using that, and I use that in maintenance when I start because to my mind, I start very judiciously. So if I start, I continue it. I'm not very open to starting at every patient, but when I start, I like to use it as long as I can. And you're right, we have to stop a lot of times for proteinuria, for example, hypertension, not so often. So I think that's my take. I am clearly debating in my mind that if somebody is BRCA positive with a family history, can I just forego the BEV? But certainly for everybody else, I'm very keen on continuing. Any last words? Amit, your hand is up. Is that for a reason or is just up?
Oh, I raised my hand some time ago, but anyway, I think, Sujit, the answer to your question is that answer is available from niraparib trial. And in the niraparib trial, HRD positive, BRCA negative continue to benefit from niraparib. Now, can you extrapolate to olaparib alone? Most likely, yes. But then, can you say for the olaparib alone? Because the solo one trial did not deliver the regimen like this. So there's a degree of extrapolation. But with niraparib, it is very clear answer. BRCA negative, HRD positive continue to benefit with adjuvant niraparib. And for rucaparib, then is loss of heterozygosity data set, but largely for niraparib.
Sir, in the end, I have just two practical questions which come to us. That HRD, we know that the My Red, My Choice is very costly. Should we be taking decisions based on the HRD, which is done by some other labs? And can we extrapolate the rucaparib or give the rucaparib benefit to those patients who cannot afford olaparib?
Can I get Bharat Vaswani if he's listening to answer that? I love his comments on most occasions. Bharat, you just logged in or you listening? Okay, he's logged in, not listening. Amit, can I have your final word on it?
So it depends upon whether you consider Bangladesh olaparib as an acceptable option. Well, if you consider it acceptable, it is cheaper than rucaparib.
Okay.
So what about the rucaparib? So you consider that as also as a kind of Bangladeshi types?
No.
No. I'm saying if you accept Bangladeshi olaparib, then you don't have to replace rucaparib with
Yeah.
Now, whether you accept that or not, I mean, that's an individual decision. Medically,
Yes.
it can be a problem.
Right.
The second question is HRD. Your point is very well taken. I mean, we don't know whether they have a validation or not, but for many things, you don't have choices.
I think, Mudassir, it's a actually clinical fit question. You're saving cost on one side of some patients who can afford with very serious difficulties, maybe better off not doing it and actually waiting to see what happens next. And if the patient can afford, you have to really ask if, so especially when it comes to test, I find that whole question a bit funny at times, that the treatment costs a couple of lakh rupees a month, the test cost is 2.5 lakh rupees or 3 lakh rupees. I mean, there's a bit of debate there.
2.5 lakh rupees, yeah.
Yeah, but so I think I buy your point that the test is expensive, but the treatment is extremely expensive too.
Agreed.
I am very tempted to say rucaparib is as good as olaparib. I have no data to say that, but there's no logical reason why it should not be. But I guess time will tell that. I think we have overshot our time. Thank you again for my wonderful panel and some very interesting discussion at an hour which certainly Amit need to sleep, and most of us soon after that.
Thank you.
Okay,
Thank you,
bye.
Nitesh. Thank you.
Bye.
Thank you, Dr.
Thank you.
Nitesh. Thank you,
Thank you.
Dr. Nitesh. And this brings us to the close of the virtual session. And I invite
Dr.
all of you tomorrow at Sector 18 Radisson from 9 to 5 for a wonderful program that Dr. Rama Joshi, Dr. Nitesh, Dr. Ishita, Dr. Vinita have curated. Obviously, this will be transmitted live as well on this platform itself. But still, those who are in Delhi, we would love to meet you. We would love to have lunch with you. I hope it's as sunny as it was today. We have arranged some good food in the open, hoping that the sun is kind to us. So see you tomorrow. Thank you so much for joining in. Thank you, Dr. Nitesh, Dr. Mudassir, Dr. Shifali, Dr. Bharat, Dr. Suhas, Dr. Piyush, Dr. Amit has already gone. He slept.
Bye.
Bye.
He's very particular of time, I suppose.
Yes. Okay. Bye.
All
Thank
right.
you.
Bye. Thank you.
Bye-bye.
Yeah.
Bye-bye.
Thank you, sir. Thank you.
Bye. Thank you.